A1.
I'm on A1.
Nice.
Hey, hey. That's TV or something. That is TV. I'll turn that down or mute it. Because it's outputting from the switcher. You have that outputting. You have that split signal from the switcher.
It does look better now.
Yes. No broken cable. Check, 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 check. I'm hitting the down button and it's getting louder. Check, check, check. Check, 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 check. No, the remote is proper. Check, 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 check. Maybe the remote's upside down, he says. That's insane behavior to hold a remote. I always hold my remotes upside down. Check 1, 2. Good morning, everybody. We're here for HMP PCR. We're testing audio live here at MNYK Studios, where we have 3 rooms set up. Good.
I'd like to. Can somebody run back into? Can you run back into the other one and just tap on the rooms? Yep.
Yeah, I think Dr. Kemp is in makeup.
Check, 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 check.
Let's have a door stop for the other, that way if we're over here, we're not walking through all the time if somebody has to use the restroom. 'Cause I know that door is locked, right?
The other door, yeah, it should have like a little foot.
Oh, I didn't even look. You don't have
I assume I'm starting on the set.
Yes, you'll be at her. We'll probably flip flop at lunch. We'll go over and do that inside. And I got you an actual monitor today. Stare at the time.
I actually didn't bring the magic cards. Do we have one?
Okay. Well, you want it off this way? Yeah. Sure thing.
Lanny's back. 2 2, check 1 2 2 2 2 2 2 2 2 3 4.
go. Good. Awesome. So we have one clicker for the two of you. Who do you want to control the slides?
Yeah, I think so.
Either one of you can control the slides, but you just might have to communicate when you want to advance next on the slides. But you have these monitors over here. Whenever we're addressing the crowd, we have the prompter here, so when you sit down, you'll be able to see it straight ahead. There's a camera directly behind that. Otherwise, we're not looking at the cameras. Just, you've been a part of this a bunch of times. And then you can always use that as a reference, but try not to stare at the monitor across from you to read directly from it. Just kind of glance over as you can.
Mm-hmm.
But otherwise, you've done this before.
No, it's my first time.
Yeah.
I'm a little nervous. A little nervous.
You are pro. I remember when we were in North Jersey, you were probably the easiest we had.
Was it teleprompter work or was
it
it?
was teleprompter.
It was, yeah.
Oh, that's dead
You were
easy.
like one
First
take
take,
wonder.
yeah,
It
first
was
take,
no
that was it.
stumble.
Yep.
We were like, should we do it again? No. Okay.
It's so easy, he said.
No, teleprompter work is really easy for me. More spontaneous, off the cuff is a bit more challenging,
Gotcha.
and with another person, even more so.
Really, you find that it's more
Oh, yeah.
challenging with somebody else?
Because you have to, have the back and forth. That makes sense.
The engaging conversation.
So lucky for us, I've worked with Brooke before, but when I'm given a total stranger, it can go either way.
I find that surprising. Usually people are the opposite. They say, well, if there's a person here, it's easier to just back and forth conversation. But I can get that too. If you don't know the person,
No, and you have
having
to
that engaging conversation, it's kind of
no, and they have to be familiar with the technical material.
right.
Yeah.
And sometimes I'm partnered with someone who does not.
Right.
Get-
So then, what do you talk about? You're kind of lost in that.
Yeah, so no, what you just said was completely incorrect. So let me rephrase it for our learners in the audience. Don't listen
Yeah, right.
to my
Correcting that
partner
person
here.
the whole time.
Yeah.
That would be the bane of my existence if I was in that situation. I wouldn't be able to handle myself.
But cool. You're set.
Okay, great.
As soon as our guest is ready, we'll get going.
Look at yourself.
Well,
You're in
look,
two places at once.
my doppelganger. That's weird. That's weird. I was going to say 5 years ago I would have had a second breakfast sandwich.
Could always take one for the road.
No, I must resist all temptation. It was really quite good.
Yeah. Which
Yeah.
one did you have?
I had the bacon, yeah. It had, for some reason, the eggs were flavorful,
Yeah.
but not in a bad way.
Yeah. I enjoyed it as well.
Yeah. I mean, I can't tell you the last time I enjoyed such a sandwich, but maybe it's because I'm contrasting it with the make your own breakfast sandwich at the United Club. When they had these little bits of bacon, I don't know, they're not complete strips. They're like, I don't know where they're from. And then I put that on half a,
Pieces that
yeah, all the,
that they can't put.
yeah. I put that on half a bagel. I find 2 slices of American cheese to put on top of that. And then they only have cherry tomatoes. So I have to go and cut them up. And then they have the eggs. I put that up. But this is better.
It's better because somebody made it for you.
And it's a brioche bun.
That's always good. A little extra butter, never hurt anybody.
Yeah.
No, my mom's theory is always that if somebody makes it for you or if it's free, it tastes better. Like, if she doesn't have to pay for it, it tastes better.
That's true. But that doesn't apply to the United Club.
No.
So Duke, how long do you want me for? Like 2 minutes?
I'd say about 15.
15 minutes? Oh. Well, we'll have to probably wait till afterwards then.
Yeah, if it works before your car comes, if not.
Yeah. What, US? Well, now it's just called Psych Congress. Psych Congress Regionals, what they mean to me. Really?
Well, it's going to be.
It's got a few more questions.
Yeah.
Oh, a few more
In
questions.
that vein, but
Oh, okay.
yeah. I think you could probably knock it out in 8 minutes.
Yeah.
So Psych Congress has been very, very good to me. Remember Garrett Morris with the baseball player sketch on Saturday Night Live? Baseball's been very, very good to me. That's all he could say.
Yeah.
Have you seen the recent episodes? I've been seeing Eddie Murphy got brought back for.
Oh, I missed it. The 50th anniversary? Yeah, no, I should see it in the, recorded. I remember watching it when I was in high school. It was just starting, 1970s. 50 years ago.
Yeah.
I was 15. Now I'm 30. Hey. You travel light.
Oh, I never travel light with all my mess.
This is all your shoes.
Elbows, got a little bit of a cold.
Oh.
Got sick on the plane.
No. So that's why Rakesh did that. That's good.
Yeah. And the flight, oh my God. It's the worst flight I've ever had.
Worst flight?
On American, 4 hours delayed.
4 hours delayed. Well, they had to de-ice the plane.
No de-icing, even though it was 15 degrees in Dallas. Yeah, not that. The toilet was broken.
The toilet was broken?
Mm-hmm.
That could be
And they
bad.
didn't know that before they boarded us, so then they had to deplane us, go all across DFW to get to a new plane, and then announce, we don't have a pilot.
Because
Fantastic.
they didn't have
Well,
a
they
pilot
didn't
from that plane go to your plane.
I'm
The other-
like, couldn't he like teeter-tottered over here?
Yeah.
At least they didn't say, we don't have a pilot. Any volunteers?
That's right, push the pilot button.
Yeah, I did Flight Simulator once.
Yeah, I've done VR.
Yeah.
Yeah, it was so funny. I have to tell you, I loved Amy.
Oh,
She is, when we got back to the place, I told Rakesh, she's just beautiful, funny, bright.
Oh.
You scored on that one,
well,
Wes.
thank you.
You did. Well, you're not chopped liver. I mean, come on.
Well, that's very nice of you to say.
No, I mean, she was lovely. Yeah.
It's too bad that we had to assemble under such circumstances. I still can't wrap my head around what you experienced. I gotta tell you, I just can't imagine. It would put me over the edge. But I guess when confronted with such a event,
It's amazing what you do.
you rise to the occasion.
Yeah, you really do. I keep trying to, somebody told me once that, let's see what was it that the woman said. We don't always like life, but it's always trustable.
Always.
Trustable. Right? That whatever happens is supposed to happen. And even if we don't like it, it's okay.
So we have to accept the things we cannot change.
There you go. I mean,
If it were a Saturday night, we could go.
I remember when we got back to the hotel that night, I said, it's tragic and beautiful. Hey, Brooke, how are you?
Good.
Tragic and beautiful all in the same breath. I mean, it was all of it. But I'm with you. It just doesn't feel real.
Yeah. Well,
I mean, it just,
how,
in these meetings, Vlad didn't come last year because they did his thing remotely. But he, like you, a consistent part of regionals. But I think it's going to be site Congress when we show up and he's not there. He just had such a big presence, at the big meeting. We just kind of fit him, right? I always said Vlad was like a big man, a big brain, big personality, and a big heart.
Sorry if I shocked
To
you.
it all of it.
yeah.
Hey, snapping.
Sorry, yes.
No, don't be sorry. Don't be sorry.
Good. Come down.
When are you flying back?
Wanna spin for me?
I'll get the car, probably leave about 1:30. And you're flying back too, right?
Yeah, I'm leaving at 9:30. Yeah, weekends are really, really tough for me right now, being away on weekends. It's a careful negotiation.
Right to your waist.
Craig was talking about missing kids,
Yeah,
sports activities, and
yeah. So, but I had promised Amy I wouldn't be away on weekends.
okay, good for you.
We did that 2 years ago. She,
Great, that's
was
awesome.
telling the story, she had threatened to go to Florida for 3 months in the winter.
And I think we
Whether
decided
I was going or
one
not.
clicker, but Les
Okay.
said he feels comfortable clicking.
Yeah.
Okay.
So,
Yeah,
I can't
as you're
imagine
seated
her
here,
saying that.
there's a camera behind that glass, so that teleprompter, if you're ever
and I was
standing
just,
outwards,
Uh-huh.
you're looking
Look
here.
at that one. Okay.
so my agreement was I
this
wouldn't
way, but then there's
readily
gonna be
agree to
conversation
weekend
during
things.
this one, that's why there's the two
But
of you.
this was unavoidable. How many minutes is this?
45.
Oh, good.
And all set, so
Okay.
if you want to head up, we'll get started.
All right.
All right.
I'm
Knock it out of
a
the
little,
park.
I'm a little nervous.
We're going to close the
nervous.
magic door.
Yeah, I don't know. This material's
Got
new to
it?
me.
But if you're
Just
looking
be
there,
careful
camera
stepping
behind
through
there,
that
so
door.
it'll be a
Yes.
proper.
Okay.
Cool.
As soon as Les comes in, we'll get started.
All right.
Push on it. Oh, it might be locked.
Give it a good get.
I was scratching at the door.
It's just a hard push.
Thank you.
Up there, Les.
Whoa. They told me to watch out for the threshold. And what did I do?
You watched it. You watched it trip you.
So I'm a bit of a
You're the
control
clicker.
freak, yeah.
That's okay. I'll follow your lead.
All right, let's roll cameras.
Audio speeding.
Sorry. You're good. I just wanted to make sure that we're over.
A10 is speeding.
All cameras speeding. Audio speeding. A10 speeding.
Do these have a second SO return of it?
Gonna check me.
Forward. A little more. Good. There. Right. We'll have a timer down here. It's gonna count up, so you just know how long you've actually been recording.
Okay.
Can it count backwards?
If you want me to, what are we doing?
45.
45 minutes.
I'm not sure how that one.
I don't think that this one does do a countdown,
All right.
unfortunately.
Okay, it's not the end of the world. Well, it's close to it, but,
It'll, you know,
but not exactly.
I have to do math in my head
this
then
one's a
to
little
figure out.
limited, unfortunately. You're off to Dan. Give us one moment. Can we actually remove the coasters from the table? Okay. Are you set?
Yep.
Set? All right, I'm gonna do a 3, 2, and then I'll point. I'll start the timer and you guys can go, okay? Ready, 3, 2.
Hello and welcome to Moving Mountains with Molecules in Tardive Dyskinesia, Optimizing Strategies for Challenging Cases. I'm Dr. Leslie Citrome, Clinical Professor of Psychiatry and Behavioral Sciences at New York Medical College in Valhalla, New York.
And I'm Brooke Kemp. I'm a psychiatric mental health nurse practitioner out of Terre Haute, Indiana, and I currently serve as an adjunct faculty member for Indiana University of Indianapolis in Indianapolis, Indiana.
Here are our disclosures and further disclosures regarding the content of this presentation.
So today we're going to have a couple objectives that we would like to ensure that you learn during today's presentation. So we want you to be able to apply strategies to improve tardive dyskinesia screening, assessment, and monitoring, including the use of validated rating scales and telemedicine visits. We also want you to be able to identify the diagnostic criteria for TD and the potential clinical features of the disorder that differentiate it from other conditions with similar presentations. And then lastly, we'll hope that you'll be able to evaluate the latest clinical data associated with VMAT2 inhibitors and the pharmacological differences between them and inform treatment selection and adjustments for patients with TD. So let's get started and talk about symptoms and the course of tardive dyskinesia. So beginning with the fundamentals and the basics, if we look up the components that make up the word tardive dyskinesia, we see that the definition is within these words: late, meaning tardive, and dyskinesia, meaning abnormal movements. So this is not a side effect that is going to occur immediately after taking medication. This is a late or delayed abnormal involuntary movement that occurs after a patient begins a dopamine receptor blocking agent. So this can occur within several months of taking the medication, and unfortunately, it can persist indefinitely even after the medication is stopped. And sometimes the side effect doesn't even occur until withdrawal of a medication. So it could be persistent, and it might vary in level of severity across the spectrum of different individuals.
In terms of how common it can be expected, 1 out of 3 people on first-generation antipsychotics have tardive dyskinesia, and about 1 out of 5 on second-generation antipsychotics have tardive dyskinesia. When we take a look at those who've only been exposed to second-generation antipsychotics, it's more like 1 out of 14. So it's less common, but not rare. What are the risk factors for developing tardive dyskinesia? Well, not everyone gets it, of course. You have to have some kind of predisposition to developing tardive dyskinesia. And if you have that predisposition, there are several risk factors that are very important. How old you are and cumulative exposure to dopamine receptor blocking agents are the most important risk factors. Some additional risk factors include a mood disorder, perhaps a history of having extrapyramidal side effects. I don't really like that term, but we use that all the time. So drug-induced Parkinsonism or akathisia or dystonia, if the person has experienced that, that's also a risk factor.
And we do know that antipsychotic medications are used more frequently now. So they're not saved just for psychiatric disorders. We use them across the spectrum of different mental health diagnoses, mood disorders, not only across different diagnoses, but age populations. We're also starting these medications much sooner, so even in the child and adolescent population. So we know that patients are going to experience more cumulative exposure to these medications, so it's not a diagnosis that's going away.
And not to even consider perhaps even more risk in off-label indications.
Exactly.
So most cases of TD remain undiagnosed and untreated, and this leads to misdiagnosis, right?
Yes, we can complicate this by looking across the spectrum of different movement disorders, and we have to be sure that we're identifying and diagnosing correctly because there's different treatment options available also.
It's been the case that everything that moves is called drug-induced Parkinsonism, and that's really not the case. And we can distinguish the two by what it looks like, when it occurs, and what happens when an antipsychotic dose is increased or decreased. Basically, the movements themselves are different. Someone with tardive dyskinesia is going to have dyskinetic movements. That's erratic movements, jerky movements, whereas someone with drug-induced Parkinsonism has a rhythmic, small amplitude tremor, 3 to 6 cycles per second, quite distinctive in this manner than the movements we call piano playing movements of the fingers. And when it occurs is actually quite different too. We would expect drug-induced Parkinsonism to emerge pretty quickly, within days or weeks, and in some cases it will take even longer than that, but generally it's quick. Whereas tardive dyskinesia, by definition, is delayed, sometimes by years. What's interesting is the effect of different doses of antipsychotics. When you increase the dose of the antipsychotic, the drug-induced Parkinsonism would become worse. That makes sense. You're blocking more dopamine receptors, and the Parkinsonism is worse. However, you can also mask dyskinetic movements, and the TD can look better. The reverse, when we decrease the dose of the antipsychotic medication, the DIP will look better. However, the TD can look worse. Ultimately, it's how it looks and the onset that will give us the diagnosis of tardive dyskinesia versus DIP, but the exposure to the antipsychotic can give us additional clues. Ultimately, the treatment is quite different. We know that VMAT2 inhibitors are FDA approved for TD. They can actually make DIP worse. And we know that the usual treatments we use for DIP, basically anticholinergics, can make TD worse.
So let's review some of the key learning points about what we just discussed. TD is not rare. And if you're using antipsychotic medications in your practice, it's likely that it does exist in your practice. Second generations are used for many indications, so we can expect, unfortunately, to see more TD. TD can be persistent even after the antipsychotic is discontinued, and it can present with delayed onset, and the use of anticholinergics can worsen tardive dyskinesia. So let's move on and start to discuss about how we can assess for tardive dyskinesia and discuss the recommended tools and strategies that you might use in your day-to-day practice. Let's start off, if you could explain the DSM-5 criteria. I know that you know a lot about this, so can you tell our audience how we diagnose?
The DSM-5 text revision criteria for TD has greatly expanded what TD is in terms of informing us about the potential causes and the course and treatments. This is different from the DSM-5 in its original version and is much longer. I urge you to take a look in the main book of the DSM-5 TR, not the pocket guide, but the main book that describes DSM-5 TR for more details. But it essentially describes the key features, the kinds of movements we can expect, and when they occur. And importantly, it talks about specific lengths of time of exposure to the antipsychotic that would be necessary in order to make the diagnosis. And generally, a 3-month period of exposure is what's necessary. However, the period is shortened to 1 month in someone who is older. The DSM-5-TR also goes into more detail about withdrawal dyskinesia. That's when we lower the dose of the antipsychotic or stop it altogether that we see for the first time dyskinetic movements. We'll call that withdrawal dyskinesia unless it's persistent. And if it's persistent, well, unfortunately, it's tardive dyskinesia. So take a look at this definition. You'll also note that it includes some mention about other DRBAs, such as metoclopramide for gastrointestinal disorders. Metoclopramide is a dopamine receptor blocking agent. And here's a fun fact. I like fun facts. There is a box-bolded warning for the metoclopramide product label that says don't use for more than 12 weeks because of the risk of tardive dyskinesia. Now, we don't have that box-bolded warning in antipsychotic drug labels, and it wouldn't make any sense because we use antipsychotics for prolonged periods of time, but it is in the ISI, important safety information, as a regular warning and precaution for all antipsychotics.
It's probably also important for us to know as providers what other medications that our patients may be on, more than just antipsychotics, unfortunately causing this diagnosis. So once our patient has received a diagnosis, when do we decide to treat? Well, we can follow the APA guidelines that emphasize the recommended treatment for tardive dyskinesia are VMAT2 inhibitors. Now, when it comes to the disability and this diagnosis causing disability in our patients, that's all in the eye of the beholder. So even though we look at this criteria here and we see the recommendations to treat moderate to severe tardive dyskinesia with VMAT2 inhibitors, we want to keep in mind that this should also be considered for mild TD. So even the slightest movements could be very disabling for individuals, particularly when it comes to these other diagnoses where we have very highly functioning, working individuals where these movements may be interfering with their ability to work and perform their day-to-day functions. And then also the physical impact that it could have could be causing a disability across the spectrum despite that level of severity. So we have two deutetrabenazine or valbenazine preferred over tetrabenazine because we have greater evidence when it comes to those treatment options. The one thing we want to emphasize, anticholinergics are not an approved option, and as we mentioned before, may even actually make tardive dyskinesia worse.
You know, I want to go back to the idea that mild TD ought to be treated. So I'm going to ask our listeners and our viewers, imagine if you were moving your lips like this, and you did it once every 15 minutes, a casual observer will see it. Your patients will see it. And yet it would be considered mild, and we've seen a lot worse, of course, in our clinical experience. But is it really mild to you? Probably not. And you would probably want to treat it. And this reminds me of a phone call I received actually not that long ago of someone who saw two clinicians, wanted treatment for his TD, and was told, no, he has mild TD. But it wasn't mild for him, and he was kind of desperate to get help.
So how do we assess for tardive dyskinesia? We want to utilize measurement-based care. Here you'll see the AIMS assessment, the abnormal involuntary movement scale that you can use in day-to-day clinical practice. I want to emphasize that this is a screening tool that is done by the clinician that you can use to assess for TD, but you can also use it to monitor progress. You can monitor for progression of the illness itself or to monitor progress or improvement when it comes to treatment. So the way that this scale is set up, you'll notice that the first 7 items are what we use to actually measure the movement. Each one of these items is individualized by specific body parts. And as a clinician, we look individually at each one of those body parts and we give those a level of severity. 0 meaning no movement at all, and then 4 being the most severe movement. Now, this may differ depending on your background and what experience you might have when it comes to looking at TD. So there's a couple other factors that you want to put in place here. Sometimes they even start at the bottom of the scale. If you look at numbers 11 and 12, it asks about patients, do they have dentures? Are they poorly fitting dentures? Are they having problems with their teeth? I also want to ask, are they chewing gum? Do they have anything in their mouth? Anything that might be making their mouth or tongue move that might distract me, and I might assume that that's actual involuntary movement, or it's actually something not related to tardive dyskinesia. So we want to get that out of the way initially as we are measuring these assessments. But then when it comes to number 8, your answer to number 8 is whatever your highest number is, 1 through 7. That is your overall severity of abnormal movements. And then you also have in there numbers 9 and 10 that you have a conversation with the patient. How much is this movement impacting their day-to-day functioning, and how aware are they? Sometimes individuals with a very slight movement might be hyper aware of it, whereas others, you're assuming the movement is very distracting to them and not as observable. So this has to be a conversation that you have with your patient. These scores are also important when it does come to treatment, because often a payer will ask for a total AIMS score. So going back to those first 7 items, that is your actual movement score. So your AIMS score when regards to movement is going to be anywhere between 0 and 28.
But you know, a score of 5 is kind of ambiguous, because a score of 5 could mean not much or could mean a terrible case of TD. Let me explain this. You can get a score of 5 by a bunch of 1s. You can also get a score of 5 by a 2 and a 3. That's why I like item 8 of the AIMS quite a bit, because it helps me define actually the severity, what it means as a clinician, how bad the TD is. Now, a patient may have their own opinion on how bad it is, and that's actually going to drive my decision making. In terms of the individual scores, let me go over this again. 0 means absolutely nothing. There's no movement there. 1 is you're not quite sure. I use that as a placeholder to make sure that I take another look next time I see the patient. 2, everyone can see it if they're trained, right? 2 could be subtle, but you see it.
Something
3,
there.
you don't have to be trained to see it. Everyone sees it. And 4, you see it from across the parking lot.
Exactly. I think people get confused about a 1, like, well, what is minimal? I always say, well, I can't call it 0, because there's definitely something there. So it's not a 0, but it's not significant enough for me yet to call it a 2. So when it comes to identifying opportunities to observe patients, it doesn't just have to be in a one-on-one setting. We can use some semi-structured options also. We know when it comes to doing an AIMS assessment, we're a little bit concerned about the time that it might take to do a complete assessment. The key is every time that you are face-to-face with a patient or seeing them over telemedicine, we need to be observing for movement. So we want to be sure that we are observing patients at each visit, and then if we notice red flags, we're going to do a full AIMS assessment. But in between there, we can have these semi-structured exams, and then we can also ask that a patient or caregiver be monitoring for these movements even in between appointments. We also want to watch the patient not just one-on-one, but from the moment that we pick them up in the exam room, walking them back. A lot of our AIMS assessment can actually be done before the formal exam is even starting.
You know, when we accompany the patient to the consultation room or the examination room, we have an opportunity to look at their gait. So if it's kind of a shuffling gait or they're not moving the arms, that tells me that maybe they're Parkinsonian to some degree. Mm-hmm. If they start moving their fingers in a piano-playing manner when they're walking, and they don't have that when they're just standing there, we've actually done an activating maneuver to bring that on. So very helpful to just look at the patient when they're walking. The other thing, though, I want to caution our viewers, is that if we're so obsessed about our keyboards and the electronic health record, we may miss something.
Exactly.
So-
You have to have eyes on the patient to see this. And you brought up a great point regarding the activation maneuvers. I know when I was initially trained on Ames assessments, this wasn't brought up, and I wasn't trained as well as I've learned now. You do have to do some activation maneuvers in those steps of the Ames exam to sometimes bring out masked movements.
You know, the activation maneuver is not an artificial way to bring out the movements. TD is the kind of movement that emerges when you're trying to do something on purpose. So when you're moving voluntarily a muscle, that starts the signaling in the motor circuits, and then dyskinetic movements emerge and they cannot be controlled. So this happens when people are walking, talking, eating, going about their business. And doing these activation maneuvers helps us assess these movements when they're just sitting in the office. We need to bring them on so we can identify them. Well, how do we do the screening and how often should we do it? Guidelines tell us to do it actually quite frequently. In terms of people on second-generation antipsychotics, doing an evaluation on an annual basis is what's recommended. With second-generation antipsychotics with additional risk factors, such as older age or a history of movement disorders of any kind, you do it twice as often, every 6 months. Now, what about people still on first-generation antipsychotics? Well, it's every 6 months, unless they have additional risk factors, then it's every 3 months. When I used to work through the New York State Office of Mental Health at a state hospital, we were mandated to do the Ames at regular intervals and put it in the chart. And many public agencies have adopted the Ames to do this. But if you don't do the Ames, at least look and at least assess and be mindful of looking for tardive dyskinesia, especially if there are risk factors. So again, older age, biggest risk factor. Cumulative exposure increases the risk. People with a history of substance use disorder, mood disorder, intellectual disability, and you know, I didn't mention this before, exposure to benztropine, an anticholinergic, increases the risk of developing TD, not only making existing TD worse, but developing TD. And unfortunately, we don't do this. Only 11% of patients on antipsychotics receive screening on a regular basis.
And you mentioned before that you are mandated to do it every so often. I know as working within a group home structure, we were also required to do quarterly Ames exams, despite whatever their risk factors are. So it was nice to have those set up, but it is up to us, the clinician, to ensure how we're going to keep track of doing that. I know some facilities might have this built into their electronic medical record to be able to give them reminders. But I think the key point is to always be observing and to somehow document that within your documentation at each visit, that you've at least acknowledged this or asked the patient about movement within each visit.
Well, what about telepsychiatry? So I have to confess, I'm not a big fan because I prefer the three-dimensional aspect of interactions with people. I could spot dyskinetic movements more easily than a two-dimensional screen. But it's better than nothing, right? So if a person does not have any other access to health care, well, it is an option. And we can do some kind of Ames exam through telepsychiatry. It's just a little more difficult depending on the technology available. So there's a few solutions here. Having someone help the patient, perhaps with the placement of the camera or the phone and being able to pan throughout the entire body, going through the activation maneuvers and walking and so on. Also, asynchronous recording can be very helpful. That's when you instruct the family or caregiver to record the patient when the movements seem to be more prominent. Because sometimes when they're there and you're talking to the patient through telepsychiatry, you don't see much of anything, but there are other times where the movements are more prominent. And unfortunately, we don't have guidance or any form of instructions on how to really do this perfectly well.
I think it has been challenging because our patients, when they're doing telepsychiatry, it's often not from a large video monitor. They're often using their phones. But as you mentioned, something is better than nothing. And if you look at those first 4 items on the Ames exam, it has to do with oral facial movement. So the majority of the time, even with a phone, you can at least get a good idea of those first 4 movements. But I like to let my patients know that we're going to be doing this. So if you could we please set this up and you plan so that you have the ability to do these types of assessments. So again, as we mentioned, in order to assess the lower body, you're going to need the patient to step back away from that camera, even if it's setting their phone up on a table and them stepping back. But again, very helpful if you can have someone else, a family member, if you've let them know, hey, we're going to be doing this exam, could you have somebody help you out holding the camera back so that I can see you head to toe. The nice thing about it, as I mentioned, we're looking a lot at the face, and you can be looking at that very closely on the screen without making the patient feel uncomfortable. And one thing in the office that we don't often do that we really need to, we have to look at the feet. We need to see the toes. Sometimes that can be uncomfortable in a very close setting, but when we're talking about telemedicine, maybe not as uncomfortable for the individual.
No, we know a bit more about the feet. It is very unusual for TD to present with only toe movements. So that doesn't happen. But in someone with TD, they may be moving their toes. It may be a big problem. And when they remove their shoes and socks and you examine the dyskinetic movements that may be there in the feet, you may notice some abrasions on the toes because the toes rub against their shoes. That's important to note because we need to address that. And we won't know that their toes are abraded unless we look. Is TD more than a movement disorder?
Yes. It can impact a patient mentally, physically, socially, across the spectrum of everything that we're trying to treat, also in mental health.
So the point here is that it's not just cosmetic. The person with tardive dyskinesia is going to have some impairments in a variety of life functions that we take for granted. The social impairment is quite prominent in people who are aware that people are staring at them. They don't quite know why, but they're told that they're moving their mouth in a certain way, and they don't notice that they're doing this. They're just told they're doing this to such an extent that they become very self-conscious. I've had patients tell me they shop at the supermarket at 10 o'clock at night so their neighbors don't see them. They shy away from family and social gatherings. And if someone who is working, they become a little more difficult in terms it's difficult for them to interact with their coworkers. So it becomes quite difficult for someone with TD socially and occupationally. What about physical impairments? Well, someone may have trouble eating without spilling, or talking, or chewing, or even walking. So we can have some physical impairments. And there's some psychological impacts too, in terms of increasing levels of anxiety and perhaps depression. So that's very real. Patients with TD express negative sentiments, don't they?
They sure do. And if you look at the study that is represented here on your screen, this is actually looking at what patients post on social media. So patients are expressing their concern and frustrations when it comes to tardive dyskinesia. They're not happy about getting a side effect from a medication that they were taking that they were hoping to be beneficial. They also discuss those insecurities when it comes to the awkwardness they feel or the insecurity that they feel out in public, now no longer wanting to go out because they do feel judged. So when we talk about mental health in general, we're always working towards fighting the stigma of mental health. And often we're working with patients that were carrying this disorder on the inside, something that they were trying to keep confidential. We now have an outward expression based off of a medication they were taking. And for some individuals, their confidentiality is now out the window because people are asking, why are you moving like that? Even family members that were unaware that they were dealing with some of these mental health issues, now they're having to share that, well, I have to take medicine for X, Y, or Z. So we're opening up a whole new door for them. So we need to be able to talk with our patients about this. If you look at this 2020 study, patients are aware. It doesn't matter if they have a mood disorder, a psychotic disorder, they are aware of these movements. And 3 out of 4 patients, they feel very self-conscious or embarrassed about this. So asking the patient how this is impacting them on a day-to-day basis in each and every area of their life is very important.
So the thing about being aware of movements is different from knowing when you have the movement. So there are many people with tardive dyskinesia who aren't aware that they're moving their lips in a strange way until someone points it out to them. Then they're aware. I've had patients with schizophrenia tell me, I don't have any movements. What are you talking about? And then I ask them, do people comment on how you're grimacing? And they say, yes, they do, and it really bothers me. They weren't aware that they were moving, but they're aware that something's up with their tardive dyskinesia, and it distresses them. The quality of life impairments due to TD, as mentioned before, extend to their social and occupational functioning and overall quality of life. This is a real issue. We cannot ignore it. Study after study demonstrates impairments that are greater in people with tardive dyskinesia than without, even though they have the same mental disorder. Those with TD are worse off. How do we assess this?
It's not that we want to add another scale to have to do in day-to-day practice where we already feel a little bit stretched when it comes to time, but there is an example here of the Impact TD scale. This is not a validated tool, but it does give us something that we can utilize to basically assess each one of those areas that Dr. Citrone was mentioning earlier, looking at the physiological, sociological, and other areas of functional impact over day-to-day life. As we mentioned earlier in this session, disability is in the eye of the beholder. And it doesn't matter the level of severity when it comes to an AIMS score. What is really important is more representative of this type of scale. When it comes to the impact of the social functioning, the day-to-day functioning, this is what is impacting patients' day-to-day life. So this type of scale opens up the conversation that you and the patient can have in regards to each one of those areas. And just to give you an idea of the scale, basically this isn't something that you add up. You're just looking at the overall global level of severity when it comes to each one of these areas.
So I was fortunate to be a participant in the development of this scale, and I was a big advocate that it not be promoted as another thing for us to do, as you mentioned, but it serves as a good reminder of what questions to ask. So I urge our viewers to take a look at the scale in more detail, because it'll help you develop the questions you need to employ routinely when evaluating patients with who may have tardive dyskinesia. Because it's one thing to identify the movements and assess their severity in terms of the movement themselves. We need to have some idea of how they impact that individual. There's some other scales that we can consider. There's the Tardive Dyskinesia Impact Scale, which is similar. It is a validated scale, and it helps us assess similar aspects about the impact of TD on that individual person. But again, the AIMS, I think, is our gold standard for assessing TD, and that's what actually a pharmacy benefits manager would want to see in many cases before endorsing the use of a VMAT2 inhibitor for that individual person. But what's driving the need for treatment is going to be impact on their patient's functioning.
So let's review some of the key learning points. Even though that we know tardive dyskinesia scales are available, only 11% of patients are actually receiving their routine screenings, so we need to do better. TD can be assessed with an AIMS scale by just observing in just a non-structured setting also. We want to involve others whenever we have the opportunity so that we can get even a more thorough exam. So if you're particularly doing the telehealth visits, having someone else available to kind of run the camera. And we need to be asking about the impact of these movements on the patient's quality of life.
This is actually the heavy lifting. The treatment itself is pretty straightforward. They work, they're well tolerated. It's just a matter of identifying the TD, making sure you have an accurate differential diagnosis, and then implementing the treatment. The treatment that's available today, as approved by the FDA, are VMAT2 inhibitors. But before we get started on that, I want to talk a bit more about anticholinergic medications. They're often used in our patients on antipsychotics. They're often used prophylactically with the idea that it's going to prevent movement disorders in the future. However, second-generation antipsychotics don't do that, and it's unnecessary to use prophylactic anticholinergics in people who are receiving second-generation antipsychotics. And we've already talked about how anticholinergic medication exposure can increase the risk of developing TD or make existing TD worse.
We definitely need to move away from everything that moves, throwing an anticholinergic at it.
Absolutely. And in older people, they're prone to anticholinergic side effects. So urinary retention, for example, constipation, and perhaps delirium. If we are to prescribe an anticholinergic, let's say for an acute dystonic reaction, we're going to use it on a temporary basis. And the treatment of acute dystonic reactions long-term is to avoid the offending agent and to move to an antipsychotic that is not associated with that kind of side effect. Ultimately, if someone continues to have drug-induced Parkinsonism and you've tried everything and to no avail, we have an alternative of amantadine that is not an anticholinergic agent, but is efficacious in drug-induced Parkinsonism and won't make TD worse. In fact, it could help TD a little bit, but the effect size of amantadine for TD is not as good as the effect size for the treatment of TD that VMAT2 inhibitors carry.
Which brings us to, what are VMAT2 inhibitors? So VMAT2 is a protein concentrated in the human brain. It's primarily responsible for repackaging and transporting monoamines, so all monoamines, dopamine, norepinephrine, serotonin, histamine, in the presynaptic neuron. And by inhibiting VMAT2, we're going to be able to decrease these monoamines. So because tardive dyskinesia is a hyperdopaminergic condition, reducing the dopamine output in the dorsal striatum will reduce those dyskinetic movements.
So it's not a dopamine depleter per se, although that term is used, because there's still enough signaling so that people can still are able to move, of course. So the VMAT2 inhibitors that we have today approved for the treatment of TD are reversible. And it's not 100% stopping the VMAT2 from working. So that's important to note. In terms of what's approved by the FDA, well, there are two choices here, valbenazine and duotetrabenazine. Both can be given once a day now. And in terms of dosing, they do differ. In terms of dosing of valbenazine, you start at 40 milligrams once a day, and you can go up all the way up to 80 milligrams a day, and you can do that as early as day 8. With duotetrabenazine, you start low and you go slow, and although you can perhaps in some patients see a therapeutic effect at 24 milligrams a day, the clinical research that has been conducted generally points in the direction of using 36 milligrams a day and up. In terms of drug-drug interactions, they differ a little bit. Both are metabolized by CYP2D6, and valbenazine is also influenced by CYP3A4. In terms of the active metabolites, they also differ somewhat. The metabolites are VMAT2 inhibitors, so both agents work. But the actual metabolite that does most of the VMAT2 inhibition does differ a little bit, and that has some importance in that it encourages us to use the other one if the other one doesn't work, basically. In terms of the titration, that's really important. I'm going to emphasize that again, because if you don't see any benefit from a lower dose, you need to go to the higher dose. But even if you see benefit at the lower dose and there's still some residual dyskinetic movements, you should strongly consider going up in order to get the full benefit of that VMAT2 inhibitor. In terms of discontinuation of antipsychotics, is that necessary?
No, the good news is you can utilize both of these medications without having to change your antipsychotic treatment. And in the clinical trials, patients were able to remain stable on their antipsychotic medication without increasing psychotic symptoms. And when it comes to worsening of symptoms such as suicidality, those were not seen within the clinical trials regarding tardive dyskinesia, but both of them do have warnings about drug-induced Parkinson.
Yes, so there are some patients who may be quite sensitive to a decrease in dopamine signaling, and it may present itself in terms of drug-induced Parkinsonism on a VMAT2 inhibitor. Another example of this occurring is, let's say you have someone who's never had drug-induced Parkinsonism, never did, but develops tardive dyskinesia. And as they get older, they seem to become a little more stiff, and they're on a VMAT2 inhibitor, and they look like they have Parkinsonism. What may have happened is that Parkinson's disease was uncovered. And that's an occasion to refer to a neurologist who can do a DAT scan and confirm that diagnosis. This generally is in older people, and it's more obvious in someone who has never had drug-induced Parkinsonism, so something's up with them. In terms of the VMAT2 clinical trials, both valbenazine and deutetrabenazine have been extensively studied and have demonstrated superiority over placebo in the reduction of the total dyskinesia score. That's the sum of the first 7 items on the AIMS. So the AIMS is a clinical scale used in clinical practice. It's also a research scale used in clinical research. It's one of the few scales that is used in both settings. Now here's another fun fact. We've heard of tetrabenazine. It is the first VMAT2 inhibitor that was created, approved in this country as an orphan drug for Huntington's chorea. It can be used for tardive dyskinesia, but the level of evidence supporting that is minuscule compared to deutetrabenazine and valbenazine. And there are no similar studies for tetrabenazine that match up with what we know about the approved drugs. So if you're told, oh, try tetrabenazine first, the evidence to support it is not at the same level. We can take a look at the approved drugs for tardive dyskinesia and ask ourselves, what is the effect size? My favorite effect size is number needed to treat. How many patients needed to be randomized to the drug versus placebo before seeing the outcome that you desire? Let's say the outcome of interest here is a 50% reduction in the AIMS total score. Both options result in NNT across the doses that would be generally thought of as efficacious. Both drugs have an NNT of 5, which means for every 5 patients randomized to the drug versus placebo, you would expect 1 additional person who has a 50% reduction in their total dyskinesia score. Now, if you look at the individual doses, there is dose response. I want to point out the dose response for valbenazine. 80 milligrams a day is better than 40 milligrams a day, but there are some patients who have complete elimination of their dyskinesias at 40. So I wouldn't go up to 80 for them, but a scenario that is quite common in about 2/3 of patients on valbenazine is that they still have some residual dyskinetic movements. I would go up to 80. And if you don't want to do that or the patient doesn't tolerate 80, you can go to 60. In terms of deutetrabenazine, yes, 24 milligrams a day has worked in some patients, but generally doses of 36 milligrams and above would be necessary. Now there's another metric called number needed to harm. How many patients needed to be randomized to drug versus placebo before you expect 1 additional patient stopping because of an adverse event? That happens to be about 100 for both drugs that are approved by the FDA for the treatment of TD. We can divide 100 by 5 and come up with the likelihood to be helped or harmed. That turns out to be 20. You're 20 times more likely to encounter robust response, that is 50% or greater decrease in dyskinetic movements, than having to discontinue because of an adverse effect. And you'll know this in a few weeks. That's the benefit-risk decision that's in front of us today. What about the tolerability?
So when we look at these overall results from the clinical trials, looking at deutetrabenazine, safety and efficacy, looking at safety and efficacy, we saw the efficacy results. When you look at the side effect profile, you can see that this is a well-tolerated medication. With deutetrabenazine, the most common side effects being nasopharyngitis and insomnia. When it comes to those and the dropout rates, very low dropout rates when it comes to deutetrabenazine. And when you look further into the clinical trials, this is a 3-year, 145 weeks, looking post hoc at the results of the study and separating them by age. Individuals under the age of 55 and those over the age of 55. You'll see in both groups that this was well tolerated and, again, low dropout rates. So efficacious and tolerable no matter what the age was.
So over the long haul, it still works. Similarly, with valbenazine, the side effect profile demonstrated here shows one side effect that is at least 5% and greater than twice that placebo. That is an outlier here, somnolence at the top there, but discontinuation rates due to adverse events, very low. And as we talked about, the number needed to harm there of 100 means that it took 100 people to be randomized to valbenazine versus placebo before expecting one additional patient stopping because of an adverse event, despite adverse events potentially occurring. So somnolence is the one at the top of this list. The others very close together in terms of the rate seen with valbenazine and placebo. So it may be greater than placebo, but the difference is very small there. In terms of the long-term tolerability and safety, it looks good. In terms of the durability, it looks good. And in terms of efficaciousness and tolerability in older people, it still looks good. So both deutetrabenazine and valbenazine are good choices and in general would be tolerable.
We have to take this into consideration in day-to-day practice. So what would some of the concerns be when it comes to prescribing these medications? As we saw, effective and tolerable medications, but when we try to offer these to patients, they may be a little reluctant. We're already trying to treat a side effect because of a previous medication. So adding on another medication, they're not always happy to hear about. And then of course we have the pushback sometimes from managed care, and sometimes we have to work out through some of the side effects during the titration phases.
In terms of convincing a patient that it might be helpful to receive a VMAT2 inhibitor, we'll employ motivational interviewing,
Absolutely.
help patients identify some obstacles to what they want to achieve in life, and that will help them reach the decision, okay, it sounds like treating this movement disorder might be helpful to me. They won't say movement disorder, of course, they'll say moving my mouth like that. I don't really notice it, but you're right, you know, I think I'm reacting to how people notice it. In terms of the managed care hurdles, if you are told to try benztropine first, I would really push back. I wouldn't do it because benztropine can make TD worse. And if you're asked to try tetrabenazine first because it's nominally perhaps less expensive, you can object to that because the evidence base for tetrabenazine is not as strong as for valbenazine and deutetrabenazine. And we know that tetrabenazine itself is not very well tolerated. For both agents, we can work through any potential side effects, and ultimately, if something doesn't work or not tolerated, we can try the other one.
So for review, there are 2 VMAT2 inhibitors that are approved by the FDA to treat TD, valbenazine and deutetrabenazine. These are 2 different medications, both effective, both have different titration schedules, and the good news is they don't require change of antipsychotic therapies.
Well, in the remaining period of time we have, we'll briefly discuss a challenging case. And this case involves thinking through drug-induced Parkinsonism. So let's review some of the details about DIP. It occurs relatively quickly in people exposed to dopamine receptor blocking agents or increasing the dose. The tremor is generally rhythmic, 3 to 6 cycles per second, and of low amplitude. It may also be associated with slowness, bradykinesia, in general rigidity, and can coexist with tardive dyskinesia. Now, DIP typically resolves when you withdraw the the dopamine receptor blocking agent. It may take some time, but it does go away compared to TD, which doesn't. In someone with DIP, this can be a real diagnostic dilemma. So let's meet Joe. He's a 55-year-old man living at an adult residence, followed by the local ACT team, and he has schizophrenia. He's been receiving haloperidol decanoate and benztropine. A new clinician on the team assesses Joe, sees shuffling gait, and is concerned about it, increases the dose of benztropine to 2 milligrams BID. The gait is better, but fingers are moving in a strange way, and it moves, so more benztropine was administered, 3 BID, and the finger movements worsened. He started grimacing, which was noticed on a telemed check-in. What would be your next step?
It brings us to some good points. So I think about a couple different things. I think originally he's on a first-generation antipsychotic, but it's a long-acting injectable. I want my patient to be on a long-acting injectable, but I do want to find out, has he tried a second-generation antipsychotic? Can we change that? But I think the one thing that sticks out in this case is a clinician possibly confusing drug-induced Parkinson's and tardive dyskinesia. As we saw, they continued to increase that anticholinergic medication, and we actually start to see a different type of movement, even getting worse. So I think the clinician has to step back and say, wait, could this not be drug-induced Parkinson's? Could this be TD instead?
So if we go back to the original table, we haven't really had enough information about the onset historically about these movements with Joe. We just don't know. But we do know that the movements look different. So the tremor, 3 to 6 cycles per second, is different from moving of the fingers. And we now know what happens when you alter the anticholinergic dose. You increase the benztropine, and actually the DIP would be better, but the TD would emerge. And so this is a good clue for us to use for Joe. So many things we can do here. There's opportunities. We can finally switch from haloperidol decanoate to something else. Sometimes it takes this to move this along. We can start to prescribe benztropine, which can take a while, weeks to months.
So we shouldn't stop it immediately.
No, never stop benztropine immediately, because then the patient will be extremely uncomfortable and will never want to try this again. If the TD remains after doing everything, well, we'll use a VMAT2 inhibitor. If the DIP remains, we'll consider amantadine. The order of which we do this will depend on Joe and the clinical realities that we face in treating Joe. How high should we go with the VMAT2 inhibitor?
Well, I feel like whenever it comes to efficacy. So we're going to push the dose until we see the desired efficacy, or maybe until the patient is not able to tolerate a certain side effect.
And if that VMAT2 inhibitor doesn't work, what do we do?
Let's try the other VMAT2 inhibitor, or again, we can look at that amantadine option.
So several opportunities here. In terms of our resource center, that will give our listeners, our viewers, more information, right?
Yes, please. You can see on the screen here, you can visit this website, TD360, where you'll be able to look at different patient videos. You'll also hear from other experts and their insights regarding tardive dyskinesia, keeping up with up-to-date latest news regarding TD and its treatment, and of course receive complimentary CMEs. So please scan the QR code on the screen and visit this site for more learning.
Well, thank you all for listening to us, and we're looking forward to your questions.
Thank you.
Good.
Awesome.
So I have a question here. Did I say if the TD remains, consider a VMAT2 inhibitor, or did I say if the DIP remains, consider a VMAT2 inhibitor?
I didn't hear you say the DIP.
Do we want to just say it? We can repeat this slide.
Do this slide.
Just, for
Mhm.
sake.
Just in
Just
case.
in case?
I would, yeah.
Okay.
That's good. We're still rolling?
Yep.
Cool. I'll count you in, and then you could just.
Okay.
Ready? 3, 2.
So there are several opportunities that present themselves here. We talked about switching the haloperidol decanoate to another long-acting injectable. This actually makes sense in general terms, and we should have done it long ago, but sometimes it takes TD to occur before it starts moving things along. We can de-prescribe benztropine, and we should, but that cannot happen overnight. We need to do this gradually over time. If the TD remains, we can consider a VMAT2 inhibitor. So if we switched to a second-generation agent, eliminated the benztropine, TD is still there, we'll use a VMAT2 inhibitor. If the DIP remains, we can consider amantadine. Now, the order in which we do this will vary according to the patient. Which VMAT2 inhibitor should Joe receive? Well, basically what Joe wants, if at all possible, but the pharmacy benefits manager may dictate which one we try first.
Which often happens in real life.
And how high should we dose?
When it comes to treating a patient, we want to treat to efficacy. So until we see resolution of those symptoms, we want to continue to try and push the dose unless it becomes intolerable for the patient.
And if one VMAT2 doesn't work, what do we do?
Then we can try the other VMAT2 inhibitor, or maybe even look at other options of something like amantadine if that other VMAT2 did not work either.
Good. Good, you gave us extra. That was
Just in
perfect.
case.
Yeah, we could have cut it in.
Okay.
All right, perfect. Cut. 3, 2, 1, cut.
Cut. Fantastic.
Awesome. Nicely done.
All right, thank you.
Thank you.
We'll grab microphones from you. Actually, if you turn around first, we'll grab the pad.
Okay. Man.
Got this. Thank you so much. Perfect. Thank you so much.
Thank
Appreciate it.
you. Les, it's been a pleasure.
Yes, that's all. Watch your step on the way out.
One bar tick down. This has one bar tick down.
They're fine, yeah.
Oh wait, no. This one's got to get replaced. It
Okay.
just went to one bar.
I wasn't.
But I turned it back on.
Oh, yeah, no,
Had the
okay.
thought
Yeah,
of
they
maybe it's
need
one.
to
So used to Canada. Well, now yeah, let's get chairs in and let's
feel like, Jill Hargavy-Friedman and I always joke about that. We always want to put color in, but black always looks so nice.
Yeah,
So,
It does.
I went suit shopping the other day, and like men's clothes are.
I know. What variation is there?
It's like, hey, this one's slightly more charcoal. This one is slightly.
I know, unless if you're Rakesh.
Yeah.
Not as navy.
Yeah.
That's a good color palette. Not as
Not as
navy.
navy. Yeah.
So
All right,
there's
turn
a
around.
podcast I listen to where somebody refers to it
Good,
that
nice.
the host is
Okay,
gay.
thank you.
And he calls a lot of suits heteronormative blue.
Yeah.
Right. Yes.
I love it.
Yes, like you needn't question my.
Everyone else has done it?
That's why I like vintage clothes sometimes. Like I found this in a store on Haight Street.
Did you really?
Yeah, it's like
It's like in primo
it's my Mad
condition.
Men suit, you know?
I love
like,
it, yeah,
But I
yeah.
mean, there's like details on this, like it's stuff like there's like weight on the cuffs.
Unbelievable.
So it drapes nicely.
Oshmi wore something yesterday it was an all cashmere blazer she found for $16 at a
Wow.
vintage store. I was like, you've just inspired me. And I feel like I need to go on a hunt.
Yeah.
Sandra and I were both pretty envious of that. And Sandra's like, I go to a store and never find anything. Rakesh, he's like, get that. Well, of course, he's got that sense of style.
He's a dandy.
He is a dandy. I love it.
I think
He is
this
a
can
dandy.
go in your inner pocket if you have one.
I do. It's there, or I can just clip it on my
Yeah, clip it on your belt.
belt. I'll just put it
Or
in my
pad.
pocket. I put it in the pocket, or is
I
that
wouldn't
bad?
do the pocket.
Interference.
I think I would do
Belt or back.
and I can do it if you're comfortable or it's better.
How's that? Is that gonna be okay if I'm sitting on it?
That slack and tuck a little bit of it into your waistband.
Got it.
Thank you.
No random wires sticking out of the.
Yeah.
Into
So
the
just don't
frame.
tuck it so much that like you can't move. But
Okay. And I feel like Pete in Mad Men in this suit.
It looks very good on you.
Thank you. Hopefully less schmarmy than the Pete character was in that show.
I never watched the show.
Oh, it's so good. We started watching it years ago when it first came out, and then the last year, Kate and I just binge watched the whole 10 years or whatever it is. Because the whole thing is like an arc from
Yeah.
1960 to 1970, and it's brilliant the way it tracks all the changes in.
Changes in society.
You won't see where your feet are.
Yeah, this is the only thing I need close by so it doesn't alarm the other stuff I can put away.
How's Cyrus?
He's doing really good.
That's wonderful.
Yeah, I just connected him with a Burning Man friend of mine who does. Rob's an interesting guy. He's like 70. And he used to be part of like Ernst Young, business stuff, right?
Yeah.
But he has a company that does workshops for organizations, usually like Fortune 500 companies that are doing having big transitions.
Oh, yeah.
And it's strategic stuff where they take like 3 days, they bring their key players together, stick them in a hotel for a time and do all these workshops with them. And the place where Sai comes
Cool.
into this is that in these conversations that they're having, these sort of focus groups, they do graphic illustration note taking, like on a big whiteboard behind them,
Yeah.
and then they photograph that and like print it into a magazine type thing for the stakeholders to have as a reference, and then they take it back to corporate headquarters or whatever and reference it. But they hire people to do the drawing, which is where Sai comes in.
Awesome.
And so it may be an internship opportunity for him. Yeah,
That'd
which
be
would be great.
wonderful.
Yeah,
Yeah.
yeah.
Do you guys want to look at the questions?
Yeah.
So I have no idea what I'm talking
Yeah,
about
me
here.
neither.
Super easy.
Okay.
Let's see.
I was telling Rakesh, that's why this day is so, I was anxious because a lot is not scripted.
Because
Everything I've done for PC Regional so far,
Yeah.
unscripted.
yeah, I know it's without a net, right?
It's more anxiety
Can you
producing.
guys, just in a minute, scroll through the script?
Yeah, we'll get
Give these
microphones
guys a
on and then we'll give
chance.
you guys a chance to look through it. And then
Okay, great.
we're not just going to sit you down and get you going.
mic you up real quick.
Oh, good, here we go, sorry.
I will come.
No problem.
Squeeze around behind you, stay where you are. Let's see which way.
Uh-huh.
Yeah, and then you can just sort of tuck some of that slack.
You got it in the back.
I feel like we didn't coordinate, but we look very.
We're complimentary, aren't we? Of course, because we all are connected.
In sync.
Connected.
We're all in the flow. How long is this show? Do you know? 2 minutes. How long is it?
I don't know.
How long is this segment? Oh,
No,
30.
no.
It's 15, 2:15.
Oh, yes.
Oh, I was about to say.
The whole time allotted for this.
Yeah, this won't take 30
No, you're
minutes.
doing 2:30.
Yeah, I was like, okay, let's come up with some stuff, people.
Let's just talk very
Slowly and intentionally.
Let's be intentional.
That's right.
We'll pause.
Look, give me a
Let's
moment.
Practice breathing together
That's good.
for 12 minutes.
Okay,
12
wait.
minutes of breathing.
Somebody asked me yesterday, 12 minutes of silent breathing.
Silent breathing.
Somebody asked me yesterday, what did Andrew say in the funny clip for NPI?
Oh, God.
It was not
It was learning
aroused.
and pleasure.
And pleasurable.
Learning- Yeah.
I don't know where the hell that came out of.
And I was like, what the fuck did she just There's a in that clip, the two of us, we're both like wheezing.
Of course, real quick.
Okay.
Are you in this pocket here?
For
Okay.
learning and for pleasure.
That's take our picture, please.
And when Andrew realized that was
Do you have a pocket?
I've been told I need one.
You have one on this side?
We left.
I don't know.
I do? Okay, cool. I'm gonna go in there.
End of a-
I just gotta flip the clip around.
Some
end of a like
documentary style.
Congress Day.
What are we doing?
He's just taking some
Oh,
pictures.
that's sweet.
And the funny
Yeah,
thing
it
is
was
the
just
one they went
laughing.
with, like, I look so serious because I'm trying to like not laugh. I'm like,
I watched it with my family, and they're like, what are they get? Stan goes, how are they going to get something out of that?
I know.
But you two were like, it's like at the end of the day,
Oh, we were
we were
punch
so
drunk.
punchy. We
Yeah.
said, could we have a whiskey first? We were just like,
Yeah. Come to San Francisco to learn and have pleasure.
Pleasure. Orlando.
Yeah, Orlando.
Mickey
Yeah.
Mouse.
pleasure.
Yeah, the pleasure part was so random. Because they're like, say something about it being fun and like learning.
Then suddenly
So-
pleasure emerged.
It came out.
Good?
How the hell did?
Opposed one as well?
Oh, no, I don't need a post.
Work man, just want to make sure.
Thank you. I
Do we want to
appreciate
post
that.
one?
Okay, we want to post one, sorry.
Here.
Sandra wants to
We'll
post
post
one.
for the
We're
girls.
posting.
Okay.
All good?
Chicks.
Cool.
I'll come
All right.
with you guys.
I assume you don't want this in the shot.
No, I mean, honestly, if you want, you could probably put it by your feet if you want to keep it here.
Sure.
Or I can kill it for you. It's okay. Oh, that's nice.
Thank you.
So good.
Thank you. Thank you.
I want in on
Well,
that.
come on, we'll get with
Come
you.
on.
I want in.
Okay, come on, Andrew.
Come on. I feel left out.
Yeah, share.
You know, I'm always told like we need more social media things, and I'm like, oh,
That's right.
it's so annoying.
Did you get set a custom time?
Thank you.
Thank you.
Look at us all photogenic.
Right?
I'll make sure that my ringer's off, and so I'm not that person.
Right.
Font size on that one just a little bit bigger because it's darker.
Sure can.
Thank you.
And for all of you, the goal when this is done is 15 minutes. So there's a lot of spots for responses and stuff. We just want to kind of
Watch
keep
it
us
going.
happy and moving as best we can.
So better to be on the shy side of 15 than on the long side?
Yeah.
Okay.
Sandra's going to interrupt me a lot.
No. We said we're going to do 12 minutes of quiet breath.
Oh, that's good. I like that.
How does
Actually,
that look, Sandra? We can
Perfect. That's good.
Good? Okay.
Should I pivot more this way? This better?
Yeah, so
All right.
oh yeah, because they've
I know that these screens are here, but try not to read off of them directly. They're more for just an assistance when you're looking at somebody else and you kind of glance over, but don't stare at them directly and read off of them, okay? If you're gonna address anything, address here because there is a camera inside of here. It looks more natural to look at a camera versus looking at these, okay?
Okay. I think you're the only one
So you're,
doing the prompt.
yeah,
right?
you're the only person.
yeah,
that's-
you guys don't need, I'm going to be doing it. So what'll happen for you guys on this side, I will not probably be looking directly at you. I may glance. So I'm assuming, if my eyes look weird, just say so and we'll fix it.
We have 3 cameras.
So if I'm talking to you and not looking directly
Oh,
at
and,
your
and
eyes,
when she's
don't.
talking, where should we look at? Should we look at?
She's talking to you, look at her.
No, but when she's like reading that, when
Looking here. You're
okay,
looking here. You're,
okay.
You're always on camera, so take note of that. Like, try to keep a happy face, because if you look like you're falling asleep, they're gonna see. Okay.
Okay.
So try to keep the face
yeah.
up. When she's
But like
looking
when
at
she's
you, look at her.
introducing, we should look there.
100%. Yes.
Okay.
And then when she turns to you and talks to you, look at her.
Yeah, because I remember one video we did where I look like I'm just like weirdly staring at you the whole time. Like, so it's made me so.
Yeah.
All right, Sandra, I kind of want to scroll through and.
Okay.
Oh, that's me.
My stuff you can skip. It's good enough. Yeah, you can just, I want them to be able to see the questions. So this first, is this the morning one? This is about burnout, I think, COVID, so it's not like anything new, you guys. We felt
Boring.
like we shouldn't, yeah.
Boring.
So Julie, we'll start with you.
Okay.
What are we talking about?
Yeah, I mean, I remember there used to be a time where we would get these questions in advance.
Yeah,
And I'd be like,
yeah.
I think the spontaneity is something
It is
that the
something
team
nice.
likes.
it is nice, yeah.
So there's yours, Vanessa.
Oh. Oh, yes, you're so always like, thank you, thank you, thank you.
There.
There we go, got it.
What's it like to be treated by a burned out clinician?
Yeah. Can you think of one?
I don't know any.
Andrew, here's a question for you.
We know the answer is pleasure.
Pleasure. I take drugs.
Pleasure in
Drugs
Orlando.
and pleasure and whiskey.
Then that's it.
All right. Oh, that was a good laugh.
Okay, so the first question is going to be to Julie. So this is just going to be like, hello.
Oh.
All right, everybody, audio sounds good? You got everybody's channels?
That just seems so weird.
Cool, all right.
Yeah.
Do you,
Speed Cameron.
Speeding.
Audio.
Okay.
You want this just as like a steady two-shot?
Steady two-shot, yeah, steady two-shot. I mean, if you feel like
H-turn is speeding.
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 We're speeding.
Structure.
Guide me in
I meant to
here.
tell you.
Oh, clapboard and everything.
Structure in your
Wow.
baby sculpture. I use that image when I meditate.
You're good on my side.
Yep.
for
Perfect,
I
right?
love it.
More.
I breathe on them.
Who knew?
Mark. When you go in,
Yep.
can you hit the?
You want me to hit? I gotta roll the.
Okay.
Yeah. All right, so I'll do a 3, 2, and a
Okay. Perfect.
Ready? 3, 2.
Good morning, everyone, and welcome to the 2025 Site Congress Regional Series. I'm Dr. Sandra Jan, a proud member of the Site Congress Steering Committee and our Site Congress family. I'm an adjunct clinical affiliate at the University of Texas at Austin School of Nursing, and I have a private practice in Dallas, Texas. I'm absolutely thrilled to be moderating this regional meeting. Now, over the next 2 days, we'll dive into practical, case-based sessions led by the foremost experts in mental health. What's our goal? It's simple. It's to provide you with practical tools and insights so that you can bring them back to your clinical practice. We're so excited to bring back the extended panel-style Q&A sessions this year. Twice during the day, our expert faculty will answer your most upvoted questions live. So don't miss this opportunity to engage directly with the experts. Submit your questions during each session and vote for the ones you're most curious about. We look forward to hearing from you. A quick housekeeping note. If you haven't already done so, please click the bell icon in the bottom left corner of your screen to subscribe to meeting notifications. There's so much happening, we don't want you to miss a thing. Stay curious, engaged, and ready to soak up as much learning as possible. Here at Site Congress, we want you to know that we're here to support you on your educational journey. Let's dive into this incredible learning experience together. We have a world-class agenda for you today, and I'm so glad, we're so glad that you've all tuned in. I'm excited to be joined by my fellow faculty members, Julie Carbray, Andrew Penn, and Vanessa Joy Walker. Welcome, everyone, and good morning to you all.
Morning.
Good morning.
Good to be here.
So glad to be here. Absolutely, Vanessa. Well, we're going to start these 2 days of education. Hold on, that is not you yet, Julie. Sorry. And I'm back. Is there a reason, just to kind of cut for a minute, why that screen is jumping around like it's having a seizure?
For some reason, it shouldn't happen.
Okay, okay, perfect. All right. So do you want to count me back in, or I can just start here?
Start off on here. Okay.
You got it.
Ready? 3, 2.
Let's start these 2 important days of education by addressing, back her up. Let's start these 2 important days of education by addressing something that hits close to home for many of us, and that's burnout and mental health. It's a topic that we've all explored frequently, especially in the wake of COVID, but it's always worth revisiting. So how does burnout really affect our ability to show up, to be fully present for our patients? You know, as mental health professionals, neglecting our own well-being can lead to burnout, and it comes with significant consequences for both us and the quality of care that we provide to our patients. So today, we're diving into this important conversation with a focus on practical steps that we can all take to take really good care of ourselves and others. So if y'all are ready, I suggest we get started. So Julie, let me start with you.
Yeah.
You know, from your perspective, I'm so curious, how have you seen burnout impact clinicians' ability to really show up and connect with patients?
Yeah, I think burnout really does impact our ability to be present in the moment and to go beyond our own experiences, to be able to look externally into how we can help others rather than being consumed by our energy level, our connection to caring, and just that humility that we can bring to patient situations. And so I think we have to be mindful of that. We probably have our own thermostat as to just where am I at with my level of burnout? What can I provide today? And if I need to do something to up my game or to shore myself up or to connect with somebody or even internally with myself so that I can touch base on how burnt out am I feeling today? Am I feeling burnt out? What kind of energy can I bring so that that presence that you and I have talked about quite a bit is in the room when I'm there with my patients? Because our patients can feel it.
Absolutely. I love what you said, Julie. It's about doing a self-check.
Yeah.
Maybe not just once a day, but multiple times a day to kind of see where we're at, how we're showing up.
Yes.
Great suggestion. You know, Andrew, over the years, you and I, many times we've talked about burnout. We've presented on burnout. We know how damaging it can be, not only to us, but to our patients. What do you think we can do individually and collectively to really protect ourselves from what we're calling burnout?
Yeah. You know, for a long time we talked about burnout as an individual problem. It was framed as maybe you're not taking good enough care of yourself, maybe, you could do some lunchtime yoga or something like that. And increasingly, I'm looking at this as a systemic problem. So all these little places of friction in my workday, whether it's a clunky EHR or not having the resources that I need to treat my patients correctly, or just too many extra steps just to do something as simple as order a medication or a return to clinic visit. Those things contribute to burnout, so it's not just about individual shortcomings or challenges, it's about these bigger systems issues. And I think this is, oftentimes when we talk about burnout, we talk about what should you as an individual do. And I think about advocating for systems change as actually a counterforce to burnout. Because if the system works better, then I can work better. Because I still love doing patient care. I'm not burnt out about patient care, but I'm burnt out on healthcare systems.
Yeah. I like that. And as you're answering that and talking about it, Andrew, I can hear Julie agreeing, Vanessa nodding. And so I think we all are in agreement that this is much broader than just us individually as
Absolutely.
clinicians.
Yeah.
Yeah, love that. So Vanessa, we've had these conversations many times, and I always feel led to thank you as a person with lived experience that you show up to these conversations so open and willing to share your own experiences, your journey. So before the question, just a heartfelt thank you for how genuinely and lovingly you show up.
Thank you.
Absolutely. I'm so curious, in your years of dealing with healthcare, meeting with clinicians, have you ever had an experience where you just got a clear signal, kind of like what Julie said earlier, our patients know when we're burned out, where you felt like the clinician was really tired, not really present? And I'm wondering if yes, what that experience was like for you.
Well, I mean, before we went on camera, we kind of went over these questions, and there was a slight giggle when this came up because, I mean, of course, the answer is yes. Perhaps in years past, before I was very intuitive about these things, I didn't really realize that is what it was.
Sure.
You know, I might have just left the experience feeling unheard, feeling frustrated, feeling like I got less than I thought I was going to get, feeling more confused, and often not feeling cared for, and I mean safe, right? You know, everyone here knows that I've had multiple health experiences, issues. I've had cancer a couple of times, but when dealing with my mental health, it's even more important to feel safe when you leave that space, right? To feel like I can go back into the world and think, oh, they've got my back,
Yeah.
right? And listen, burnout happens to everyone, right? You're never going to show up 100% all the time. And so I just loved what you said about systemically thinking about what are the things that we can do in our whole practice and then in our community to start to work toward creating environments where we might experience less burnout.
Absolutely. I love this conversation. You know, as we talk about this, I know we're all in agreement that at Psych Congress Regionals, what we want our conversations and our education to be about is we want it to be practical. We want it to be clinically useful. So let's do something to meet both of those things. Let's talk about how to manage burnout. So Julie, let me start with you again. What is your go-to wellness practice?
Well, it's really become quiet prayer, meditation, exercise, and laughter. I listen to podcasts on the way to work. I have a colleague who stops by almost every morning and says, how are you? How's your day? What are you looking at? Is your challenges? And we connect at the end of the day as well. And then I do the same thing. I laugh on the way home. And if I really have had a rough day, I even in the evenings will try to get a walk in and to do more laughing and do all those wild five. Sleep, good nutrition, connect with people I care about, have a time where I'm quiet, and exercise.
I love all of it, Julie. All right, let's hear from Andrew. How about you? What's your go-to wellness practice?
Well, you know, many of the same things that Julie said. You know, getting outside. I'm an aspiring meditator. I've never been particularly good at it, but I'm going to keep trying. You know, but also pushing back against some of these systemic things. You know, when the system isn't working, rather than just sort of accepting it and saying, okay, that's just how it is, you know, to really ask, why is it not working? And to keep bringing that up as a barrier to care, because, you know, what you were saying really made me think about how, you know, how many times have I been sort of frustrated with the computer system or something, and the patient picks up on it and thinks maybe it's because I'm not a very interesting patient, you know, when really I'm just frustrated trying to get the computer system to work. So, you know, really trying to make some changes in these systems in which I work in, so that I can do the work that I love to do. That's another form of self-care.
Yeah, beautifully described, Andrew. It reminds me, as you were talking about that, once we were talking about how silly it is in these systems when you have free pizza Friday.
Oh, yeah.
Like somehow that's going to make it okay.
Right.
And that's a great way of just being able to give that practical feedback to the higher ups that that's really not specific to what we need to feel better, to be more engaged, and to felt, Vanessa, what you said, held and safe in the environments where we're working. So,
Yeah. If you take good care of your employees, they can buy their own pizza.
Yes.
there you go. Yeah, exactly. Vanessa, how about you? What rises to the top for you when it comes to wellness practices?
Well, I would say that who better to answer that question than the person who has mental health conditions, right? Because you as clinicians are going into your spaces and you're telling me often what I could be doing. I'm not going to say should, could be doing. And I would say to everyone, as opposed to choosing one thing, what are the things that you tell your patients? What are those best practices that you bring into the space? And when you're sitting across from someone and you can tell they're burnt out, what are the things that you tell them?
Yeah.
And then I ask myself these questions, am I doing those things for myself? And I think there's a lot of value in taking a moment to have a little self-reflection. And I loved how you used the word humility. Also just taking responsibility. Sometimes being able to say, boy, you know, today's kind of hard. I've got this bracelet that I think you guys have all seen me wear before. It's green. And it was created by Mental Health America. And one side says, today's a good day. And the other side says, today feels hard. And I think I told you one time that I wear that bracelet less for other people and more for myself. So that when it's a hard day, I can look down and I can be reminded, oh yeah, today's a hard day. So if I'm going into a space, I need to remember that today is a hard day. And that helps when the end of the day comes because I've been kind to myself. I think being kind and gentle to ourselves is an ongoing wellness practice.
Beautifully stated, beautifully stated. And I think, Vanessa, in previous years, you've been my teacher around self-compassion when it comes to wellness practices. Because I don't know about you guys, but we set these goals for ourselves about, oh, to Andrew, to your point, I'm going to meditate every day for 20 minutes, right? And then it's like, well, that didn't happen.
I'm meditating, I'm meditating.
Right. It's another opportunity for failure.
Right.
Right.
The negative voice kicks in, and it's like, you're not doing this right. And Vanessa did such a nice job of teaching me, and I know all of us, that we don't have to do it that way, that we can be, I mean, we're teaching our patients about self-compassion. How about we adopt it, walk the walk, and practice it? So I'm so glad you have put that into this conversation today. So we are at time, but I want to thank Julie, Andrew, Vanessa, all of you for joining me in this discussion, and all of you at home, or maybe you're at the office, for tuning in. The conversation this morning, it's a reminder that taking care of ourselves is not optional. It's essential for the work that we do. We've got an exciting day ahead, lots of sessions. So please join me for our first session of the day, which starts in just a moment.
Nice. Very good.
Okay.
Thanks, guys.
Yeah, good.
Nobody get up.
No, please,
No.
can we just have,
You want to take a photo?
oh, okay, photo. I just got to get some water.
Yeah.
He's got to go. He's got a session.
So good. Does it feel like I have my back to you? It feels
No.
so, okay. I don't like this chair
I
thing.
know, and
I don't
we
like
can't
it.
move them.
No.
We still have another session, so
Okay.
we'll get you after this.
Oh, after. Okay, can we just have a little break for some water? Just quickly. Thank you. All right, guys,
You
I'll
go
be right back. Oh, do y'all want to scroll and see what's coming?
Yeah.
Well, actually, wait till I get back because I know.
Okay.
Okay.
It's all about motivational interviewing, I think.
Self-care? How about a union? I'm just going to quietly
Don't say
dissent
that
over
too
here.
loud because, you know,
Yeah.
my husband's doing work for SEIU and they canceled all
I know.
their DEI contracts with him.
Yeah.
So
I just wrote an abstract in another application the whole thrust of it was demonstrate your encompassing diverse populations and marginalized youth into blah, blah, blah.
Water real quick.
It's such a juxtaposition to what's happening. I mean, you just see how all these agencies, funding agencies, conferences, are really aligned with all these initiatives.
Did
It's
you
better
see this,
today.
if
That
not
5
this
hours
week,
of
if not,
nap
I'll
was
send, I'll
good.
send it to you.
5 hours.
So
You
much
might need
better.
to take a
Do
deep
we
breath
have
and drink before you
coffee
read it, but it
cups
was
anywhere
put
just
out
so I
by
can get some
the,
hot water?
it's about the NSF and.
Are
it's
these
put out
clean? Here,
by,
I don't care.
Yes, that would be clean. It's
yeah.
upside down on there.
Yay, I'll do that.
Senator,
That'll save us.
I don't know, one of the, Senator
Try
Cruz's
not to
office,
delay
I'm not
us.
sure whose office, but it's basically an entire 43-page report on how DEI initiatives have basically ruined the government over the last like 8 years. And in it, the last like maybe 12 pages
One
is
down,
an
one to
appendix
go,
of
and then one day
all of the terms that they do not think that you should be using.
Yeah.
And there's about
Like trauma.
like trauma, like, and there's probably about maybe like 250 or more terms.
Oh my gosh.
Like it's stuff like underrepresented, stuff like trauma, stuff. I'm like, really? We can't use the word trauma now,
But talk about thought police.
right?
Thought policing, it's like you can't, if you put, and some of these things are screened. It's like trying to get a job now. Like you put your resume in, nobody actually reads it. It's all
AI.
It's all character recognition. They're looking for certain keywords. So now if you put a grant proposal in that says the word has the word trauma in it, does it just automatically get thrown in the
Gets
reject
bumped
pile?
out.
Yeah.
You know, it's also very interesting. I just discovered ChatGPT like a month ago. Amazing.
And a midwife.
Last 2 things I submitted. Did you use any AI technology to write this abstract? You have to check it off now. If you've used, reduce this to 300 words.
Right.
Oh yeah, you can't do it. And I thought, oh, this is a new thing now too.
Oh, I'm having to deal with this with my students.
Oh, I bet you are.
Yeah.
Yeah, I
In
bet.
fact, I'm getting ahead of it. So what I'm going to do, they have a case. I'll give them the subjective and objective part of the note, right, without the the treatment plan. And I say, okay, go ahead and write your own diagnosis and treatment plan, case formulation, and then run this case through AI. I want you to run it through 3 different AIs and compare what you find. How does it line up, and where did it agree with your treatment
One day, my
plan
friend.
and diagnosis, and where do you think
Somebody
it went
drank
wrong?
last night.
Because they're going to do this
Love
anyways.
that. They're going to do it anyway.
I figure I might as well have them
That
find
is
out
so brilliant.
where.
I love that. I
Yeah.
had a professor, who did something similar where
Yeah.
she just came straight out and she said, listen, you guys are all going to be using AI. It's going to be part, and you're going to be using it to write grants, you're going to be using it to do programming. So let's just talk about it, and let's talk about ways that we can incorporate it and check ourselves. And I really appreciated that.
Yeah.
You know?
Yeah, I figured,
I was
they're going to.
saying, I applied for 2 things recently, and you had to disclose if you used any AI technology.
In writing the
Beeswax.
application.
Yeah,
How about none of your beeswax?
I know.
What I'm using in my private house.
I thought this is a new disclosure.
And what happens if you say yes?
Well, you just have to own up to it, apparently.
Interesting.
Hell yes, who doesn't?
Yeah.
Yeah.
So,
Do you
do you want us to do a run through again? So
Yes,
you guys
please.
get-
That'd be perfect. Is this okay, you guys? Does it feel? I mean, anything you need different? or-
No.
It's good.
Yeah.
Okay.
Yeah. How's your voice holding up?
Do I feel? Does it help for me to turn around a little in my seat?
No, you were perfect.
I was
I
good?
think that, but I
Okay.
just have to turn, and I know
Okay.
it's odd me looking
No,
at that.
that's all right.
Okay, so can you just go back up? Not my stuff. I don't care about that. I've got that. So Vanessa, I'll start with you. Just reflecting on motivational interviewing. Right. Have you ever felt like you've had a clinician who had their own idea about what you should be doing? And then Andrew, for you, does it get enough attention in training programs?
Okay.
I mean, we can modify, and that's not my favorite
Right.
question, But do you
Yeah.
think, I mean, I think
we
it is
talk about it.
important that,
We use it a lot.
okay, perfect.
Yeah, I can rip on that.
Okay, and then Julie, just for you, that
Yeah.
what kind of advice would you give specifically for clinicians who really want to integrate it more, learn more about it?
Right. Okay.
And again, remember, like we did last time, you guys, if
sure you can comment
if you have
whatever.
something to add,
Right.
just add
Sounds
in.
good.
Um,
An ambivalence.
Oh boy, a favorite
Feeling
in my
stuck.
devotion.
do you need a minute for that one?
No, I'll think of something.
Change talk.
Yeah.
This one good, Julie, where you could just
I
a
like the
moment
5
where
whys.
that
Okay.
led to a
When you ask them
breakthrough.
if it's
Okay.
5 whys.
Yeah.
You heard this?
Tell me.
It's where you ask someone, you say, how are you feeling today? They tell you, why do you think that is? And then say, well, why do you think that is?
Oh,
And you ask it
interesting.
5 times, and they've actually done studies to say if you ask something 5 times, it
Uh-huh.
gets the person closer to
Mm.
what they really wanted to say the first time.
Huh.
That's called the 5 whys.
The 5 whys.
I tend to avoid the word why in interviewing because it makes people defensive.
It can,
Right.
but I think it's interesting the way you position it.
Interesting. You know what? I have a variation on that
Sorry.
with patients that are really like hard on themselves
Mhm.
and do that like cross-examination, like, why do I keep doing this? I say, what if you introduced "I wonder" in front of that sentence?
Oh,
Like,
that'd be good.
I wonder
I like
why.
that.
That'd be a great
Because
example.
because you
Andrea.
you don't feel like you're backed up against the wall when
Yeah.
it's like I
love
wonder.
that.
I
It's-
wonder.
It's like an invitation to ponder a little bit.
Yeah.
And
Like,
I
I
would
wonder
say
why I
could
do that.
instead of should. You
Mhm.
you shouldn't should on people.
Yeah, you shouldn't should on people. Yeah.
I mean,
Okay, so I'll ask you about
Yeah.
empathy,
Good.
Vanessa. All right, we're ready. If you'll just scroll down. Sorry. Oh, and that's the end. Oh, okay, good. That was easy.
Yeah.
Everybody good?
And we got 15 for this.
Yeah.
Mhm.
Some final thoughts.
Final moments. Didn't Jerry Springer have that?
Final thoughts.
He did
Oh yeah, he'd
something-
have his little monologue, right?
Yeah, at the
Yeah.
end.
Yeah,
I have to give some sort of like final thought now.
that's right. Jerry Springer style.
They do better.
In homage to Jerry Springer. Oh, Randy would
I'm
be
going to
like,
throw this chair at you, Andrew.
That's right. Fellow Cincinnatian,
Randy
Jerry
would not be
Springer,
happy.
native son, Andrew Penn and Jerry Springer, Cincinnati, Ohio.
I'll try not to say vagina at all.
Oh, there's people that play bingo with that though. We have Site Congress bingo. Vanessa
Vagina
says
bingo?
vagina.
How many times does Vanessa say vagina in one site congress? How many times does she?
Oh,
It's like
no,
a
no.
drinking. Does she
game.
fit it in?
a drinking
game.
Because I do try to fit it into every session at least once.
If you do it now, I'm going to elbow you.
That's what she said.
Yeah.
Sorry, Dan.
Mark.
Unruly. Okay, people. No vagina talk, people.
All right, everybody set?
Everybody set.
Schmutz.
What'd I drop?
Contact.
I laid an egg.
That's going to open it up for Vanessa to say something.
I know. Don't do it.
Sorry.
All right, I'll count you in.
All righty.
Ready? 3, 2.
What a terrific first day, my friends. Thanks to all of you for spending your day with us. I'm here again with Julie Carbray, Andrew Penn, and Vanessa Joy Walker to close out this Thursday with some final thoughts. Vanessa, as the day's gone on, I keep thinking about motivational interviewing. We've talked about that. You and I have actually presented together on motivational interviewing. And I'm wondering, in your experience as a person with lived experience, have you ever encountered a clinician who had an idea about what was best for you, what you should do, and they were really insistent on convincing you of that? If so, can you tell us a little bit about what that was like?
Well, of course, the answer is yes, right? If the answer was no, I would be lying. But I did have an experience recently, and I was actually telling Andrew about it just yesterday, where I've been in the process of finding a new psychiatrist because I moved and I had to find a new provider. And I ended up having this session with someone, and they started out the session by not really introducing themselves, not really asking me anything about myself, like, why are you changing psychiatrists? Like, nothing to set the stage, right? Nothing to create a sense of an area of empathy. I like to say that, right? Nothing to create that. And they just began asking me questions about what I'm taking. And I got to the fact that I take a low-dose benzo every day that helps with my vocal tic, and I could sense right away that this person was very upset. And they said, not, tell me more about that. They said, has anyone ever told you that taking a benzo on a regular basis isn't good for you? And I said, well, yes, actually, I have had people tell me just like you told me. And then there was silence. And I think that's the point, right? The wall went up.
Yeah.
Whether this person meant to erect that wall or not, it was then there.
It's a great example. It's also a very sad and discouraging example, but it speaks to, like we all know with motivational interviewing, to meet our people where they're at. And this person just missed the opportunity to do that. So all of us, I know, we're sorry that you had an experience like that, Vanessa.
Yeah, and I appreciate that. And I also want to make sure that if anyone's watching this and they're like, oh my gosh, I think I've done that, to not beat yourself up over it, right? This all has to do with how, we're all products of the environments we've been reared in educationally and otherwise. And so if we're not really taught to lean in that way, and we're taught to check the box, then of course that's how you're going to enter in, right? So you have to step back.
You know, it reminds me, and Andrew, I'll ask you this because I've heard you speak about it so often on stage, off stage, but asking a patient for permission to talk to them about something. So in a situation like Vanessa just described, how might you have handled that differently?
I mean, it makes me think about, I always tell my students, your patient is assessing you as much, if not more so, than you're assessing them. They're assessing you for different things. They're assessing you to see if you're safe. They're assessing that clinician to see if they have an agenda. And I think where I hear in your experience is that clinician had an agenda. And that agenda was that you shouldn't be on a benzodiazepine.
Right.
And they weren't interested in why you were or what benefit it had or what the potential risks were and having that conversation. And so they just went right into their agenda, and you pick that up.
Yeah.
And once you pick up the agenda, then you no longer feel connected, right? And so yeah, that idea of kind of incremental consent, that each step of the way, can I ask you about this? I'd like to ask you some more about this thing that you brought up. Would that be something you'd be open to doing? And one of the things I think it does with this, when I see this with students, is a lot of times students have this, they want to do well. They want to do the right thing. They want to get the patient better. I mean, we wouldn't be in this work if we didn't have those motivations. But sometimes that gets in the way, right? And the patient can pick up on it a little bit. And one of the things I like about motivational interviewing is it really respects the pace of the patient and where they're at, and that they may have a different agenda than we have. And really, MI is about uncovering that, understanding that process, respecting where the patient is at, and starting there, rather than us imposing our kind of preconceived notions about what this patient should have, which came out in your particular situation. And it really broke the rapport. It made it so you didn't feel comfortable going back to this person.
Right.
So if the goal of the first interview is to have a second interview, that person didn't do a very good job.
Right.
Well, and it ties into what we were talking about this morning around wellness practices. self-compassion.
Yeah.
So if we realize, oh my goodness, I've done what that clinician did, not to beat ourselves up, but to just see it as an opportunity to build safety, to have an open conversation. And I love what you said, Andrew, incremental consent.
Yeah.
It's not a one-time deal. It's not just a form at the beginning of our work.
And if you do stumble, you can go back and repair. You know, go back and acknowledge, you know, you say, I realized when I brought up the benzo thing, I think the way I said that, you know, something shifted in the room. I don't know exactly what it was, but I just noticed something changed in that moment. Could we go back to that moment? Was there something more that, was there something about what I said that bothered you, or was there something more you wanted to say, to give an opportunity to repair the relationship? It's not over at that point, you know, but that's therapeutic.
Absolutely.
To demonstrate to patients that we make mistakes, and mistakes are not the end of the relationship, and they can be repaired.
Love that. Julie, how about you? I mean, again, we've talked a lot about motivational interviewing. I love that we've all had this history together around motivational interviewing. Being in an academic, teaching, mentoring position for these many decades, as you have, for all of our viewers, what piece of advice, best piece of advice can you give them about motivational interviewing if they're really interested, but maybe they just haven't had the opportunity to learn much about it quite yet?
There's some great resources on motivational interviewing. There are courses that you can take. And I would say it is a muscle that needs to be worked over and over again. Of course, it's very patient-centric. So if you're a clinician that's engaging in any interaction with a patient, you are going to really ask that question, tell me what you're hoping to do at this time we have together. That's so open-ended. And it really then directs what you will do next around determining where is this person in their progress towards their care. And you might have that treatment plan in your mind. I loved your point about students. You know, they sort of come in and they want to demonstrate and they want to fix things. And what you're trying to help them do is listen, be present, partner, determine where is this other person you're really trying to help in their walk with engaging in care for themselves, and meet them there and slow down sometimes, or make suggestions other times when you see they really are expecting something different from you. So I would say the best tips are learn, keep learning, stay very centered on your patient, on being present with your patient, and being very clearly a partner rather than somebody who's going to come at them with your tool set. It's there, but you want to make sure that you're engaging in a collaborative relationship.
I'm going to go back to that incremental consent, just checking in, engaging it as we move forward. Let's do this. Andrew, I keep thinking about patients and how sometimes they show up to our practices and they're just kind of stuck. They're ambivalent about all of it. Is there something from motivational interviewing that you used, or you really, it's kind of in your back pocket, a go-to, to really help unstick patients when they're just stuck in indecision and overwhelm?
Yeah. I think about those patients that are really hard on themselves for being in that place. You know, why can't I be different? Why can't I change this thing? And this kind of goes back to that theme of self-compassion. And one of the things that I'll suggest, just as a little turn of phrase, is like, what if you introduce the phrase, I wonder, before you say why? You know, I wonder, instead of, you know, why can't I stop drinking? It's like, I wonder why I can't stop drinking. And it changes that sort of cross-examination tone that it feels like you're putting yourself under a spotlight of why can't I change? And introducing curiosity, which is a very different orientation to the question. And it also sort of opens up the question, you know, that why, when you sort of feel like you're pinned in the corner, it feels like you have very few options, whereas I wonder why introduces this sort of curiosity and exploration that you do together with your patient.
I love how that subtle, tiny little change can make a huge difference in, again, I'll go back to the safety in the conversation to be able to really explore rather than feeling like they're getting the cross-exam.
Right, because the more important thing is that we maintain the relationship.
Yeah.
The outcome will follow if we have a relationship. If we lose the relationship, which is what happened in your situation, there's no opportunity for change.
Yeah.
Right, so when you're in that situation where you're not sure if you should prioritize the outcome or the relationship, prioritize the relationship. The outcome will follow if there's a relationship. If there's no relationship, there will be no change.
Right, can I clap?
Yeah.
Right.
Thank you.
So
Great
good.
point.
You mentioned change, and Julie, it makes me think about another concept from motivational interviewing, change talk. When patients really voice their reasons, their motivations for making a change.
Right.
In your family work, I can imagine there's probably a lot of examples, but can you share one with us quickly just to illustrate how that can really open things up?
Yeah, I think it often happens in my family work when parents understand that their high level of emotionality in trying to interact with their child when they're having their own emotionality is just not doing it. And I've been privileged to get to see parents say, you know, I realized this week I'm making things worse. Now, it could have been that we had some psychoeducation early on, that in those moments, can you do your best to regulate? And how can you regulate? But sometimes it doesn't connect as quickly for parents. And I see that a lot in my Chicagoland area where we treat a lot of diverse populations where yelling and emotionality is part of the culture, but it's also fueling that dysregulation within a family environment. So when I see either a child saying, you know, when my mom yells, this is what I do. Or when I see a parent saying, wow, I just saw her for the first time cowering, then we can then move forward, because it's those moments of change where a family has a new understanding about what they need more help with. I want to still be a very emotional person, but in those moments, I do think that I need to do something different. Help me with that.
It's a beautiful example, that aha moment.
Yeah.
Where the parent can then soften back and really see the impact.
Yes.
Beautiful. Vanessa, we talked about this throughout the day. We've talked about it for a long time, and that is the concept of empathy. And I mean, it's a huge part of motivational interviewing, really what we've all been talking about, that connection and presence. And I wonder for you, what has the experience been like when the conversations have been, you know how we say heart-led, empathy-led? Can you talk to us about that a bit?
I mean, I think we've all been saying it, right? I love how you started this morning. I think you said something about humility. And I think it's directly related to empathy, and it's directly related to creating a space that is conducive to building trust. And if I feel like I trust the person that is caring for me, I am much more willing for them to suggest something that they know I might not like, for them to challenge me. And I've had that happen. You know, I've gone to my providers and said, hey, you know, like, I want to do this. And say, okay, tell me more about that. You know, tell me more about, you know, why that is that you think, you know, that this is going to serve you right now, as opposed to, I don't think you should do this, right? Here's what I think you should do. And because we built that trust, they have the ability to perhaps challenge me sometimes in the way that I'm thinking, right? And that is key to growth for your patients, right? You have to create a space where you can challenge them at times. And that is directly linked to creating a space of empathy.
Yeah. I mean,
Well said.
Right? This is my thought as kind of closure for our conversation this evening, that relationship first. You know, I'm pointing to Andrew. These are his words that really illustrate what we've been talking about. Relationship first, outcomes will come, right?
They'll follow.
Will follow, yeah. Just beautiful. You know, I want to thank all of my amazing colleagues for sharing their insights today, and to everyone online for joining us. Psych Congress, we want you to know we're here to keep you inspired and informed with the latest in mental health care. So please stay connected, join our mailing list, and follow us on social media for updates and upcoming opportunities. Now, that's a wrap for today's sessions. We look forward to seeing you tomorrow for another day of engaging discussions. So have a great evening, everyone.
And cut. Hey, let's sit down.
Well done.
All right.
Friends.
All right.
Talk about
You got
presence
through without
and
saying
connection.
vagina.
I did. I didn't say vagina once.
You did a great job.
I did say erect though. And I
Oh,
was
erect the
waiting-
wall.
I was waiting for you to maybe giggle, but you didn't.
No,
You
no, I'm in character. I'm not.
We got erect in pleasure.
Right.
Send you into the back.
Okay.
So funny. I didn't actually mean, but then once it was coming out of my mouth,
You can't stop it.
I was like, oh, I'm saying erect.
Yeah.
At least I didn't say ejaculatory.
So you're gonna head into the back. We'll take you. Yeah.
All right.
All right,
That's
Julie.
good.
Thank you, Andrew.
We steal your microphone.
Okay. I'm going to keep my microphone.
Yes, you're keeping your microphone.
I'm going to make some hot water.
Yeah, you please do. Don't let me block you.
Got me some 30 more minutes.
Oh, good. Thank you. I appreciate it.
Thank you.
That was good, you guys. I'm getting a hair off of you like I'm a monkey, but sorry.
That's a good friend right there.
Well, that's what mamas do.
Black.
What we do,
Yeah.
we take care of each other.
That's what mamas do. You doing good, Dan?
You are
Doing
as
all
well.
right? No, I said, are you doing good?
Oh, I thought you said you're doing good.
You're always, that's so obvious. Yeah.
Typical Sandra.
Oh. You had a good evening, though? Rested well?
Oh, yeah.
Good. Good, good, good.
I'll be right back.
Okay.
I just need to grab my.
What you guys gonna do now?
A little break and kill it, yeah.
And kill it. Yeah.
One more. Well, two more. 15 minutes, yeah.
Boys doing okay?
I'm going to get some hot water. Yeah, it's just a little scratching, but that's all right. Will it? Is there any? I don't know if there is any. Right back there. Yeah. How'd your little interview go? Good, baby.
Yes, I am. No. That's usually how it works.
I even looked for lemon juice, but no.
Oh, it's so fun.
Let me go make sure.
These are my favorite
this is
things.
off so I can pee.
The discussions. The discussions.
I don't trust it. That would be horrifying.
The feeling that one side of the jacket is
Oh,
being
sure.
weighed
Oh,
down
you're
by
talking
the
about weight,
pack.
sure, sure.
Yeah.
I was talking.
Ah. No, just if it's weighted unevenly, then it's like,
I
"Come
understand what
on,"
you're saying. Yeah, yeah. You're
and
good though.
I don't want to be shuffling around or
No, that's
stuff
fair.
like that. So a far one, okay.
That is fair.
Just go after that.
That was tomorrow.
Yay. Good job, Vanessa. You always do so good.
You always do so good.
I'm ready to go home and go to bed.
I can't believe that you are.
I've never been sick for a Psych Congress anything. Stupid planes, stupid viruses. They're my man. Hey, Craig.
Hey, Sandra. How are you feeling today?
A little bit better.
Okay. Was yesterday tough for you?
It was hard, but we did it. Got everything done. And then I took a 5-hour nap yesterday when I got done at 5 o'clock, and that was magic. Just beat down.
Yeah.
But it's okay. What do they say? Something about what kills me makes me stronger. That's not right. What does that say?
doesn't kill
What
me
doesn't
makes
kill
you
me stronger?
Yeah, Kelly Clarkson.
Yeah,
There you go.
Exactly. That's where I was going with it.
Yeah, that's right.
Thank y'all.
Tiffany and I are going to go see Kelly in July at
Oh, really?
her residency at Caesars.
Let me just say,
I love Kelly Clarkson.
she's so talented.
I know.
She
She can
is.
sing anything.
Yeah.
Exactly. It's
From
unreal.
rap to crazy hard rock.
One of the best voices in the world. I mean, she's just so phenomenally talented. And she makes every song sound better.
Yeah.
I mean, I've never heard anything that I'm like, yeah, the original was better. I'm like,
Right.
oh, she sang it better.
They're saying
love
don't let her
Chris-
cover your song because
Yeah.
It'll make you look like crap.
I love her Christmas album.
So, well, anything she does.
Anything she does.
But she, so over Valentine's Day, the Nevada Psych Association has their annual conference. And my birthday is on February 20th. And so last year we combined that in the Tiffany flew out and we just spent 3 days together in Vegas doing all the things I never have time for at Elevate or anything like that. We saw Adele and everything, but Tiffany couldn't come out this year. And then like the week before the conference, I got an email, pre-order tickets for, pre-sale tickets for Kelly Clarkson residency starting in July. Like, well, okay, well that's after Elevate. Tiff, what do you say? Late birthday, early anniversary trip? And she's like, sure. I bought us the tickets for Kelly Clarkson, booked the flights, booked the hotel. Like, I can't wait.
That's awesome.
It's gonna be so much fun.
I want to go. I know other people have done this at Elevate, but I want to stay and go to the Sphere.
Yeah.
I really want to experience
Absolutely.
that.
I haven't seen an actual concert in it, but I saw the Postcards from Earth in it, and it was unreal.
Amazing.
I mean, just incredible. The sound, the picture quality, it's 100% worth it.
I'll be right back, and then we can kind of look at the script. Nothing. It's all easy stuff.
Yeah, when I was at the airport leaving Las Vegas,
Gonna make you up
last
real
year,
fast.
people were talking about the Sphere. They'd been to concert. There was some like Grateful Dead concert
Oh, yeah.
there that same weekend of Elevate, and yeah, sense about it were like, yeah, it sounded like
That's
it.
like the ideal one if you're into the Dead, like Jonathan
Yeah.
Meyer is. Then, because you've got like 270 degree around you, the highest quality video you can imagine, the sound.
Main room by
They
the
actually
kitchen now.
have the ability to calibrate it that every seat gets perfect sound. The tour that we
Was he
did
in the
of it,
shadow?
they demoed
I just
it
walked back
outside,
looking for you.
where
Can you do just a
stand
quick
in-
touch-up
there's
for me?
6 different lines, and if you stand, you just hear all these if you're not on one of the lines, you hear just like a garble of different speeches. And then if you stand in line 1, you hear English. If you stand in line 2, which is just 3 feet away, you hear German. If you go to the line 3 feet to the right of that, then it's Russian or whatever. And it's all playing at the same time, but they have it so precisely targeted.
Wow.
So that was to show you that that no matter where you are, your seat is in the Sphere, you're getting the perfect sound.
Wow.
It's mind-boggling. Mind-boggling.
That sounds pretty amazing.
Yeah, so Jonathan's been to the Grateful Dead one, I think 2 or 3 times. Huge Dead fan.
I never got into their music myself.
Me either.
I was into.
This is smooth. Yeah, last year. I just think they have it down now. Like that, it just seems.
I think I was in the Grateful.
Because this is second year,
Grateful
right?
Dead for like one summer because
Here,
the
yeah.
guy I liked was into it. So
Oh, yeah.
I
And
was
this is
like,
just
oh, I'm
moving-
gonna like the
moving
Grateful Dead, and then
super
I stopped
fast.
liking the guy, and I was like, yeah, I don't.
Yeah, that's kind of how it goes.
Although sometimes it sticks. Like I also have a pattern I think of liking music for
Easy.
the guys I've liked growing up, and so the
Sunday
Beatles.
morning.
I liked. It was like this guy. I liked.
Okay, freshened up and ready for round 2, people. Thank y'all for making that so easy, Andrew, Julie. Oh, so good.
Yeah.
Thank you, babe.
Some of them
Thank
serve
you.
a purpose. The guys we meet.
Yeah, some.
Okay. I'm ready. Did y'all check the
Not
Beatles,
you,
that's-
Craig. Not you, Craig.
Exactly. I'm your forever music friend.
That's right. I like to say that I have I had my first marriage, and then I have my forever husband now.
Uh-huh.
So
Yeah.
Exactly.
Me too.
Same. I mean, not a husband, but
Yeah.
similar concept.
And my husband has fabulous taste.
No
in
worries.
music. He's broadened my horizons that way. Yeah.
Hello.
Hello.
You better watch those boots.
I
when they
know,
take 'em.
because
Oh, look at I feel like we're matching.
I know, I love that. It thinks
Yeah.
what about the pink?
Energy.
See, the good thing though is being sick just puts a little Kathleen Turner in your voice.
That's right.
Yeah. Andrew used the word sultry. I'm like, I'm not really going for that. told Randy, I said, I sound like a 65-year-old alcoholic who smokes. And then Randy goes, no, maybe 50. I'm like, okay,
Good comeback.
smarty pants. Smarty pants.
Randy.
Oh,
He's funny.
every now and then he comes through with the
Yeah, let's do that real quick. Obviously, nobody cares about what I'm going to say, so just, I mean, I can do that. You just skip down, let them see kind of the. So, Craig, I'll just start with you. That's what we'll do. So, really, this first part is just about self-disclosure. Which should be the same thing for you, bringing self-disclosure into the practice. How do you balance true authenticity? Yeah. And again, crosstalk, always Vanessa. Here we go. Good. Oh, let me just see real quick. Okay, so then I'll just come back to the camera straight on. Okay. Blah, blah, blah. You can scroll down. Shift to the theme of hope. This last section, really, Vanessa, it's kind of what we were just doing. Ushmi, I'll start with you. In the midst of all of our patients' struggle, how do you offer them that? Again, Craig, self-disclosure to instill hope. And then Vanessa, for you, in your own journey, inspiring other people. And then I'll close it. Oh, no, sorry. There's more. Sorry, that's not the close. So right here, yeah. So this one's super easy, you guys, just about. See, it's doing it again. That's so weird. I really thought I was having a seizure.
Yeah, I apologize. I don't know why.
I know, it's weird. Yeah, that is the closeout. That is the end. So really just about self-disclosure. And again, if any of those don't sit well, even in the last one, I didn't ask Andrew about academic training because your thing was so perfect. So I may switch it up a little bit, but it won't be anything that you'll be like, what is wrong with her?
Yeah.
Questions
And we
are
can
okay.
talk to each other too.
Yeah, I like that.
I was trying to think because I hadn't seen the questions before. So
Right.
what I was thinking about saying the first one is kind of subsumes the second one. So I'm trying to. Can you scroll down to where? What is the first question specifically?
Right here. Keep going. Keep going. So Craig here. Just talk about all the multiple roles.
Yeah.
And self-disclosure can be part of that balancing act. Like how much do we tell, not tell a patient about our own experiences, and how do you navigate that boundary? How do you make decisions around how much is enough? Kind of what's the sweet spot on self-disclosure?
Right. I mean, I was thinking, okay, well, I'll say something about how usually it has to be to serve a purpose, and it's to let them know that they're not alone. And then that's exactly what the second question is. How do you instill a sense of hope and let them know that they're not alone? So that's what I'm trying to figure out is what do I say different between the two?
The questions were slightly redundant, I think, this time.
So can we go down, Dan, to Craig's second question? And sure, right here.
That's good in this camera.
So how about if we just take out the second part?
Yeah, just freestyle some question.
Yeah, so
Because I mean,
self-disclosure
you're so
and
good
instilling hope.
at figuring, at knowing where the conversation has been and putting in ad hoc questions. Just because really, this is exactly what I was going to say in part one. Is that my patients always say like, well, you don't understand because you've never been through this before. And I say, well, actually, I have been through this type of situation before, or something like that, and let them know that I understand and that there's hope because I got through this, and I do use that to not motivate people, but to help them feel like that they can get through it.
How about this, Craig? Let's just switch it. Instead of asking about about a patient-clinician interaction, I'll ask you as a mentor to new clinicians in your practice or to other speakers, how do you use self-disclosure to instill hope and help train and educate? What about that?
Okay.
Because we have so many people listening in who want to be. So,
okay.
Does that work?
Yes.
Okay. Dan, can you just, on this question for Craig, can you take everything out and just say, as a mentor and teacher, how do you use self-disclosure to really inspire people? How's that?
Sounds good.
Look at us.
See?
Okay,
On the fly, people.
great. And you don't think that takes the conversation into a different direction too much? I'm just asking. I'm not saying I think that way, because you're asking me about patients, which is where I feel more comfortable, I guess, talking.
Yeah. So we'll stay with patients. What I'll say is, you know what, Craig, let's switch it up just a little bit and let's talk about peer-to-peer.
Yeah.
How about that? I'll just do something like that. That way it'll make
Yeah.
it clear that we're demarcating it.
Yeah.
And, okay.
That sounds good.
And then can you scroll down one more? I think, Craig, that's the last thing. No, Vanessa, then. Oh, and then I can say, okay, so now
So we go
let's
from patient to peer to
advocate.
Yeah.
There we
see,
go.
Nice.
Brilliant.
see, we made it even better.
Yeah,
It's even
we
better.
did.
Thank you, people. Thank you, peeps. Okay. Thank you, and it's soft and cushy.
Oh,
It's kind
and,
of like yours yesterday. How soft
Yeah.
it
We'd just be
was.
looking at
And the
main
color.
camera main
So,
Yes.
whenever our host is
or
looking at
ourselves.
Maine, look at Maine.
Okay.
She's asking you questions.
Yeah,
Look
yeah.
at each other. Okay?
Okay.
And then never look at the side
Never look at
cameras.
the side cameras, and don't stare at this too long. We will see you stare.
Yeah.
Oh, I'm never gonna look at the
And
front.
I may, like if I'm looking at you, Craig, I may sort of glance there, wish me the same thing, right?
Okay.
So just ignore my eye movement.
And so, I'm sorry, when are we supposed to look this way?
Anytime that she's looking in this direction,
In the open.
Probably just like the opening and the
Yeah.
ending.
always on camera in that regard, right? So always keeping an upward face, always looking like attentive. Okay. Good.
And then just one note, they'll have the camera at 15 minutes. So obviously talk as much as you want, just be cognizant of as it start, you kind of know what we're gonna do and yeah,
Perfect.
That was for me.
I will count you in. And rolling.
it's not for you.
Harrison, watch your head.
Be fine. When I go one, that's when you hit it. Okay. Ready? 3, 2.
Happy Friday, everyone, and welcome to day 2. Today's agenda, it is packed with meaningful topics, so grab your coffee, settle in, and let's get started. If you weren't able to join us yesterday, let me quickly introduce myself. My name is Dr. Sandra Jan, and I'm proud to be part of the Psych Congress Steering Committee and our Psych Congress family. I'm an adjunct clinical affiliate at the University of Texas at Austin School of Nursing, and I also have a private practice in Dallas, Texas. I am thrilled to be moderating this regional meeting. If today is anything like yesterday, we're in for another fantastic day of learning and connection. Now this morning, I am here with my wonderful colleagues, Craig Chepke, Mushmi Mukherjee, and Vanessa Joy Walker. Welcome, my friends. So glad that you're here with us today and for this morning's roundtable discussion as we kick off day 2. So, Craig, I want to start with you this morning. I know that you wear many, many hats.
That's right.
Clinician, researcher, mentor, all sorts of things. But as I'm thinking about the work we do, another hat sort of pops into my head, and that is how to make decisions about self-disclosure. I don't think that's always an easy decision, but I'm wondering, in your work in all those roles, but particularly with patients, how do you make those decisions around what's enough, what's just the right amount, when to, when not to self-disclose?
Yeah, I think that's a really good question, and it's really important because when working with patients who are struggling with mental health challenges, they often feel just so alone. And I can't tell you how many times I've had patients say, you know, you wouldn't understand. You can't understand unless you've walked a mile in my shoes. And those are the times where I think it's important for myself, I'll just speak for myself as a clinician, to offer some self-disclosure if I have had an experience that falls along that route, because I want them to know they're not alone. That I have been through something. I do understand how bad it is, or I've had a family member who's gone through this, and that it's okay. I understand. I can help you through it, and there's hope that if I got it or got through it, or my family member got through it, then hopefully it inspires hope in them that they can get through it too, or at the very least, I really truly understand in a way that they didn't think I could, and it helps to level that imbalance that we have. But there's always a power imbalance with a clinician and the patient. We work to try to equalize that, to really walk alongside of them, and I think self-disclosure is a way that we can help to do that.
I like that. And it's something that we're really not taught in training. It's sort of like that's a no-no, don't do it. Yeah. But I hope in our conversation today, we'll kind of touch on exactly what you said, Craig, that sometimes it is useful. It does allow for a greater connection with our patients. So let's continue the conversation. Bushmi, how about for you? I mean, I know in the work you do, self-disclosure has to be something that you also sort of are very observant of. How do you make those decisions between true authenticity, connection, and when to not go there?
Yeah. Yeah, I'm so glad you're bringing it up because you're right. We didn't talk about it in my training. And so this was something I really had to play with in my own practice, and I made mistakes and I learned from those mistakes. There's a tenet that I learned in psychedelic assisted psychotherapy, which is an acronym called WAIT. Why am I talking? So I've been applying that. When I am listening to a patient's story and something is bubbling up in me, some resonance or a memory is coming up, I'll play with it inside and I'll wonder, okay, can this be useful? If I bring forth my own experience, will it serve a purpose? Will it bridge a connection? But it, or it could backfire and it could make the patient feel unseen, or somehow I might also be, I'm making an empathic guess and I could end up being wrong. So I sit with it and I wonder, and then why am I talking? And then if I feel like, yes, there is some benefit to my bringing this experience forth, then I will share. And what I find is that with time, I have gotten better at making accurate guesses. I think you're absolutely right. You use the word authenticity. Patients know when we're being authentic and when we're not. And I have definitely had times when I've said to a patient, oh, I understand, oh, wow, that must be so blah, 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 or I understand. And they're like, no, you don't, And so I've had to really pull back and be very thoughtful about when I offer some empathy and some understanding. I find that when I made the right choice, it feels like it moves the therapeutic relationship forward. And I can see it in the patient's body language. Sometimes I see some softening in their body, in their nervous system, like, somebody gets me. And that's lovely.
Beautifully stated, beautifully stated. I'm gonna take away WAIT acronym.
Yeah.
I love that. As still talking. Brilliant. Vanessa, let's turn to you. I mean, you're wearing another hat. You're, in addition to all the ones we've already identified, you're wearing the hat of a person with lived experience. I wonder, in terms of self-disclosure, a lot of it for you is all about self-disclosure and telling your story, your journey, the ups and downs. Would you take a moment and speak to us, like, what is that like? Do you have to kind of gauge how much is enough, kind of like you were just talking about? Yeah. How is that for you?
Well, it's incredibly sobering and difficult. I mean, anytime you have to go into a room with someone you don't know very well and share with them the most intimate details of your life, sometimes the most hurtful, harmful things that have happened to you. It's scary. It is disarming. It creates uncertainty. And it's strange because it's something that we have to do, but as someone who struggles with severe anxiety and panic, it actually makes severe anxiety and panic worse. So and yet it's a part of the process, right? And that's you know, yesterday we were talking about motivational interviewing and this whole idea of self-disclosure and creating this trust in this zone of empathy. And that's why that is so important, because it creates the space so that I can enter in and feel safe to share anything. And that's ultimately what you want, I think.
Yeah, absolutely. I mean, my guess is that's what we want when we go into healthcare for whatever reason, right? We could probably spend another hour just talking about not only not so great experiences, but really good experiences. And you know, there was something yesterday, Vanessa, we were talking about that, I'm just going to comment on it briefly because it was so powerful. And it was about, as we're learning about different things as clinicians, what you said, growing into it, getting better at it. When we reflect on times when we've not done a great job, that we really elicit self-compassion, that we can be forgiving, that we're sort of in the next best version of ourselves and growing. So these are just possibilities, because we don't want our viewers to feel like, oh, I'm not doing this well. But this is really an opportunity to learn from all of our experiences. So thank you for sharing all of that. And I love hearing about how each of you is navigating this topic of self-disclosure. You know, it's a powerful reminder that it's not just the stories that we share, but it is the intention behind them, which is what we've each commented on. And so doing it, when we really identify the intention, we are fostering exactly what we said: trust, connection, and ultimately hope. So I want to shift in the last few minutes to this theme of hope. And we all know how transformative hope is in the healing process. And I'd love to hear from each of you how you're doing that, how you inspire hope in your work with your patients. So, Mushmi, let me turn to you and ask you that in the midst of all the chaos, the crisis, a lot, Vanessa, of what you were describing of when you go into an interaction with a clinician, how do you do that? How do you sit with them and really instill hope? We'd love to hear what that looks like.
Wow, it's such a great question again. I mean, it's all about hope, isn't it? At the end of the day, if a patient doesn't feel hope, then what point is there? Ironically, my practice is called Hope. So, pulling from my psychedelic-assisted psychotherapy training, there's the understanding or the belief of the inner healing intelligence. And I think of that as just the organismic thrust towards healing and recovery, the way a plant will grow towards the light. I think everybody has that capacity. I think that's inborn. And so I try to access that with my clients. It sounds kind of esoteric, but I point out to them where they're actually showing me resiliency. Because so often we get so focused on what's going wrong or what's pathological. And frankly, we've been trained to focus on what's pathological. But when we take a moment to step out of that paradigm, and we do need that paradigm, it serves a purpose, but when we take a moment to step out of it and notice, wow, you know, when you're telling me about that conversation that you had with your boyfriend, and look how this time you didn't fall into the same trap that you had last week. You actually approached it in another way, and you got a different response. You got a different outcome. Wow, look at that. That's you learning. That's you changing. That's you growing. And that kind of validation of change, of small processes of change, of small wins, I think, really helps inspire the patient, and then helps them to see their own capacity.
Yeah, that's absolutely beautiful. I love that your clinic, your practice is called Hope. I mean, that is spot on. Yeah. Craig, if I could, Mushmi was talking about instilling hope when we're working with patients. But I wonder, let's go back to one of the hats that you have worn, that you still wear, and that is as a mentor, as a teacher, maybe to a new clinician who's come into your practice, or maybe you're just consulting with someone in your community, or maybe even to someone who's an inspiring speaker and teacher. I wonder, how do you instill hope in that setting, peer to peer?
Well, I think I'll echo a lot of things Mushmi said. It's all about hope. And so one thing I've always said is a kind of a catchphrase is that the most important thing we as clinicians give to patients are not prescriptions, it's hope. And I think if you center everything around that, then it kind of flows from there. And I think self-disclosure about my journey. I started off as just a clinician who paid to attend Psych Congress and then was asked to be a faculty member and then to be on the steering committee and then scientific advisor and director. And that if you put yourself out there and you find connections with other people in the community that you want to be a part of, that great things can happen. That we need to be able to inspire each other, and we need to connect with each other, and people will recognize that and opportunities will come to you.
Yeah, and it's so interesting in that setting, Craig, being able, self-disclosure about your own journey really is a source of hope and inspiration, which, to go back, that's what it's all about, that we all have that sense of, hey, I can do that too, that's possible. Just love that. Vanessa, let's go back to lived experience, because that's your unique hat in the conversation today. Can you speak a little bit from the advocate and teacher perspective, how hope plays a role when you are speaking with others?
Well, I mean, I think that we've all said it. It is the role, right? I mean, it is what secures everything. I believe that we have two options in life. We can either be hopeful or remain hopeless. And I often will share with individuals that there's no in between. And I learned that from experience. And when you choose hope and you turn yourself toward hope, your circumstances may not change, but the way you interact with them does. And hope is something that is unique to everyone. So I encourage people to not only think about hope as this, like, oh, we need to choose hope, but where do people place their hope? Because different people place their hope in different things. Some people are religious, spiritual. Find that out and then lean into that and help the people that are around you. I try to help the people that come to me, new advocates, other patient speakers, to say, where do you find hope? When you turn toward hope, what are you looking at?
That's a great question. When you turn towards hope, what are you looking at? I love that. Well, we are right at time, and I want to thank all of you for sharing beautiful insights and your wisdom. Self-disclosure, it's deeply personal, and it's a nuanced part of what we do. And I'm grateful for all of your reflections today on how it shapes connection, hope, and healing. So I'll see you three again at the end of the day for our closing roundtable discussion. And to our audience, stay with us. The first session of the day is about to begin.
Fantastic.
Yay, you guys are awesome.
You're awesome.
This is fun.
Exactly, that's why I always think, like, you're awesome. Like, you're the glue that holds all this together.
Yeah.
So
we
good.
just danced around you.
Yeah, really.
It gives me goosebumps. Love you guys.
I also love this, I mean, I've heard the phrase before, but just in this application of plants growing towards the light.
Right.
That was like, oh, wow, that's so good.
Yeah.
I have to admit that I can't take credit. The psychiatrist I work with, it's his idea, and he's developed a model called Hope. Yeah, and that's part of it's really a nice visual, isn't it? And it's true.
Yeah, exactly.
And it's true.
It's true.
Yeah.
And the psychedelic work. Oh, it just shines through.
Oh, and why am I talking? Oh, I'm taking that one back too.
Yeah. Why am I
What a,
still
what a,
talking?
what a phenomenal acronym. Just wait.
But really, when we
Why
were
am I
talking
talking?
yesterday, about, I mean, the other roundtable about, oh no, Julie and I yesterday on anxiety about, we got to check our own anxiety.
Yeah.
Yeah,
That
yeah.
just like feeds through the energy, and then we're adding to it, and oftentimes that comes across as
Exactly.
And our own biases. I mean, we talk a lot about that when we talk about sex. You know,
Yep.
I mean, you knew
Of
I was
course,
going to
you
bring
knew
it
to
up.
bring it back.
You know, you knew I was going to
Hopefully
turn it.
you're
I was
still
going to bring it
rolling,
up.
'cause this is great behind the scenes.
You know, but that idea that I always say, like, if it's okay if you're not comfortable talking about sex, but deal with that in your own therapy session. Don't bring that into the session with your client,
I'm
because
gonna get some hot water.
they
just real
will
quick.
sense
I'll be right
if
back.
you're
I know we're
uncomfortable
pushing
talking
time.
about sex, talking about sexual wellness, talking about anything. If you're uncomfortable with talking, it doesn't matter what it is. I use sex because it's something that often people are uncomfortable with.
Yeah,
And,
just one more to go.
You know, you and I have had these conversations many, many times.
15 minutes.
And so I just, you know, I always say, like, you have to check yourself.
You do.
You have to know, where are my biases? Where are they?
Yeah.
Lipstick look okay.
And,
Sure.
For some reason, super dry.
and it's okay that you have them.
Yeah.
They're super dry.
We're human.
Yes.
Right? We are.
Maybe that's
Yeah. You know, in that question about
okay. I'll
self-disclosure,
put some of the gloss on
one
top
thing
that
I'm
I've got in
starting
there.
to do
And
is
we'll
also
call it
say,
even. Thank
I actually
you.
don't know what that
Hey,
feels
Kevin.
like. You know,
How are you?
And
Better today,
I'm trying to understand, or I'm bringing in.
That
I
sleep
just want you to know
magic.
that I'm trying. I'm
Feel
thinking
much
about
better.
this. That I went through this, and it's not the same, but it understanding. I think Craig, you kind of alluded to it. I don't think there's anything wrong with actually saying, no, especially if you're asked. You know, no, I don't know, but I'm trying to understand. You know.
Yeah, one of the things we, like, in the, like, because I've done a lot of motivational interviewing training, and one of the things that, you know, in the work that I've done is we talk about, like, asking permission, right?
Yeah.
To share something.
Yeah.
You know,
Definitely,
you know, I thank you so much for sharing that experience. I have an experience that isn't the same, but would you be open to me
guys ready to
sharing
knock it
something
out?
about my personal life that I think might resonate with you?
Yeah, perfect.
It's
Thank
just
you.
asking that permission
Yeah.
creates an environment of trust.
Yeah, for sure. That's
Okay.
a great point. That
You guys-
permission taking.
Yeah, I think they're ready for us to go. Y'all want to just quickly look at what we've got?
Oh yeah.
No, you're good.
So we can rewrite it.
Yes, no. So I'll do an intro. This, what inspires us, what fuels your passion, excitement, blah, blah, blah. Wishme, I'll start with you first. What excites you the most about your work? Vanessa, meaningful perspective to our conversations. What drives it? And then Craig, for you.
Should I say vagina?
Well, I'm going to leave that call to you, but
What inspires you? Vaginas.
yeah,
I haven't said it once, so.
well, I'm going to leave it to you.
Okay, thank you.
Oh my God.
And then Craig, obviously.
Would somebody bring me a tissue?
Sure thing.
I'm sorry.
What about,
I
are
have
we
this
going to
rhinitis
say what
that-
inspires you?
I could. And then we'll wrap up the evening with one word that speaks to our passion about caring for patients.
Okay. Thank you. I appreciate it.
Everybody good?
Yeah.
One word that speaks to you. Okay.
What did I say?
I don't know. I was reading it and I was like, wait, why does it say what's your word?
Oh, one word. Oh, yeah, what's your word? What's your one word?
You need another one.
Thank you.
Thank you, that's a good catch. I did it on all of them. And your word? Word. That's all I'm going to say. When you go, what's your
Word.
Sandra? Word. Oh, my
vagina?
son would just, can I say vagina?
Yes, there you go. That's
If y'all haven't noticed, Vanessa has a theme.
Yeah, sorry. I apologize in advance for my.
His body.
All right, let's roll cameras.
well. Actually, can you scroll down
Yeah.
to the last to where Sandra asked me about the one word?
Oh, sorry, Craig had a question.
Can you scroll down to the where Sandra asked me about my word?
What did I say?
Okay.
You're the first one, Craig.
Actually, I would want to make passion the word. So can you use a different word other than passion?
Oh, I see what you're saying. So let's wrap up this easy one word that speaks to your excitement.
Yeah, perfect.
Can you just change that to excitement? Yeah. And if I don't get it right, just say, interestingly, it's the same word as you just used.
Yeah, I was thinking that too.
Just in case, that way we don't have to redo it. Okay.
Cool.
And Dan, I think you're scrolling, so thank you. Giving me a little bit of heads up about what's coming is awesome.
You're good. I'm a good scroller.
Exceptional.
Good. Count you in.
Okay.
Ready in 3, 2.
What a wonderful day. I want to take a moment to thank today's faculty for their outstanding presentations and the lively Q&A. It has been a privilege to hear from so many experts, and I hope you're walking away with new tools, new perspectives, and a renewed sense of purpose. I'm excited to be joined again this evening by Craig Chepke, Mushmi Mukherjee, and Vanessa Joy Walker to share some final thoughts. So thanks to everyone for being here, and let's get started. You know, I'm curious about what inspires all of us in this ever-evolving field of mental health. It's always changing. I'd love to hear from each of you about, well, what fuels your excitement for the work you're doing? And let's do this. Mushmi, let's start with you. What really excites you about the work you're doing?
Oh, wow. A lot of things, I would say. Just the fact of always learning, always growing, always evolving. I mean, my own healing has come a long way. I heal along with my patients, you know? So, yeah, I think what really makes me passionate about the work is that I'm seeing the healing intelligence we all have in action as humans. So
I love that. As you talked earlier today about that internal healer, the plant turning towards the sun, it was this sense of this light that we all carry, that we become a reflection to our patients and them to us. And that is, I mean, that is excitement at its finest, right?
It's vitality and it's joy.
Oh, it's all of that. And a bag of potato chips, I think is what we say, right? Craig, how about for you? When you think about the work you do day in and day out, we talked earlier about the multiple hats you wear. What are you most excited about?
Well, I'd go back to what we talked about this morning, hope. Hope that there are new treatments coming out, new research that can help us to understand what's going on for people better, that we can, for me, being a mentor to up-and-coming clinicians, that hope that the next generation is going to be even better than I was at helping people. And being a part of being able to facilitate all of that is just incredible. I'm always looking to the horizon of how can we make things better, and there are better things coming, and trying to be progressive about that. That's what it gets me up every day and gets me excited to put on all those different hats throughout the day.
I love it, Craig. And even as you're talking, I bet you guys noticed this. Your smile got bigger. You just got excited as you were sharing it.
Exactly.
So it's just so authentic.
Well, and I just hope that it's contagious to people that I work with, whether it's a patient or a mentee or anywhere. I want people to also be excited about what we're doing, because that's the best antidote for burnout, is to be excited about the work that you're doing.
Yeah, beautifully stated. Vanessa, you know, you bring a level of, you just enrich the conversation in a way that we alone cannot do. And I wonder, for you, with all the hats and the added hat of lived experience, what gets you excited about the work and makes you want to get up in the morning and just keep on doing it?
I mean, sometimes I don't want to get up in the morning. I keep on doing it. I'm just going to be honest with you, right? So sometimes it's not a feeling, it's a choice, right? It's understanding that there's work to be done.
Yeah.
You know, I didn't wake up one day and think to myself, boy, like, I really want to sit on stages and talk about my trauma to help people learn more. That's not, I didn't grow up wanting to do that. But what I realized at some point in my life is that all of the different things that I was good at were coming to intersect at this place of sharing my own lived experiences, as well as interacting with the advocacy world and being able to really participate in clinician-facing education. I've spent so much time with doctors over my life, so much time, and so many great experiences, and so many not so great experiences. And it's not because the clinicians or the people that were serving me are bad people. It's often because they didn't have adequate training. And because the patient voice wasn't included in the training they were receiving. And so what inspires me today is that. It's being able to be a part of things that really I know that there's some clinician out there, some provider out there that's going to take something back to their patient, and they're going to have a better relationship. And that's going to help that person. And that brings me joy.
Really, it's why we do this work, right? I think about what gets me excited. You asked me about this earlier, Vanessa, when we were chatting. And it's conversations like this. It's being with my colleagues and my friends, like-minded, like-hearted people who want to make the world a better place. Right? And I feel like that is what we're doing, and that's the fuel that keeps the engine going. But again, I'm going to end on, before we end today, we're going to talk one more little section on this, but what you've said consistently in the roundtables, Vanessa, is about as we as clinicians do this work to practice that self-compassion, that we can't do it perfectly. And you just illustrated that so well. Like some mornings I don't really want to do it. Right? But it's a choice. And when you said that, I could feel both of you guys, our bookends, you really confirmed, oh, I've had days like that. I've felt that. So thank you for keeping all of us grounded in both sides of that story.
And it's okay.
Yeah.
Right?
No fail.
Like it's okay. If you wake up one morning and you're like, man, I do not want to get on that Zoom or sit in that chair today. That doesn't make you a bad person. It doesn't make you a bad provider. And it doesn't mean that you're not going to provide good care that day.
Yeah.
The fact that you are acknowledging it is the most important thing.
Yeah, it's what we've been talking about, that self-check, self-checking our own energy and what we bring to these interactions. Yeah. Well, let's do this. Let's wrap up this evening's conversation with one word. So I'm going to give you just a little minute to kind of think about what your one word is that really speaks to this excitement about caring for our patients. So give you just a little bit of a minute. Craig, I see you're thinking, the wheels are turning. I want to start with you.
Sure.
What's the one word that describes it best?
I think my word would probably be passion. And for instance, if someone has a particular issue, actually a great one is tardive dyskinesia. That for a while, I really didn't give tardive dyskinesia in my practice the level of commitment that I should have. And then there's this one patient that turned it around, and I researched it, got up 4 a.m. in the morning and studied and stayed up late after kids went to bed, and that passion. And that, I think, means so much to my patients. They know that I will bend over backwards to, if I don't know what is going on or I don't know enough, they'll research it, I'll do the extra work. And that passion means so much to them, and it means so much to me too. And so I think that would have to be my word.
Got it. Vanessa, how about you?
I think the word is necessary. That everything that we're doing here today is needed, and it has to happen. And if we don't do it, it's a disservice to ourselves and to the people that we are serving. And, you know, I think we talk about motivational interviewing, and, you know, how much I love that so much, but it is so important because, you know, integrating this idea of really all we're talking about now is the psychotherapy, and how does this enter into the psychiatric care practice and your, you know, what you guys do, and how important that is, because you never know when the person you're going to be serving is coming in with something that is very traumatic, and maybe you're not used to having that that relationship that involves a ton of motivational interviewing, but they're going to need it on that day. You know, I shared with you earlier this year that my therapist in the fall died suddenly. Yeah. And these things happen. And thank goodness I had a psychiatrist who I had an incredible relationship with, who had built a rapport with me, who had done psychotherapy with me, even in the short sessions we had. So I didn't feel totally lost because I had someone there that could help me navigate that situation and get to a new provider. So this all is necessary.
Yeah. Thank you for sharing. Yeah. Rashmi, how about for you? What word bubbles up?
Wow. Well, I'm still taking in what my colleagues here have said. So beautiful. And I've been mulling that over, the question, and I don't want to sound corny. So I really thought about, is this my word? And the word is love. The word is love. Craig, when you got up at 4 a.m. to research TD for your client, I bet you didn't like having to do that.
Right.
But love propelled you.
Mm-hmm.
You know, love for the field,
Yeah.
love for knowing, and some experience of love for your patient.
Yeah. Kind of like Vanessa said, it was a choice. It was a commitment.
Yep.
It was a choice.
It was a commitment.
Yeah, yeah. And so I find that quality is what keeps me going, you know, because love is a kind of, it's an acceptance of what is, and it's courage. It's courage to keep going. In my presentation earlier, I talked about change and how change, it was about navigating change throughout, you know, as a woman throughout your life. And change is the only constant. It takes a lot of courage to go through life. I mean, for each one of us, no matter how easy how relatively easy our lives might be, it takes a lot of courage. It takes a lot of courage to grow and to change and to deal and to function. And so in my work, I might not like certain aspects of a patient. You know, there may be, you know, I may be the recipient of some of the transference or whatever. I might not like that. But what keeps me going, what allows me to overcome my own personal, like, human reaction is love, is continuing love for that person's healing. When it comes to medications and, you know, new treatments and new psychotherapies, for instance, it's love that prompts me to keep learning, to keep, you know, to tell my husband that I don't have time today to go do something with him because I'm taking a class today, you know. We make choices all the time, and I feel, you know, when we're making our choices from a place of love for what we do, then those choices become easier to make.
Mm. Well, that takes a moment just to breathe all that in. And it's interesting, I wish we had a chalkboard and we had been documenting all the words, because love, courage, choice, necessary, commitment, passion. It's sort of all of a sudden this beautiful, rich soup with lots of great ingredients. I'll throw in connection.
Yeah.
And that's what this feels like, that we are really connected in service to the betterment of other humans and ourselves. So thank you all. It was absolutely beautiful. Yeah, just beautiful. A pleasure, as always, to share this experience with all of you, with all of our attendees who are with us today. I want to thank you for spending your time with us and sticking around through to the evening. But sadly, it's time to wrap up and to say goodbye. But before we go, I want to express our heartfelt gratitude to everyone who joined us online. I hope you're leaving with valuable insights, practical takeaways that you can start using right away in your practice. Please don't forget about those credits. Claim them for the sessions you attended. And if you have any questions, you may have feedback, comments, you may have concerns, I want you to know our team is here to help. So please use the help desk feature that's available both here and on the credit claiming site to contact the Site Congress Regionals team. We truly value your feedback, so please don't hesitate to share your thoughts. Wishing all of you a wonderful weekend, and we'll see you next time. Take care, my friends.
And cut.
Very nice.
So good.
You just need your own talk show, Sandra.
I mean, how hard can it be with you people? It was so good. It was so good.
Yeah.
Honestly.
This was like the special after-school special one. It was like that.
And I'm really proud of you. You didn't say vagina once
I did
throughout the
not
whole
say
recording.
vagina once.
I know. I could tell.
I did think it,
bet.
but I did not say it. It wasn't appropriate.
Next time.
If it
always
was,
next time.
if it was appropriate, if there was a time where it was appropriate.
We should have done like a blooper take of where we come back in. We're really doing it. What's your one word?
Vagina.
And then straight face, say vagina.
Right. Oh, sorry.
Just
Yes.
to use internally.
Right.
So funny. You know, and I would be like the 12-year-old, like we're doing a panel discussion. She'll say vagina and I'll start giggling.
Oh my
Like I'm 12.
Well,
I'm sure I would.
We're
I'm just
gonna,
saying.
We're gonna do a session at.
Don't say we, like including me,
No.
please. Is it about vaginas?
It is.
I'm not
We're
doing
gonna do a session at Elevator.
Vagina's with Sandra.
Oh, it's the pillow.
That's your. That's
That's the new show.
That's your talk show.
Yeah.
I mean, it could be part of like the women's mental health,
That's right.
you know,
Oh, for sure.
outpouring of
so don't jerk off or anything. That's where Patrick wants you. Okay.
I'm gonna mic you up. Yes, sir.
And then you'll be driving the show here.
I will be driving the show, even better.
You want Brooke in the center by you, or where do you want Brooke?
Wherever Brooke likes to sit. Brooke, you want to come sit to my right?
Sure.
Got it?
Always look at Brooke.
Always look at Brooke. Good attitude. Would you give me control of the slides, please?
I'm really glad I didn't wear my plaid jacket. Otherwise, we would look like we would start looking
the plaid crew.
We'd start looking like a mismatch, like dormitory, frat house dormitory. Rumpus.
That would have been awesome.
No, they put me on my pants.
Yeah. I actually just made
Mhm.
a suit. This week.
Oh,
It's
thank you.
Purple gray, low key plaid, but I chose not to wear it. Saving it for the next
Go.
one.
Yeah, I think
We'll hold up the we'll do the solid.
Keep an eye on
bookends.
it.
Okay.
Me and Brooke.
I like it. We appreciate it. We need solid people at the end of these two weirdos. Did you?
Yeah.
I actually no longer own dress shoes.
Really?
Which I need to get back to. Yeah, I don't. I have.
I don't
five
know that you
pairs of
need to
these.
get
I have 4 pairs of these. Exact same one. I like them so much. I bought 4 pairs, which is excessive.
No, it's like me with the Adidas.
Yeah.
The Stan Smiths. I must have 10 pairs. in my closet.
So I like a pair of jeans, so I just went and bought 5 of them. Done.
Are you doing any other impulsive activity?
I'm one of the
So
cases.
this is, I was going to say, so this is introduction to the
Now
case.
let's talk about the moderator.
You know where this goes.
There's no.
Excuse me, oh my.
How do you feel
Oh,
about
this is going to
Vraylar?
be fun. I like it a lot.
Would you like some?
Or do we need to increase your dose?
I'm gonna give you 2 doors. One is Vraylar, one is Flat. Choose your doors.
There's one here, but it might get a little bulky again. You want to just put it in
Yeah, I'll
back pocket or something?
Tighten up some of the slack.
Are you worried about Caplyta being delayed just because of the new FDA? Or there's
All
not
good?
much concern on your part?
It could be.
Because it's atypical
Could
for a major depression,
Could be.
and that's what he's going after.
Well, for me.
It's all right. Is it the wrong one? Maybe the packs.
In my humble opinion, yes. But
Well, it should, because they're gonna look that way, so it should be on this side.
is that
That's the reason. So when you put it on him, now it's on the wrong side. So if he's talking this direction,
Yeah,
So this needs to be over here?
Yeah.
let's swap Greg and Rakesh, because your jacket is blending very, very much.
See, I did it at the right
Our
way.
navy wall.
All right,
that,
sorry.
Got it.
Ah.
So
who do you
who's
want- where do you want
swapping
us?
what now?
You and I.
you and
Okay, okay.
Oh,
or, I'm
no.
sorry,
Oh, do you want me to put in,
Or Andy and I?
Andy and Rakesh. Sorry.
Andy,
should
who's
switch.
Andy?
where you are.
Andrew.
Andrew, yeah.
You and I should switch.
I have no idea. Is it, are we switching? Okay, yeah,
Okay.
okay.
Yeah, the navy does
Pardon me.
sort of blend a
It
little.
was nice
Excuse
knowing
me,
you.
yes. Take care.
All right.
Take care. Take care now.
this to your other side?
Oh,
Side. Sorry, you okay?
I'm okay. That was a good one there.
Wow.
But now that microphone works.
Oh, yeah.
That worked out.
That sorted itself out.
They said you looked like you were popping right out of the wall.
Oh, well.
It's like when you were something in green in a green.
Yes, yes. The green screen thing. Like there was that dress that the Queen would wear that was that green screen color, and people would do all sorts of antics with it.
And I'll be turning more to my right, so you're going to be shifting this, okay?
Yeah.
Now we're leaving the cable across your chest.
Hey.
This is a
It's a
pocket
good
bed
look.
too. All right, we'll
The
put this
superhero.
to your
My hip?
jeans.
Okay.
Yeah. Excuse me.
Ron. Brooke, any fun marathons or things coming up?
Let's see, what's our next one?
When you said we'll just make sure that the wire is.
Okay.
We're doing the Cincinnati Flying
Thank you.
Pig in May.
Is it a half or a full?
So,
Half.
is
You do
there
mainly
any
half.
way you can take the timer
Yeah.
and put it there?
Halves are better on your body.
I do too. It's just, in the training's just too hard to put that much. It's hard enough getting the timing
I won't
in.
have to turn that because this is my camera.
Yeah, so you will always.
You know, if a half, you keep yourself in decent shape.
Yes.
It's not too hard on the
Yeah.
body. A full one, like you said, you're just,
Okay.
it's a lot of pounding.
Yeah, so
It is.
But I'll
and-
be
yeah.
rarely
Screens are
talking
for
to the
reference.
camera. Yeah.
These screens are for reference. There's actually a camera in here. So this, if you were to ever address outwards, you would look here instead of there.
Yeah, the only way I'll know my time is getting close to an end, because I've got 3 15-minute sections, is when I'm looking here. So that's in my line of vision.
Gotcha. Okay.
So if
What do you want us to set it to?
right, 45.
45? Sure.
Yeah. Yeah, thanks, guys. These have been extraordinarily popular, these difficult case series.
Good.
Yeah. Repeatedly getting from the audience realness, truth speaking, get it. Oh, good job.
That's good.
Yeah.
Beautiful.
All right, let's roll cameras. Audio.
And I will start here, is that correct? And then move over to, okay.
Yep.
That's really dull. Is there any way to brighten that screen the way you got these two, or is that,
That is at full brightness.
that's at full brightness? Okay.
I.e. full darkness.
I was like, damn that macular degeneration.
Good.
Good. Mark.
All right, I will count you in. I'll do a 3, 2, and I'll point, and you can start, okay?
And the timer, you will
Yep,
start
I
it
was gonna say,
right when that
I got it,
happens. Okay.
Ready? 3,
Hello, dear colleagues, and welcome to this session on solving clinical challenges. And we'll be focusing on bipolar disorder today. And as you can see, I'm being joined by 3 extraordinary clinicians who also happen to be people I've turned to in times of my own need. So here we are talking about these 3 cases with them. Brooke, welcome. Andrew and Greg. Shall we rock and roll?
Okay, great. Let's go.
Let's do this. Okay, to do that, let me first offer our audience members a full list of faculty disclosures that's present for their review. And of course, the other CME disclosures, which talk about how these slides and this information has been vetted for full ballots. Our learning objectives are to learn from you 3. And this is as real as it gets. I'm really getting a consultation from you 3 on these difficult and complex cases that I face. Though as we were talking earlier, the 3 of us, and you mentioned this, Brooke, is it really such a thing as an easy patient?
I haven't met one if there is.
Right. Yeah, I think that humility to appreciate that every human being's suffering is complicated and difficult, and we should approach it with this seriousness. In itself, clinical wisdom. Okay, first case. This actually is a patient from my case. So this is the case of the embarrassed, rageful parent. That's her description. She's a 32-year-old female, married with 2 kids, in a mostly okay marriage, I guess, she told me. Works for a large advertising company as a project manager in Austin. Now, this is our first encounter. The first encounter with us is, I'm embarrassed. How often and how easily I lose my blip, blip, blip. It's been a problem from high school, but now it's getting to the point I will lose my job and mess up my marriage. I don't mean to yell and scream and get mad so quickly, but it's like I can't control myself. This isn't me. I know something is wrong. I don't want to end up like my mom, angry and bitter and alone when I'm old. Can you help me? I'm desperate. So, perhaps if I may start with you, Greg. What should we explore in this clinical interview with our patient?
You know, obviously she's distressed. And we're all parents here. What we've learned is if you run around with your hair on fire as a parent, your kids are going to run around with their hair on fire. So when you talk about this case, you have to say, listen, taking care of yourself is even more important than taking care of your children, because you're the model they're going to learn from. So in her case, I'd want to go back in time. I'd want to go back in time and just say, let me get to know you. Go back in time. Where did you grow up? What was your family like? What was your structure like? What were you like as a kid? And then I would walk through her life until I start to see signs of distress. Maybe that was difficulties with learning. Maybe that was difficulties with emotional modulation. Maybe that was childhood trauma. Maybe that was a family that fell apart during very formative years. But I'd want to walk through her life till I saw the times when we started picking up distress.
So you're making a profoundly important point that even though she's presenting in a cross-sectional fashion, you want to be a medical archaeologist. You want to look for fossils in her history. Andrew, as you apply the lens of DSM with all its strengths and weaknesses, what would you specifically focus on exploring with this lady?
I too would want to look at a longitudinal pattern here, because obviously we're leading the witness a little bit here. This is a bipolar, we're talking about bipolar cases, but this presentation alone doesn't make anybody bipolar, right? So what I would want to look for is a pattern. I'd want to look for a particularly disruptions in sleep and other ways of looking at energy, how much energy the person has. Sleep is obviously one of the more objective ones, but just really getting a sense, is this, and also, is what she's describing here kind of a reactive pattern, or is this something that's more endogenous? Is this something that happens irrespective of external circumstances, or is this how she responds to stress?
Gotcha. So you wanting a pretty significant, deeper dive into her symptoms, but also its association with external stresses, etc. Brooke, her family history.
That's exactly what I was thinking about.
Yeah, why did that intrigue you?
She mentioned she did not want to be like her mom.
Yeah.
Tell me a little bit more about your mom. When you say I don't want to be like your mom, did she just have significant small episodes where she's responding like this, or was this a pattern? Was she like this chronically all of the time, or are we looking at what type of family history of other mental illnesses might there be? So just on top of what Greg said, looking back historically at not just the patient and how she was brought up, but what else is in that family history so that maybe I can see if there's an ongoing theme here.
Yeah, I think the three of you are alerting me to a salient fact about psychiatry, which is we're not a biological specialty. We're not a psychological specialty. We're not a social specialty. We are biopsychosocial.
Yeah.
In fact, that's the only branch of medicine I know where we get to play all three roles. So let me ask you to perhaps dive in. Is there a way to explore the possibility of a potential diagnosis of bipolar 1 or 2 disorder with her, and what pathway would you take?
So first of all, I would say that, a lot of these conditions don't run by themselves. So when I was struck by this lady, it may not be bipolar by itself, it may be bipolar with ADHD.
Yeah.
I'd go back in time once again.
Gotcha.
What were her first symptoms? Maybe those were difficulties with school and learning that were described as ADHD. Maybe as an adolescent, she started having problems with insomnia or anxiety, as Andrew said, and I couldn't shut my brain off. Very early symptoms we see with bipolar, but can also be a symptom of ADHD or depression. And then I'd want to say, have there been periods of your life where this stuck with you, as Andrew said? Is this something that's reactive to stress, or are there periods where neurologically my brain gets stuck and I can't shut my brain off? Maybe it's days, maybe it's weeks, and we know that the differential between bipolar 1 and 2 is a period where it lasted for at least a week or more, or it was bad enough I had to get hospitalized for intervention. So neurologically, my brain was stuck. I couldn't control it. Versus bipolar 2, we'll see much more hypomanic episodes, subsyndromal depressions, more rapid fluctuation, more mixed symptoms that we want to make sure we don't miss with bipolar 2. And I think we've all learned that bipolar 2 can get missed because it doesn't have that outward hospitalization.
Right.
It doesn't have the time the police got called because I was psychotic or something really traumatic happened. But I just know I'm not stable.
Yeah, yeah. Beautiful point. Which is don't just fall for the obvious. Look a little bit deeper. Andrew, Sandra has often educated us, Dr. Jen has often educated us that irritability is a symptom, not a diagnosis.
Yeah.
But as an educator, have you often seen that your students sometimes fall for the obvious trap? They see irritability and boom, here they go jump into a diagnosis.
Yeah.
How would you educate your colleagues on don't let the tail wag the dog, let the dog wag the tail?
Right. Well, irritability it's the fever of psychiatry, right? And we all know that hundreds of things can cause a fever. None of them, it's not diagnostic in any one of them. It's just an associated symptom. And so we can't there's no pathognomonic symptoms in psychiatry, right? So irritability is certainly probably the least specific of all of our symptoms that we look at. And so irritability could be depression, it could be ADHD, it could be anxiety, it could be PTSD, it could be any number of things. So, I remember when we went through a big reappreciation of bipolar disorder maybe 20 years ago, that people were using irritability as a pathognomonic sign of bipolar disorder and how that really led us astray. So we have to, I always tell my students, like, if I were to be able to mask off your vision and show you one star in the sky, you couldn't tell me what constellation it's part of. It's only when we pull back and we see the whole pattern and we say, oh, that's the Big Dipper, right? And diagnosis is the same way. So you're seeing one star, you're seeing the irritability star, but who knows which constellation that's a part of.
So irritability is a sensitive symptom of bipolar disorder, but it's not specific.
Correct.
Am I getting that correctly?
Yes.
So it should alert the clinician, look deeper.
Yes, it adds it as a possibility.
It adds it as a
But it adds a lot of other possibilities as well.
Yeah. Brooke, I've heard a lot in psychiatry that we make two types of errors, type 1 and type 2. We underdiagnose what we should diagnose, and we overdiagnose what we shouldn't. You see, that's probably in your trainees. On this case, the possibility is strong that this might be a person suffering from bipolar disorder. What process do you take in your clinic to differentiate or to include or exclude bipolar disorder? And do you use scales and screeners in your practice?
Absolutely. So I think Scales and screeners have become part of our day-to-day practice. The PHQ-9 is often used, but we should never stop there. Anytime you have a diagnosis that you feel is major depressive disorder, you want to rule out a bipolar disorder. Is it not just a depressive episode? Are we missing hypomanic episodes? Is there history of mania that the patient did not understand that that was mania? So not just the PHQ-9, but adding in a mood screener so that you can differentiate between those things. And in thinking about our clinical assessment, we have to take time. We need to spend time with the patient. We have a lot to go through. Doing a screener is a great screening tool, but it's not diagnostic. We can utilize those to kind of guide some of our questioning, but we need to take each one of those symptoms and dive deeper, identifying what symptoms that she's experiencing day in, day out, how long those symptoms are happening, and how each one of those symptoms are impacting the day-to-day functioning.
She's clearly impaired. She's distressed. She's approaching us saying, help me, help me. And would you agree with the gentleman? They both made a big deal appropriately that just because you have a diagnosis doesn't mean that's the end of the journey.
We're talking about difficult cases, and that's what's difficult. There's often a lot more to it than that one diagnosis.
I hear you. And based on the literature, an average patient with bipolar disorder has 2.5 diagnoses. So as we say in Texas, a dog can have ticks and fleas, and it's quite common to have that. In your opinion, what are some of the most common comorbidities that occur with bipolar disorder and make your task a little bit harder? And maybe you could give us a couple of pearls of wisdom how to differentiate.
Certainly. In the world that I live in, Andrew and I were talking about ADHD.
Okay.
We know 1 in 5 people with bipolar disorder will have comorbid ADHD. Those can be complicated patients. Quite often we see the ADHD started earlier in life, and then later in life they develop the mood cycling. So ADHD is something, and that's tricky. Sometimes stimulants can help stabilize bipolar when treated with a bipolar medicine, but sometimes they can flare bipolar. So we know we have to be careful with that group of patients. Anxiety disorders, ubiquitous, especially with a woman like this. I would guarantee you she meets criteria for some version of anxiety. Generalized anxiety, potentially social anxiety, maybe panic disorder. I wouldn't be surprised if she doesn't have a lot of comorbid anxiety. Insomnia disorder. And I sometimes have a hard time, Andrew, you mentioned sleep. Is it sleep that's related to the bipolar or the mood disorder?
Right.
Or is it truly an insomnia disorder? And we now know that in DSM-5, sleep disorders, insomnia disorders, the rule of threes. 3 times a week for 3 months or longer. So it's an ongoing pattern where I have sleep difficulties even when I'm not stuck in a mood episode. So I think for me it would be ADHD, it would be anxiety disorders, sleep disorders, and then finally always the possibility of self-medication. Am I self-medicating to try to fall asleep, to try to cope with my irritability, to try to cope with my anxiety? This is a no judgment zone. If I had this condition, I might be self-medicating. But we need to understand holistically what's going on.
That's a basket of pearls that you have shared with us. Thank you. Thank you, Greg.
And I would add trauma to that. I would.
Trauma.
There's not much more to add to what Greg already said, except for maybe trauma. When I saw your chief complaint there of that sort of irritability and ragefulness
with her mom,
and that raises a lot of questions for me. And anytime I see somebody who's sometimes patients will pick up on our technical language, our jargon, right? And I've had patients come in and say, I was really manic today. I say, well, what do you mean? They say, oh, well, I got a call from my partner and I was really upset for half an hour afterwards. And, I wanted to do some things. And then what happened? Well, then I calmed down. Well, that's not mania, right? That's a kind of reactivity that we see often in people with trauma, that sort of emotional dysregulation. And so one has to explore what exactly does a patient mean by when they use our language, our jargon, diagnostic jargon, to really make sure we understand that we're talking about the same thing. Because a lot of times patients are using it in a way that is actually not what we mean by that term.
The big T, the small t, I've heard you describe it before eloquently. Great, thank you. Brooke, any final words of wisdom on this case?
One little piece that kind of sticks out, she's very, very concerned about working out some kind of plan so that she's not impacting the kids. I just want to take a little bit dive deeper and make sure the kids are okay. Make sure that we're not beyond that point. Safety first. So emphasizing that she is safe, family's safe, and being sure that she feels safe and sharing that information with us so that we can work together on a plan.
Gosh, in a 15-minute time period, you three gave us great pearls of wisdom. I'm going to do my best to summarize them, the best I learned it. One, I think I learned that bipolar disorder is highly comorbid. So just because, even if you suspect bipolar disorder, dive a little bit deeper. In fact, a diagnosis of bipolar disorder makes it almost incumbent upon me that I explore deeper. From you, I learned the importance of collecting a bigger history. Maybe even collateral information, if her husband's available, whoever's available. From you, I learned that scales and screeners are important, and we should always, whether we suspect it or not, explore for safety. Patient's own safety, patients, family members, etc., etc. Before you jump to a diagnosis, make sure you've explored it fully. Yeah. Thank you very much, folks. Thank you very much. Can I turn to case number 2 now?
Yes.
Okay, let's see. Yes.
Sorry, I didn't want to jump in. I thought this was a good point to do this.
Yeah.
The wire sticking out there.
Yeah, let me get behind it real quick. Mind leaning up?
Thank you.
So
Every second is valuable.
So your case made me think about the bidirectionality of trauma.
Okay.
Oh,
Right?
absolutely.
So I can be a victim of trauma, but I can also be traumatizing others. I don't mean to.
Yeah,
But
that's the.
Oh, yeah.
You guys are.
Hurt people hurt people.
Yeah.
Thank you, guys. You guys are giving pithy responses with the 3 of you in 15 minutes. We still covered so much ground.
That's great. So this is a different case.
It's a different case, yeah.
Yeah.
Different case.
Good.
Oh, okay. Okay, dear colleagues, we now turn to case number 2 to get our experts' opinions. And this is the case of the artist caught in a revolving door of hospitalizations. This is the 38-year-old female patient, very accomplished artist who, despite her obvious talents, has never been able to hold down a stable job for herself or to provide for her 11-year-old son. 20-year history of well-established bipolar 1 disorder, mixed episodes, often accompanied by psychosis. Has never been suicidal, though, not really. But mixed manic episodes and psychosis have led to 7 hospitalizations over the last 20 years. This is the patient that I encountered. Says, each time I kind of get my feet under me, I forget my meds and I get right back into the hospital. I swear, I've learned my lesson. I would like to be super religious about taking my medication this time. Look, it's not that I don't want to take my medicines. This time it'll be different. I swear, please refill my medicines and I will see you in a month. Well, Brooke, if I may start with you.
Sure.
Lovely woman. But what might be an optimum plan of action in making not just the correct diagnosis in this patient, but an appropriate treatment plan? How would you approach this lady? 7 hospitalizations in 20 years.
So whatever we're doing is obviously not working. We need to come up with a plan, and it's obviously got to be a plan together. I hear her say she wants to be better. So working with her, using that shared decision making to identify what she'd be willing to do. And this, I think this is a perfect example where I'm going to be promoting a long-acting injectable. She wants to take her medication. For some reason or another, it has not happened for one reason or another. And so one way that I can find that often easier approach, not just because she's not taking her medicine because she doesn't want to, and it's, you know, being a bad patient out of convenience. Maybe we could find a different approach to taking your medicine because what we're doing right now is not working.
It's not working for her, and she so desperately wants to be better. Greg, adherence is a challenge in psychiatry, yeah? It's a challenge in life, but psychiatry in particular is a real challenge. But she's so convinced she can do it differently this time. What would you do? Refill her meds, or would you have a deeper conversation?
Obviously have a deeper conversation, and I think all of us here, this would lean us towards possibly some of the medicines that are approved as long-acting injectables for bipolar. And the good news is we have several now that are. I would go beyond that, though.
Okay.
One of the things we make the mistake is many of our treatments for bipolar are good for an acute episode, but they haven't been shown to be preventative for relapse prevention. So I would make sure I'm using medicines that have been shown to help with relapse prevention. Our long-acting injectable atypical is, long-acting aripiprazole has been shown to be appropriate for relapse prevention. I was a part of those trials. Lamotrigine, lithium, have good relapse prevention data. They don't have as good data in the acute onset, the acute episode, but they do have relapse prevention data. So I would have a discussion with her about these are medicines that have been shown not to just help in the acute stage, but these are medications that have data about helping with prevention of the next episode. And then I'd go into holistic things like, does she have a pill box? Does she have it there where she can see it? Has she tried to do lifestyle interventions that make it easier to remember it? Does she set her phone to beep every day to remind her to take her medicines?
Yeah.
So I would lean towards an LAI. If she's not there yet, then I would talk about some of these other holistic interventions.
Yeah, I very much like the suggestions you offered. Andrew, you've been a practitioner for some years, and I bet you've seen more relapses from partial adherence, non-adherence, than you have from actually medications not working. So I assume, correctly I think, that increasing adherence is a large part of what you do. Can you share some tips on how you improve? How do you assess for adherence, and how do you improve adherence in your patients?
You know, one of the best questions I ever heard taught to me was asking a patient, if this medication were to work, what would it allow you to do that you're not able to do now? And that taps into so many interesting things, right? Because it taps into what they've functionally lost, and also taps into hope. Because, and if you can tap into hope, hope is a much greater draw than fear, right? And so if this patient were to say, you know, I really want to be able to hold down a job to provide for my kid, you know, that's a great goal. What's getting in the way of that? Well, I have these breakthrough symptoms, or maybe it's the side effects of these medications have been the problem. You know, we often think about medication adherence, and we don't think about why are patients not adhering. You know, we often go to this just poor insight as an explanation, but you know, when you actually really get into why do patients sometimes not take medications, it's actually quite rational. It may not be the best decision in terms of their long-term outcomes, but in the short term, you know, I don't like the way the lithium makes my hands shake, so I only take half of it. You know, or something like that. And I think we've all had, you know, I think we've all personally probably had negotiations with medication. Do I need to take this today? Maybe I'll skip it today, right? Well, our patients are no different, right?
Patients are no different. And from what I understand, reduced adherence can be a symptom of an impending relapse. It may not just be the cause of an impending relapse.
And it's bidirectional, right?
It's bidirectional.
Yeah. And when you think about with bipolar illness in particular, you know, if I have a headache, it's pretty easy to convince me to take some ibuprofen. But once that headache goes away, why would I take ibuprofen?
Good point.
Right, and so a lot of these medications often get started in an acute episode. The person starts feeling better. They say, great, you know, I don't need to take that anymore, which we think of as poor insight. But really, you know, from a patient's perspective, that's a reasonable thought. It makes sense, right? And so it's incumbent on us to explain what we're trying to do here is, you know, I will often explain it in two directions. One is we're trying to reduce the amplitude of your event. So you might still have some depression, but it's not, you're not going to bottom out. You're just going to dip, right? And you might go up a little bit, but you're not going to skyrocket. And we're also trying to reduce the frequency. So I want you to have more periods of time where you feel normal. That's really a treatment goal here.
I'm hearing a lot of echoes of motivational interviewing in what you just shared, which is so good, so good. Brooke, you mentioned long-acting injectables for her. Based on my read of the literature, only about 1% of patients with bipolar illness disorder actually are even offered, leave alone take it. Could you perhaps do an autopsy on psychiatry?
Sure.
What is the challenge? Why are we not even offering, considering the use of long-acting injectables in a disorder that is rife with poor adherence? Thoughts?
Yeah, there are a lot of thoughts with that. So let me start with, I don't think that we do it on purpose, but I believe a lot of that falls on us as clinicians. I think we have in our head that it is going to be difficult to get a patient to agree to do so. And it's going to take time to convince them to do so. It's going to take time to administer an injection or set up an injection. And unfortunately, we have a lot of clinicians that are tight on time. And so in thinking about, oh, that patient's coming in, I know they've not been taking their medicine, we're going to have to discuss these other options. Maybe I'll do it next time. They're going to say no anyway, so I don't feel like having that argument with them today. And it's not an argument. It's a conversation, letting them know risk or benefits, them making the choices, and using our motivational interviewing to allow them to see the benefit, and that this isn't punishment. This is an opportunity. I always say for them to be able to take a medication once a month, once every other month, once every couple months, so that they don't have to think about taking that pill every single day. A constant reminder, a constant decision. Am I sick enough to take a medication? So laying out and taking the time as a clinician to actually do that motivational interviewing, I think is key to what is going on in our field. I really feel that we assume patients are going to be resistive, but we know long-acting injectables are used across multiple other disease states, and they're accepted. We really have to start accepting within ourselves that patients are open to hearing this, and they, as part of informed consent, they need to be informed of those treatment options.
I really like that.
Rakesh, as I was listening to Brooke, 100%. And it's how you offer it and offering with hope.
Yeah.
I never say, what would you think about a long-acting injectable? I'd say, what would you think about a medicine you could take once a month? What would you think about a medicine you could take every 2 months?
Right.
What would you think about a medicine you could take as often or as often as we need it? They're like, really? I didn't know you could take something once a month. Well, yeah, we have a couple of options. Let's talk about those for you.
It's not what you say, it's how you say it.
Yeah.
It's the attitudinal change you are recommending. So in other words, even though we're looking at this as a patient problem, it sounds like it's also our problem. We have a culture of silence.
I just did a lecture for a group of Yale-trained psychiatrists and nurse practitioners. And at the beginning of the lecture, Brooke, I said, so how many of you have used a long-acting injectable with somebody with bipolar? 1 out of 14 hands. I said, okay, at the end of the talk, I'm going to ask you the same question. But the question is going to be, if you offer this to your patients with bipolar, how many of you think you have patients that would want to receive it? And every hand went up. So you're right. It's the training, it's the comfort, it's how we offer, it's our ease. It's there's a lot of components to it.
Yeah, bipolar disorder is such an extraordinarily expensive disease to a patient, and often what stands between a relapse and a patient is a medication, if it's on board. So let me do this. Last question on this particular case. If you were to offer 2 pearls of wisdom to our colleagues listening in, how to increase the number of individuals with bipolar disorder who do receive an LAI, top 2 pearls you would offer?
Offer it with hope.
Okay.
Offer it with hope. I've had patients just like you that this has helped to stabilize their life.
Okay.
And then talk about this is going to make things easier in your life. This is going to make it easier in your life because it's once a month, it's every 2 months. I'll be here to give it to you. And you don't have to think about it in between.
Wonderful. Hope and the real possibility of moving away from the disasters associated with bipolar disorder. Andrew, two pearls of wisdom you could share.
Well, one is to think about the systems in which these are administered. So I think that's another barrier. So there's things like cost and insurance coverage, but then also who's actually going to deliver the injection?
So practicalities.
Practicalities, because one thing to order, it's another thing that nobody knows where this person goes to get this fulfilled. I've worked in clinics where there's an injection clinic, which is fantastic because this is what they do all day. They have the medication stocked. Also, sometimes ordering it is a challenge because it needs to be special ordered depending if it's on formulary, things like that. So reducing sort of friction between the patient, between me ordering it and the patient actually receiving it.
I very much like what you said. Sometimes the barrier isn't anything other than the system's not in place.
Yeah.
So if you can reduce the friction, then the chances. Thank you, Andrew. And you have the last word, Brooke?
Yes.
2 suggestions you would offer so that we can go from 1% to maybe where I think it deserves to be. Around 50% of our patients really should be getting a long-acting injectable.
I think as clinicians, we need to ask ourselves, if this were my family member or if this were me, Would I be offended if their provider did not offer them every option available to treat this illness? We have seen what this illness has done to her life. Think about how many hospitalizations, how that's impacted her child. The time that you're away from your child, every day is impactful. She's had multiple different hospitalizations, the way that it's impacted her work. So really bringing it home and personally asking, you know what, we have to treat each individual as if we want our own family member or ourselves treated. So if we have better treatment options out there with proven efficacy, don't we want those at least offered to ourselves, let alone our patients? And then, again, just bringing it back home, real life situation, asking the patient, what would it take for you to try this medication? You've already told me that what we've been trying is not working. I've presented you with this offer. I hear you're a little bit hesitant, but what would it take for you to try it? I often find there are a lot of misperceptions about what our long-acting injectables entail. Some have had bad experiences on an inpatient unit with an injection, and they assume each injection correlates in that same matter, where these don't. So getting rid of some of those misperceptions that your patient might be carrying and is actually another barrier.
Beautiful. Amenities of care is how I tend to present it too, like a menu of advantages and potential disadvantages. And just like you three, I never underestimate emotionally what it must feel like to receive an injection for a disorder. I usually at the end of a case offer take-home lessons, but I can't do better than what you three said, so I'm going to not do it. Thank you, the three of you, for giving us real pearls of actionable items. How about we turn to our final case?
Sure.
Let's go. Let's do it. Okay. Case number 3 is the case of the political science major student with bipolar disorder and ADHD who's experiencing sexual dysfunction. 19-year-old male diagnosed with bipolar disorder type 2 at age 16, doing very well on lamotrigine. Currently a sophomore, transferred from a local large university, is on a stable dose of Vyvanse 70 milligrams per day for a well-documented history of ADHD. He's been on it for a medication. Now get this, this is what he says. I've been having like real trouble with sexual stuff. Scares me, worries me. When I ran out of my Vyvanse for a week, the sexual stuff got better, but now that I'm back on it, the problem is back. I don't think stimulants can cause such a problem. What do you think is wrong? Do I need testosterone shots? So Greg, let me start. I mean, stimulants don't cause sexual dysfunction, do they?
They can. They can.
Talk more about that.
It's one of those dirty secrets. Anything that modulates norepinephrine, in particular, can cause sexual dysfunction. Atomoxetine, SNRIs, stimulants, all can be associated with sexual dysfunction. Not a common side effect, not something we think about, but can be seen with any of them. I'd also ask about other things that can change sexuality, though. Anxiety. A lot of my college students, you see that sexual functioning now becomes not down here, but it becomes up here. Right? So what were the triggers? What were the primes? What were the things that made you think about it? Does being anxious affect your sexuality?
Yeah. Andrew, in psychiatry, we tend not to, unless the patient brings it up, talk about sexuality, particularly with men who are this age. What is your general approach, not just to this gentleman who's reporting sexual dysfunction, but what's your general approach to the evaluation of sexual functioning in your patients?
Well, we broadcast to our patients what we're comfortable hearing, right? So if we ask a question like, you're not having any sexual problems, are you? I'm pretty much broadcasting what I want to hear, which is, no, it's fine, right? Versus if I broadcast that I'm comfortable talking about this. And, I joke with patients, I say, look, I'm a nurse. There's nothing you can tell me that I haven't heard before, and if it comes out of your body, I'm interested in it. I use a little humor in there to just kind of diffuse the tension around that. But we broadcast with our own questions what we're comfortable asking about, and breaking down sexual function. Like, I actually really hate the term sexual side effects, because what does that even mean? Right? Exactly. It's a very sort of polite term, but it's sort of meaningless. Are we talking about problems with arousal? Are you having problems with erection? Are you having difficulty with orgasm? Is the quality of your orgasm diminished? Like, what are we talking about when you're saying you're having sexual problems? I want to understand that better. Are you having reduced libido? What's happening? And then, as Greg said, what else is happening in your life? Tell me about your relationship or relationships. What's the context? Is this in the context of masturbation, or is this with sexual partners? What's your relationship like with that person? Because all those things can.
So it's a deeper conversation
Right.
having. That
Absolutely.
That was a masterclass in how to do an evaluation for a part of humanity that generally speaking, you're right, clinicians don't want to explore. Brooke, ADHD and bipolar disorder? Come on now. Can they occur?
They can occur together, and often they do occur together. One of the things that stuck out about this case is mentioning these sexual side effects. And he mentions that he did well. They seemed to go away when he was not taking his Vyvanse. So I'm starting to correlate those two. But what I also worry about, we have a young individual who's concerned about sexual side effects, not just him not taking that Vyvanse, but if he stops taking his medication for his bipolar disorder because he's assuming that's what could be causing, then we're worried about, unfortunately, an exacerbation of his mood disorder.
There we go. There we go. So just because he's having a side effect, just offering him quote unquote reassurance is not the way to go.
No.
So can I turn to you, Greg? Let's for a second assume that Vyvanse is clearly the cause of his sexual dysfunction. Is switching him to another stimulant appropriate?
Certainly. I would probably switch to a different class at this point. I would think about a methylphenidate option, going to a medicine that has slightly different mechanism, may have slightly differences when it comes to vascular response. We do know that stimulants all have slight constriction of the tips of your blood vessels. It's now a caution in all of the stimulant labels. So, I think as Andrew said, sexual side effects is not just one thing.
No.
It can be prolonged erection, decreased erection, problems with libido, problems with premature ejaculation.
That too.
A variety of things that could be affecting this young man. I'd want to know about it. I would probably go to a methylphenidate next, would be my next option with him. I might think about a medicine with a shorter duration of action. So that if intimacy is pretty predictable, it's Friday night at 8 o'clock, well, I might think about a medicine that's pretty much gone by Friday night at 8 o'clock. But my first step would probably be a methylphenidate.
Gotcha. Okay, so this is a really important teaching point. Several things came to the fore. Explore sexual dysfunction in a humanistic fashion, in a way that invites commentary from the patient rather than pushes back. Your point about they can co-occur. And you made a very important point that just because it's a stimulant, they're actually pharmacologically quite different.
Yeah.
Yeah. What are your thoughts about potentially using non-stimulants in someone who has ADHD and bipolar disorder, just in case this patient says, I will never try a stimulant again? What are your thoughts about that?
Sure. I mean, we could think about other noradrenergic agents that are used in ADHD. We could think about atomoxetine, although we might run into similar noradrenergic side effects. It also occurred to me as we were talking that we should get clear on what he's basing his sexual function baseline on. This is a bipolar patient. So if this patient's presentation when hypomanic is to be very sexual, if he's having sex 3 times a day when he's hypomanic and he thinks that's normal, right? I mean, this is a 19-year-old kid. I'm assuming he probably doesn't have a lot of sexual history. So, he may, but, probably certainly not decades of baseline data, right? So getting clear on what are you, when you say sexual dysfunction, not only the mechanics of that, but what are we talking about here? And how does this compare to maybe when you were in a more elevated state and perhaps you had a higher libido?
I just love what you just said, because you did not look at just the obvious. You even broadened the horizons and the scope of what we are to collect. That really is very helpful. Thank you. Brooke, what about you? How shall we approach this individual if he has ADHD and if he has bipolar disorder? It seems to me that both must be addressed as best as we can. What steps might you recommend? Reassurance is important, but the gentleman really wants a correction of his difficulties. What are you thinking?
So what I'm thinking, again, having the conversation with emphasis that both of these diagnoses need to be treated. This is a college student, and I think what we fall back on sometimes as providers, oh, well, if you don't want to treat the ADHD, you don't want Trivivance, we will just stop it. I'm okay with continuing your medication for your bipolar disorder, but I find the ADHD gets put on the back burner.
Yeah.
And it's not addressed as significantly as it needs to be. Yeah. This kid could fail out of school if we don't treat his ADHD. So if he wants to change his medication, and I do believe that it's correlating with the sexual side effects, whatever those might be, I'm going to offer probably the methylphenidate options and shorter acting options, because I want him to be successful in school, and I don't want us to assume that we can then just not treat the ADHD.
Gotcha. So STEP BD showed us that 15% of individuals with bipolar disorder have ADHD. That's ridiculously common, right? So as a result, and maybe I'll start with you, Brooke, again, and perhaps go around our table. Knowing that these disorders are so common, when you encounter patients with bipolar disorder, knowing fully well that distractibility is a component of that disorder too, how do you parse this issue of, is it bipolar disorder with inattentional difficulties, or this is bipolar disorder with full-blown ADHD?
Very good question, and really hard for, I mean, as trained clinicians, sometimes it is a knotted ball of different things, and we have to slowly, each thread of those, peel back and see. So in looking at the different diagnoses and the concentration difficulties, the impulsivities that go along with a bipolar disorder, yeah, they often are associated with that mood episode. There's a lot more going on. Are these episodic in nature is what I want to know. But then if this is a problem that's been occurring since this individual has been a child, getting that good history from them, and it's not episodic. This has been a lifelong problem for them, impacting day-to-day functioning, then I'm going to assume we're dealing with two different diagnoses, not one bipolar with poor concentration and impulsivity.
I liked you used your hands literally, and that's how it feels.
It is.
But I really like what you said. When you find a thread, pull on it. And if you don't find the thread, find the thread.
Yes.
So pull the longitudinal history thread, pull the family history thread, pull the thread of, can you find episodes of mood without distractibility and episodes of distractibility? That tends to be chronic without mood. Thank you. Great pulse of wisdom. Andrew, the same question, because it's such a big question. What are your specific tips and suggestions on how do we pull what Brooke talked about, this ball of, thread? How do you do that?
Yeah. Well, since obviously ADHD requires some history as well. So I'm looking at that longitudinal pattern as well as of ADHD, but also bipolar disorder. When did each of these symptoms start? Because usually ADHD will predate the bipolar disorder symptoms. But I also think about the cognitive effects of medications. So some of our mood stabilizing medications, I'm happy to see these on lamotrigine because that tends to be more cognition sparing, but things like valproate are not necessarily, and have that somewhat cognitive dulling effects. But then a greater appreciation in recent years of the subtle cognitive challenges that happen even when bipolar people are euthymic. So obviously there is cognitive slowing when people have depression. There's often kind of a cognitive speeding up, but also disorganization that happens when people are manic. But even when people are euthymic, they can have some cognitive challenges. So sometimes disentangling that from ADHD makes it even harder.
So while it's a difficult task, both of you are suggesting there are ways to approach it. Thank you. Well, Greg, you're the president of EPSART. You're leading the nation in better understanding these issues. Lead us, and you have the last word on this one. Same question. Tell us how you suggest we pull these threads apart so we get to the right diagnosis or diagnoses.
And I think, first of all, just having it on your radar screen.
Yeah.
1 in 5 patients with bipolar disorder will meet criteria with ADHD, and those are studies from all around the world. And the number comes in 15%, 19%, 24%, but it's 1 in 5.
Yeah.
So 1 in 5 people will have it, so you have to screen for it with each of your patients. we routinely use rating scales.
Okay.
And as you know, we now call them our mental health vital statistics. Every patient that comes to our clinic gets their vital statistics. They get a measure of mood, they get a measure of ADHD symptoms, they get a measure of anxiety, they get a measure of trauma. Every single patient ubiquitously.
So more information gathered, the better you are.
Across
Gotcha.
the board.
Okay.
When this person's euthymic, I still want to know, are there ADHD symptoms in remission?
Yeah.
So what is that ADHD-RS score? And our goal in our practice, there's 18 symptoms on the ADHD-RS. I want all of those symptoms to be mild or less on average. So when I want that score to be under 18, somewhere in the 12 to 13 to 14 is a patient doing really well with ADHD symptom control. And then remember, ADHD is beyond just cognition. It's an impulse control disorder as well.
That's important.
So appropriately treating ADHD in that complex bipolar ADHD patient has been shown to decrease suicide attempts, self-injurious behavior, and relationship difficulties. So I would talk across the board, especially in this gentleman who's already brought up sexuality.
Yeah.
You know, dating with intention, dating with respect. What is sexuality at this stage of my life, and what do I want it to be in my next chapter of my life?
Wow. In 45 minutes, you three have made me a better clinician. And I think you made our colleagues a better clinician. Greg, Andrew, and Brooke, thank you very much, all three of you, for advising on these three cases. And thank you, dear colleagues, for joining us in this wonderful discussion about these cases. And we certainly hope they benefited you as much as they benefited me. Goodbye for now.
Great.
Damn, you guys are good.
We want to just do the first couple of slides before the first case. Just because there was water on the table, we want to make sure that
Oh, yeah.
we ended up moving it. But just the first slide before the
I can do that. Let me take us back.
Right, Patrick, because we didn't get into the first case. Like, we removed it and then we got into the first case. So.
Okay, you guys still rolling?
Yes, we're still rolling. I can do it. I can give you another count in.
No, I got it.
You got it?
Yeah, I got it. Hello, dear colleagues, and welcome to part one of Solving Clinical Challenges. Today we'll be focusing on bipolar disorder. And I'm joined by my three colleagues, Ms. Brooke Kemp, Mr. Andrew Penn, and of course, Dr. Greg Mattingly. Let's dive right into these cases. But before we do that, let's dive right into these cases. Before we do that, though, we have our quick faculty disclosures here for your review, along with disclosures that pertain to the CME activity. And our learning objectives are to have a deeper discussion on these complex cases to better understand how, looking at evidence-based medicine but still using clinical wisdom, we can walk our way through these cases in a logical and productive manner. With that said, we're jumping right into case one.
Good. Awesome.
There we go.
And
That's a wrap.
It's a wrap.
All right.
Do that. I don't want to hear what I got.
How's Sandra doing?
She's better. I think she's gone.
Okay.
She caught an earlier flight. She needed to go. Huh?
She already left.
I think
Okay.
so.
Well,
I
I'll
think
see you
so.
guys
Put her
in
on a
Orlando
4
then.
o'clock flight.
You're going to Orlando, yeah? You're
For?
at the Institute?
I am. I'll be there. Yeah.
Yeah, I know.
Or, don't tell me
Where? When?
Did my tone give it away when you said Orlando? I wish I hadn't been so negative about Orlando.
Oh, well, Florida can't help itself.
Thank you. Thank you for your wisdom.
thank you very much.
Are you headed out or you got something more? Okay.
I'm done.
Okay, go, go, go.
Thank you so much. Appreciate that.
That was fun, Andrew.
I noticed there's a typo in my credits. Who should I bring that attention to? Is that
Tell
a
that.
Genevieve problem?
Yeah, you if you give Pat, there was a typo in his
It's a lot of other people.
what was in your title?
Yeah, it's my institution. It says U.S. San Francisco.
Is this for
UC San Francisco.
Are the backs up?
We need to swap them. They're low.
All good, guys?
All good.
Wow,
Thank you
you
for
guys-
Yeah, that's
redoing
fantastic.
that for us.
Oh,
Appreciate
please. It is
That one's
zero problem.
This one is? Yeah, that one's good.
Which is that one?
Zero problem.
Did you check Rakesh's? Is it still on?
Can I check your
Mhm.
pack?
Sure.
Just make sure the battery's good. Don't necessarily have to remove it, but I just.
Okay.
He's good. Full bars. Cool. I'll turn him off for an hour.
Turn it off, please.
We should be starting one hosing. What time is it?
It is 3:02.
It's 1:56, so we'll start at 2:30. I think is our.
Let's do it now. If I can
Do you want to start? Let's start early.
We
Everybody's
can
here.
start early.
Let's
Yeah.
do it.
I would love to.
Yeah, I just told Kevin to get ready. I'm gonna go find Julie.
Fantastic.
So
And
the
then Mark
next
just
one
finished in the
is-
back, so he's coming up.
Give the bookcases
I got
part
Kevin,
two.
Craig's not here. but
No, it's gonna be Julie instead.
Barbara. Okay.
We need you a part of every session to get everybody to go early.
I am.
We have some dilly dallying today. A little bit of dilly dallying.
Zero daddy.
I love it. Yeah, I hated to stop then, but I knew this mic cable was just gonna like fly out. Oh, gotcha. Cause it was riding its way out. I'm like, oh man, I can't.
Yeah, the water, I could have masked that.
It was on his body though. Like it was like floating above the table. It wasn't just on the table. It was on the chair and his leg.
No, it wasn't. It wasn't.
It was like this. I can show you exactly.
Unless he moved his leg and.
It was like right here.
Yeah. But it wasn't on any person. I could have just masked that.
Yeah, there was leg there, and that's why I was like, oh, it's gotta go.
It was close.
It was easier to just have them redo that part.
Yeah. I didn't even see you climb in there. I was adjusting audio levels and I
You
looked
didn't
up and
hear
the
me
water.
because I was smacking the TV.
And the water was gone.
I knew it wasn't an issue, but I was like,
No, I
"Man,
didn't.
just
I didn't
wanna
hear it
be a
at all.
distraction."
I was adjusting audio levels and I look up. I was like, oh, the water's gone.
And, like walkies hitting the TV. That last one, I was a little heavy-eyed. Just like, all right, I'm tired. That's why I only had an apple for lunch, because I knew if I ate, it would hit me hard.
Food gives you energy, dude. Oh, okay, probably because I popped the battery pack back in.
Yeah.
It has me. It has me. There's like. It was a friend of yours, too. You doing all right?
Yeah.
That up. Let me see.
The preciousness of life. Something I forget.
Twist. Good to go. Cool.
Yeah.
I'll also have you on this side.
Oh, high IQ's on that side. You don't have to help me out, buddy.
No, I don't want
the opposite.
black
no,
clothing
no,
to
no.
fade into the navy background.
Ah, there we
That's
go.
more of
Mark,
the-
good to see you again.
The well tanned on the left. Come on, buddy.
And I'm
You
assuming
here for a
have
couple days?
No, I leave tonight. Yeah. You as well, I assume.
Well, my son is here, so I'm staying in. Actually, my other son's coming from New York, so
Oh my
kind of
gosh.
made a
family reunion.
little reunion.
Nothing better, and it's a nice area. I think there seems to be quite a bit to do.
Yeah. So I've just come up with, see what we'll do tomorrow.
Fantastic.
So my son is here with my
There you go.
granddaughter.
You can take a
so-
seat if you'd like.
So yeah, I'm
Nothing
like,
better than
Philly?
that.
I'll be there. I'll be
We
there.
will be
So-
there. Yeah. When I was here last year, I thought I'd like to come back and stay a day or two.
It's a great city.
Yeah, and
I've
even
spent quite a
this
bit of
little
time here.
town here, especially. I love the bridges, the
City
Riverwalk.
center, yeah.
Yeah, but of course,
I miss
I'm
the
in and out
Riverwalk.
again.
There's a
right
Riverwalk
behind the
here?
hotel, and it goes.
Oh, that one.
Yeah,
Yep,
quite a
yep.
distance.
And Main Street is fun to walk.
Yeah, it's a cute little area.
Yeah, thank you.
But alas, here and gone again.
Sorry about that. Sorry about the delay.
No, it's okay.
Over here might be a little easier.
We weren't supposed to see this case ahead of time, were we? Because I.
No.
Okay, good.
This
I
is-
didn't
Even I
prepare,
haven't
so-
seen those cases
Oh,
ahead
okay.
of time.
This
We're
is
okay.
something they've enjoyed doing, sort of springing it.
Yeah.
And
I think you have to
was
load
telling
up the
Randy,
new slide deck.
I wasn't
yeah?
a fan the first
Yeah.
year. I thought I'd like to sort of
Yeah.
prepare some thoughts.
Yeah.
And he's like, but wasn't it great because of the spontaneity?
Yeah.
And so it's a mainstay now. The past several years.
It was a total experiment 2
Yeah,
years ago.
it
to
is.
have
It was.
I think that's great. People.
Would you
need to
change
hear that, yeah.
Dr. Chepke to Dr. Judy
right.
Carberry?
There you
But
go.
maybe you'll do it later?
Actually, turn around.
There's so much theming out there. You need to mix it up a little bit. You need to
Yeah,
things that
just
are,
if you want to take out
Right,
Craig
that will
Chep,
kind of
yeah,
stand out.
and just replace with.
And what's so interesting
go.
is just how
Thank you so
everybody
much.
complements one another and how the conceptualization comes together. So.
I love coming here and just being with all the luminaries.
Yeah,
and
right?
everything.
Isn't that great?
All right. We're going to remove the waters from the table. Apologies.
Okay.
You want last hit? Last hit?
No, I'm good. I'm
No, you're
good.
good?
Your name came up the other day.
My name came up?
Yeah, because a patient who was seeing you or something. I have to try to think who it is now.
Uh-oh. Did I send them to you?
What?
Did I send them to you?
No, I think it was just happenstance that they were.
Oh, wow.
So, where's your practice located?
In Tampa?
In Tampa, that's right.
Oh, that's
yeah.
How cool is that? Huh?
Yeah, that's really cool.
Yeah, so
Yeah.
it was a family in Tampa.
Uh-huh.
Speeding.
I have one more.
Yep.
Sorry.
Oh,
I mean, I
would
need to
you
think who
pass
it is
me
because
this?
I normally don't have patients in Tampa, but I just happened to say.
Oh, wait, 1 second, 1 second. All right.
Oh, you're good.
Oh, okay, okay. So guys, we have 3 cases.
Oh.
15 minutes each. I only have 1, maybe 2 slides to describe the case. And then we jump into conversation. There's no particular order I'm going to follow. 15 minutes is a relatively short time, so.
Yeah.
But have fun. Have fun. And if you want to have a comment about what someone just said, feel free to do so.
Right.
And my job is just to listen to your brilliance and applaud. A pretty nice job. And that's it. 3 cases. Let's learn. Let's teach them something. I know we will. We'll go from there. Sound good?
Sounds good.
Okay, let's do this.
This slide, are we gonna?
You're not going to be looking at the slides at all.
Oh, okay. Just hear.
You're welcome to, but you don't have to.
Okay.
I'll read the cases to you.
Yeah.
And I'll pose the questions, and I'll just kind of back and forth, back and forth. That's my job.
And they want us to look at each other, or at
No,
that?
not just ignore that. Other
Yeah.
than the very opening, because I'll be addressing that. But after that, it's really a water cooler conversation. No case is a geriatric case, or an adult case, or a pediatric case. It is what it is.
Yeah. Okay. Sounds good.
Okay.
Yeah.
All right, all set.
Sounds good.
Ready to go? All right, I'll count you in. Ready in 3, 2.
Hello, dear colleagues, and welcome to Solving Clinical Challenges, Part 2. We're going to be focusing on major depressive disorder. And as you can see, we have 3 stars from the world of psychiatry, Dr. Mark Agronin, Dr. Julie Carbray, and Mr. Kevin Williams. Welcome to all 3 of you.
Yeah, thank you. Hello.
Oh, my goodness, it's going to be a good time, and I'll learn a lot from you. Faculty disclosures are here for your review, along with disclosures that are germane to the CME nature of this conversation. Please be assured this activity has been independently reviewed for balance. In terms of our learning objectives, we're going to really try and understand how to incorporate evidence-based medicine into our practice, though fully realizing that that often isn't enough. We have to bring clinical wisdom to discussing what are often complicated clinical scenarios we encounter. So towards this end, I've brought 3 cases from my own practice to get our 3 experts' opinions. So here we go. Case number 1. This is a case of a recent transfer to an assisted living facility. This lady is 78 years old, widowed, who has recently lost her husband of 50+ years and has moved from another state to become a resident at an assisted care facility where we are a consultant, so that she can be close to her daughter. She has been seeing a psychiatrist for decades for my, as she describes it, my nerves. She's currently on alprazolam 2 milligrams 3 times a day for over 20 years and tells us, it's working great for me. I just need a refill. So, Mark, this is the case we have. If I may start with you, how do you recommend we initiate further exploration of this issue regarding alprazolam, or just because it's been working for 20 years, it's best to just refill it and move on?
Well, my first comment would be we need to listen to how she's experiencing these changes. I mean, seemingly she's gone through enormous transition, enormous loss, but we don't want to assume what it is for her. And so the first step is just hearing how she's doing, what's going on. Is this creating more depression or anxiety or not? And sometimes we can be surprised how people respond to losses like that. So that's issue number 1. Issue number 2, obviously when you hear that much alprazolam someone is taking later in life, it raises a concern on many different fronts. Who is managing it? Is it being managed properly? Are there side effects to it that we're not aware of? So that needs to be also explored. I tend to be conservative in the sense that if someone is doing well on a medication, especially if they're going through change, I don't want to rock the boat too much. So I'm not ready to jump in and say this is a problem or not. I really have to learn what's going on. But at the end of the day, someone in their 70s and 80s, you'd like them to be on a lower dose or the least amount of something like alprazolam as necessary, and explore other modalities to deal with
quote-unquote nerves that she describes.
What do you say, Julie, to what Mark just shared, which is a really holistic, thoughtful, kindly approach to understanding?
And I loved how you started out with what is her current experience? How is she understanding these changes, this loss in her life? And how is it rolling into her condition that was already these nerves? I want to also, of course, talk with her daughter. I'll start with her, but then I'd like to get some sense from her daughter around her functioning pre-move, pre-loss, see if there's been any shifts. This is such a shift, going to a care facility. Who knows how many friends may have shifted as well. Are the nerves worse? Are the nerves about the same? One might expect there might be some changes. And then medical stability. What else might be going on? Of course, assuring her safety. It looks like she'll probably have some eyes on her all of the time, but one of the largest risks might be one of falls. And especially as she's navigating this new environment and experiencing those nerves, what has her history been over time? And yes, these medications have been long-standing, but I also want to have a sense of that history moving backward and then her current state of functioning and getting some perspective from her daughter, of course.
Yeah, both of you are recommending a very thoughtful, well-considered approach rather than automatically reaching for this, bam, the hammer. You're taking alprazolam. Nobody under my watch ever takes alprazolam. So what is your thought, Kevin? How should one approach a scenario like this?
Well, agreeing with both Mark and Julie in regards to understanding the transition and not being so quick to make adjustments to the medication, but I would also add on, when did your anxiety originally start? And what was the journey to the alprazolam 2 milligrams? Just to understand initially, if we're able to recall what took place. Are there potential triggers that could be having some potential to worsen being in the assisted living environment? Yes, the transition to moving out of state to a new facility, those areas to be closer to your daughter. How often is your daughter visiting? Those are great things to understand, but really trying to hone in on, are there going to be potential triggers that could make this worse?
Gotcha.
That would be another approach that I would take.
Already you've given us a lot to think about. All three of you have said, be thoughtful, be curious.
Yes.
Get supportive information, get longitudinal information. I got it. But I gotta say, just speaking from the other side, of the 10 most prescribed drugs in America for psychiatric reasons, 4 are benzodiazepines. There is a problem though.
Right.
So having said that, perhaps, Mark, you could get the ball rolling on educating us. What are the strengths and weaknesses of benzodiazepines in all populations, but perhaps your area of expertise, geriatric psychiatry?
You know, I love the comment about looking into the origin of where the medication came from, because it really speaks to, often benzos are used to quickly take care of a problem without looking at the big picture. And so you're right, how did she get on that? I mean, it's a great question, and maybe it was due to panic attacks in the past, which gives you one direction to think about, because you don't want to induce panic attacks here. Or maybe there was substance use involved, or maybe there was some particular stress that was time limited, which is either not in existence or there may be a recapitulation of it. So the problem is that people use these quickly to solve the issue, but we know there's cognitive toxicity to these medications without question. When you get to 2, 4, 6 milligrams, you only amplify that, and then when there really is cognitive impairment, it's going to make it worse. You mentioned about falls. That's a big issue we need to focus on. We know there's an increased risk of falling. Sedation. People use it often as a sleeping pill, but it doesn't necessarily have an optimal approach to the architecture of sleep, especially as people get older. And so that increased risk for sedation, confusion, falling, you're really putting someone at great risk with this medication.
Gotcha. So there are definite weaknesses to thoughtlessly prescribing benzodiazepines. Julie, I did something in the intermediate time. I actually called up the prescribing psychiatrist.
Yeah.
And I asked the psychiatrist what was the diagnosis, and get this. And I told the psychiatrist that the patient was saying nerves. He said, oh no, her diagnosis is major depression.
Oh, wow.
So I asked, why is she then taking alprazolam? And he said, because she did not tolerate the SSRIs, and she's been taking alprazolam 3 times a day for the last 40-some years, actually for major depression. Does that change in any shape or form how you would approach this patient from now on and her use of alprazolam?
I would want to understand that major depressive disorder, what her experience was, and what the medication, what the benzodiazepine might be doing to help her. She's describing it as nerves, but the understanding of that depressive component hasn't yet been illuminated. So I'd want to understand that. And in understanding that, that might lead to some education for her, as well as for her daughter, especially at this time where she's just lost her husband and there's been all these changes.
Yeah.
I too worried that even at this dose, something was going to come about to rattle her. And this will also pave a way for us to be able to look at this medication, which was doing something. Let's figure out what it was doing. Is there an indication for alprazolam at this dose for major depressive disorder? Typically not. And so I'm not going to necessarily say that.
Yeah.
But what I will say is let's assure that you have the right medication to address not only what you were experiencing then, but also what you might be experiencing in the road ahead. And I want to make sure that it continues to be safe and manageable for you.
Gotcha. Kevin, do you think there might be a role for us to approach her for her major depression, but now with perhaps a more recent medication, a modern medication, with an exploration of her previous side effects? And do you think a benzodiazepine taper is ever possible? This lady's in her 70s. Is it even possible for someone that age to reduce their benzodiazepine?
I do think so. Actually, I was, as both Mark and Julie were talking, I consistently thought of keeping the patient close by, doing frequent visits with her giving feedback on what she's experiencing. And I call it homework, but I want you to monitor, this is kind of a conversation I would have, I want you to monitor over these next 2 weeks these lists of possible feelings. And if you're coming back saying that, I want her to trust that we're actually identifying more of the depressive symptoms and then continuing to educate softly on the role of a different class of medication that could help. But gaining her buy-in by allowing her to trust me. She's, at this moment, I particularly feel she's more forced to see me.
Sure.
I'm assigned to the building. Yes, she can go anywhere and be seen by anyone, but I want her to feel as though she has a choice still, because several of her choices are being taken from her in some regard. So building that trust will help to transform her personally to then saying, you know, Kevin, I'll take the medication. You're saying it, I trust you. And in this particular demographic, I've learned gaining that trust is much more important and valuable than the switch or the taper first.
Wow. Lots of pearls of wisdom from you three. Julie, you had a comment?
Prioritizing the relationship and the efficacy of that relationship in rolling out education.
Yes.
And engaging almost through like a motivational interviewing type approach of, what do you think? Here's what we're discovering together. And what do you think about moving forward in this direction? Is that intriguing to you?
Yeah, it's the best approach. And it's going to teach us, is this really major depression, or maybe it's a misdiagnosis? You know, benzos, and clonazepam in particular, have mood stabilizing properties. So what if this really is a bipolar depression? And so, you know, I want to trust the other clinician, but we don't know. But as you've outlined before, by building that relationship and trust, you'll get more information, you'll get a sense for it. We don't want to destabilize her.
Right.
That's the last thing we want to do. And yet we'd have to think about maybe 75, she's tolerating now, but what about when she's 80 or 85?
Right.
It's a different brain, a different body.
Very true.
So we need to really start preparing for that.
My goodness, so many things I've learned just from these last 15 minutes. So I'm going to try and summarize all the key learning points I've gotten from you. Perhaps the most important, all three of you made a big deal about, is relationships. Relationships are medicine, especially in complicated patients. 2, don't assume.
No.
Just because she said nerves, it's good to hear the patient, but get a deeper history. 3, don't even assume the diagnosis is correct. As a new clinician, you want to reestablish. 4, you guys made this point too, tapering a medication requires relationship and motivational interviewing. I actually reviewed a study recently of benzodiazepine tapering that one single variable, motivational interviewing and relationship, just one variable, improved the outcomes 300 to 400%. So it's medicine is not always medicine. People first, medicine second. And finally, thank you for making that point. The brain changes. So just because you're on a stable dose when you were 50 doesn't mean the dose is still right. And we need to be cautious about benzodiazepines. We don't need to throw the baby out with the bath water, but benzos can cause challenges.
Yes.
Did I miss anything?
No.
Well, in that case, compliments to all three of you for teaching us so much in 15 minutes. Are you ready to move on to case 2?
Let's do it.
Let's do it. Now that we are totally warmed up, let's do it. This is case number 2. And this is the case of the golf pro who's loving his work and life. So this is a 56-year-old male who works at a local golf course as a pro and loves his work. 30-year history of major depression, but currently stable on fluoxetine at 60 milligrams per day, bupropion 450 milligrams per day, and aripiprazole 10 milligrams per day. He gently states, "It's like a magic combo for me. I've never been better. I'm living the life I've always wanted, but never got to until right now." Kevin, I see the smile on your face, man. This is what we all live for, is to get this from our patients. But this is what he says now. "I'm here because my primary care doctor is hassling me about my weight. Since we started aripiprazole, my life is like 100% better, but I've slowly gained weight. It's now 45 pounds. My GP ain't happy, my blood work looks like crap, my cholesterol is through the roof, and I can't stop eating. It's like I'm hungry a lot. Even when I eat, I don't feel full, so I eat more. It feels like a bad Ferris wheel ride I'm on daily. We gotta do something here. I can't exercise more. I'm like walking the golf course 6 hours a day. What can we do? Can we just think about stopping my meds?" So Kevin, I'm going to start with you. Is it even possible to gain weight from the medication combination, or is this just a 40-some-year-old guy complaining too much?
Actually, yes. One of the adverse events of using aripiprazole is weight gain. And while it may not be as rapid as some of the other medications that we have, that we utilize in our toolbox, we can see some weight gain. So one, I think validating that what the patient is experiencing is known to be seen, and that we have options. I think that's the first approach that I would take, is spending some time going through the list of possible options, the pros and cons of all of them, but going through each of them because of the concern of the GP and because he is unable to exercise more, really finding a treatment plan of how are we going to reduce this weight or potentially change medicine, or what are we going to do to help him with making the lifestyle changes that he needs to lose the weight and to remain stable.
Absolutely. Both are equally important needs, aren't they? Julie, we are head doctors.
Right.
Right. Why should I be caring so much about below the neck? Why is that even important?
Because our head really runs the whole rest of our body. And we also know that a long-standing diagnosis of major depression carries in and of itself some metabolic concerns. We know that there are hypotheses, inflammatory processes that we have yet to understand. And a good place to start with him, of course, is to take that holistic view. Tell me about your life. Tell me about when the weight gain began. Tell me about the last time that there might have been a modification in the dose, any of the doses or not. And just having a good sense of holistically what has he been up against. And educating around things like wellness and what has he tried to move. But we've all had these cases where they've been on the good cocktail of medications, and they're looking for you as a prescriber to do something different so that that medication adverse effect potentially, if that's all this is, which of course we have good evidence it could be, might shift. But we know that we can look at changing medications, but we of course have to look at modifying everything else. And I would suggest that the medication cocktail that worked for him so many years ago, we might have some efficacy in potentially looking at that aripiprazole, because it might be driving predominantly what we're seeing with weight gain, and maybe we could make some modifications. I've had some success in even looking at dosing and lifestyle changes, but then again, it may not have that effect.
Gotcha. So you're both recommending empathy and validation. It sounds like that's the starting point of a conversation. So Mark, I have a colleague who says obesity metastasizes to the brain. Which if you let it sit with you for a minute, I think it's the point you were making, Julie, which is obesity is not just a problem below the neck. For biological reasons, it actually has an impact. Do you see patients where a longer-term exposure to medications leads to weight gain, and how do you approach that clinical conundrum?
This is such a tough case because he's doing so well, and yet these are serious metabolic changes that for a middle-aged man are going to pose increasing problems as he gets older. So they need to be taken seriously. If he weren't having such a spectacular response to the medications, I might be more apt to jump in. But I think the point being that, is your point about obesity, that these are multi-determined conditions, and I wouldn't initially assume it's just the medication doing that. That's a lot of weight for any medication to put on. And even though you can see metabolic effects on cholesterol from antipsychotics, I mean, for aripiprazole, this seems to be a big change. So this is where I would first call in other colleagues.
Such as?
Well, primary care, definitely, but maybe a specialist, a cardiologist, or someone who really can focus on the metabolic issues such as the cholesterol, and someone who focuses on obesity, and definitely a dietitian. We need to really determine what role might the medications be playing. If you put on 45 pounds since starting the aripiprazole, I'm more suspicious of it. But maybe not. And especially if that obesity has been there long-standing. Look, he's doing so well, there's a cost to destabilizing someone and not doing so well, and so sometimes you do need to think about antidotes and lifestyle changes, but aggressive management, maybe even through medications or whatever to deal with it, just because you want to preserve that benefit for him.
Yes, yes. He's doing unusually well. So let me stipulate a few things. Let me stipulate that the weight gain did start after aripiprazole. Let me stipulate that it was only 2 to 3 pounds in the first 6 months. It's gradually built up. Let me also stipulate that his cholesterol is a challenge and he's on a statin right now, but the weight gain hasn't come down. Is there any role for metformin in this particular patient? What do you think, Kevin?
So, well, give my initial thought was not necessarily metformin, but actually was to consider a GLP.
Okay, tell me more. Why?
So, actually, in my practice, we brought this on to one, train our clinicians to be able to prescribe it, but then to begin to educate the patients on its role. So as we were sharing, it came in my mind to really say, I would have actually not gone to metformin as an initial, which I guess someone would potentially look to do that, but actually to use the GLP-1 as a potential, and this is one of the options if he's not wanting to move off of the medication at this time, to one, speak with his primary care. So we don't work in silo as we prescribe it, but to make sure the primary care is on board and we move forward with treating with that to help not just with the weight loss, but also metabolically to assist the patient in the other metabolic profiles to make the improvement. Monitoring closely, clearly, and I always share with the patients, you gain that over time, so let's not expect that we're going to lose it tomorrow. Let's make some lifestyle modifications that ensures that you're able to keep this off 5 years from now.
Yeah. Did you guys hear that he works as a golf pro?
Right.
Yes.
Yeah. So the reason why I thought that was interesting is I actually have a family member who's a golf pro, and drinking a lot of beer is part and parcel of the culture, at least for him. So the point you three made was don't automatically assume this is, it could be. But look at the holistic background the patient's coming from. What if there's nothing? That's a different issue. What is the family history of early death? Is that there? Not there, that's an issue. But your point about thinking about GLP-1s in psychiatry is just so important. I understand that GLP-1s are becoming part and parcel of other people's practices too. What would you say, Julie?
Yeah, I think it's really a wave. It's something that has been embraced by many colleagues enthusiastically. In fact, there was a study that just came out that was circulated across our hallways that physicians themselves are big-time users of incorporating GLP-1s.
Particularly
themselves.
cardiologists.
Yes, did you see that?
I did.
So I've been hearing about my colleagues combining GLP-1s in their psychiatric practice. And I think it's been one of those areas where, you know, in my area of child, in adolescent, I'm not going to start a GLP-1 in my practice. I'm going to engage an endocrinologist. We're going to have that discussion. But certainly this offers a tool. Metformin, studies of use of metformin, not as robust as we would like. I loved your point about the beer drinking, because that's the holistic lens. What can we do to help him to beat this so he can remain well? So I think there's a lot of options, and GLP-1s, especially if drinking is an issue, may have an enhanced effect of also maybe curbing not only those food cravings, but also alcohol cravings as well.
Yeah, the excuse he used is I walk 6 hours a day. That's not an excuse, he was stating a fact.
Yeah.
But walking 6 hours a day, if you're eating an extra 1,000 calories a day, will not counteract it, if that's the case.
Yeah.
If that is the case. Mark, do you have any thoughts about pharmacotherapeutic approaches towards the treatment of obesity?
Well, I agree that the approach we're discussing is going to be the best approach at this point in time. I mean, if you look at the overall approaches to obesity, in this case, we have a more specific situation, especially if it wasn't the case from before going on the aripiprazole. And so some of the other modalities might have some impact, but they're not going to have the full effect that we want. And so this seems to be a little more of a specific case of that, which in some ways might make it easier. But what I love is this discussion of bringing in the primary care, endocrinology, whatever specialist, because we can't be in silos when we do this type of management. And as much as I can teach myself to use these, I'm still not a cardiologist, I'm not an endocrinologist. And I always have concerns when other specialties try to play psychiatry without really having the understanding of it. So I think this is where that partnership is really critical.
Yeah, and it's really important not to let the ball drop. Because sometimes what I have seen is when patients are bounced between specialties for good reason, no one wants to do the hard work.
There has to be a captain on that, that's true.
Gotta be a captain.
Because otherwise patients will just stop the medication, they won't tell you for whatever reason, if you don't have that type of relationship with them. And that's unfortunate. I've had people, you don't see them because they don't want to tell you, they're embarrassed, they don't like the medication. That's where that relationship, the communication, but also the captain of the team is so critically important.
That's such a big point, because frustration results. And I've seen this as well, when somebody has several clinicians and nobody is really spearheading that team, the patient gets so frustrated, and I too have found myself frustrated. Okay, who wants to assume this role?
And there are many side effects that we can talk about that individuals will or will not talk about. So this is one you can't miss it because if he walks in and you can see the difference. But there may be other side effects people will not talk about, they're embarrassed to talk about, but they simply won't take the medication. I've had patients who tell me they're taking it and they're not.
Right.
And the outcome is never good with that because then you really don't, you're flying blind, is the bottom line.
Relationships, always having the patient be the captain of the ship. I very much appreciate that. I very much do. And of course, the results of partial or poor adherence with medications can be quite catastrophic. So folks, I got a lot from this discussion on this case. So here's the take-home messages from me. Message number one is, you're not a head clinician. You are a person clinician. Thank you, Julie, for disabusing me of my completely incorrect belief that I was only a head clinician. That's really important. We should appreciate that we're clinicians first and then psychiatry specialists, number two. The second thing to keep in mind for me is obesity is common, period. But I do think psychiatric medications very often carry an extra burden. Three, it's our responsibility to address it. How come this gentleman gained 45 pounds under our watch and we didn't even know? That he had to come back and tell us that his clinician is upset about it? That's not right. I should have been measuring, monitoring this patient. Fourth, don't assume. Get a full history, get a full history. And then finally, if need be, pharmacotherapeutic approaches towards treating obesity is perfectly appropriate. And if you're not comfortable with it, that's okay. There are other colleagues who can address it. And of course, the final thing is losing weight is not all that difficult. Keeping it off is. So we'll have to create a game plan to address his long-term needs. Did I miss anything, folks?
Thank you.
Well done. Well done.
Well, thank you. Thank you. Aye, Captain. All right. Thank you very much. That was a very beautiful case that you helped me understand better. Here's my third case, and this one I really need your help with too. So this is an anesthesiologist colleague who states, I've lost all joy in life. She's a 44-year-old lady, married, 3 children, works as a busy. She's been an anesthesiologist for 20 years at a outpatient surgical center. She has a 20-year history of recurrent depression ever since medical school and has always achieved remission within a few weeks of starting SSRI. She's one of those patients who she starts SSRIs and gets better, but then she stops it. So in current episode of depression, it's about 4 months long. Something is different this time. It's not that I feel depressed. I do, but it's like all the joy has been drained from my life. I enjoy nothing. I feel nothing. I like nothing. Nothing holds any meaning, even my own children. I can't get any good feelings when I'm around them, and that's not like me at all, I swear. This time my depression is different. It feels different. She really wants me to know that this is different. It hurts more. What is wrong? What do we do now? So here's the question, and Kevin, if it's okay with you, I'll start with you. You know what? If it walks like a duck, quacks like a duck, often it is a duck. Are you suspecting what I am, that significant anhedonia is? What was your clue?
When she mentioned the lack of pleasure in life, nothing she's finding joy in. And when she mentioned and describes that it's starting to feel like hurt, she's used to rebounding quickly. And now it's been 4 months and she's stuck. So those are some of those key words. I oftentimes don't hear someone say, I feel like this is anhedonia.
Right.
They describe it as they're not understanding what they're feeling. They just know this feeling isn't normal to feel, especially for as long as they do.
Gotcha. Well, did you get that same sense that this presentation is highly anhedonic?
Absolutely, absolutely. And there's even this sense of hopelessness. I was thinking about some component of her depressive episode this time that seems to be hitting her across all areas of her functioning. When you can't really do and feel for your children, and you're dragging yourself through your days, and you begin to lose hope that you can get that feeling back, that character of this episode is bringing something new and may indicate for us that same old is not going to get us to where we need to get from her previous approaches. So yeah, I think really engaging with her and understanding all those components of what we call anhedonia. Wouldn't be great if patients said, it's funny when they do come and they say things like that. I'm like, well, tell me what anhedonia is for you, because they've read something. But that is what we have to help her, is to understand what is the signature of this particular episode and how it varies from previous
Gotcha.
times.
Mark, I suspect you feel the same way, that her descriptions were very anhedonic in nature, but why does it matter, besides the intellectual curiosity, that we accurately identify anhedonic depression?
Well, I'm concerned about her, and I think there's an urgency here.
Yes.
Because you worry about suicidality.
Yes.
And even recent data shows that physicians have higher rates of suicide. And certainly we have to pursue that and make sure that we've asked her about that. And because she describes this different, and everything is hopeless for her. Nothing's giving her pleasure. So I'm concerned. And I also wonder, is there something missing? Did something happen? Is there something in her marriage, something in her life that's not being said, that's maybe tipped this off? This goes deeper than that, it sounds like, but we need to identify that. And then I would want to be very aggressive with medications. And I think we're beyond SSRIs at this point. She's going to need not only an antidepressant, maybe augmentation. I don't think it's probably premature to talk about ECT, but you always have to have that in the background because, again, I think there's an urgency to this.
Yeah, I identified the same urgency that you're talking about, and perhaps we can talk about it. Depression is a difficult illness to live with to begin with, but anhedonia appears to color everything into a darker shade of worry.
Yes.
You identified suicidality, employment, yes?
Yeah.
Child rearing, yes, and functionality. So anhedonia is not just an intellectual pursuit, it's an important one. And I understand there are two kinds of anhedonia, anticipatory and consummatory. Kevin, maybe if I can start with you, what are some of the practical tips you could suggest on how we clinicians can look for anhedonia, even in patients who don't present this overtly? What questions do you ask?
Well, one, asking questions is key. Oftentimes we get so into routine of PHQ-9, scoring, you don't score high, the risk is low, let's move on. That we pause to just ask, beyond the survey, how is the patient doing? So I would assume that you asked more questions rather than her just walking in, only saying this because she completed a PHQ-9. So I think asking questions is there. And then being consistent, that we remove away from just using terms like anhedonia to allow for the patient to describe more. Then we get a lens of how they're seeing it and the benchmark of where we're going to move from. I'm a believer in, really in my practice, to transform individuals personally by me clearing the way. So I have to go ahead of the patient and I have to assess now and for the future what your current symptoms are, or what are your current feelings. Move away from the word symptoms. Just describe it for me so that we can then have that documented and understood, so that for the day that it changes, we know what the difference of feeling is.
Gotcha.
So a practical tip to answer your question, sorry taking a long time to say this.
This is important.
The practical tip is having a conversational approach where the individual doesn't feel like you just asked me 7 questions that you memorized or 9 questions that you memorized, but really digging into being more conversational. Identify that this is affecting you at home, it's affecting you at work, it's affecting possibly your marriage and other areas personally. Let's dig into that. Today, let's spend time there. And what do you want to feel in your marriage? What do you want to feel at work? Maybe she's tired of being an anesthesiologist.
Yeah.
and she wants to switch
Right.
careers.
Mhm.
I might be placing her in a box by not allowing her to describe what she desires to feel.
A biopsychosocial approach. I love the fact you brought in PHQ-9. So if you look at DSM, item 1 is depression.
Yep.
Item 2 is anhedonia, right? If you look at PHQ-9, PHQ-9 reversed the order. Item 1 on the PHQ-9 is anhedonia.
Yes.
It's that important. And PHQ-9 does us a service. It doesn't ask just about consummatory anhedonia. It talks about are you looking forward to and are you enjoying? Those are two completely different things. So thank you for making a big deal about open-ended questions, but also narrowing the focus down to better understand the patient. And that biopsychosocial approach is just exactly what we should be doing. Julie, help me. I miss anhedonia a lot in my patients. Guide me, please. Couple of suggestions you could give me so that I'm better at identifying anhedonia in my patients?
You know, I was thinking about the question I often ask, tell me about your day. Tell me what gets in your way in your day. Another question I like to wrap up to the point where my kids will say, I'll say, you know, the question I'll ask you before we wrap today. And they'll say, what are you looking forward to? And I'll say, share that with me. What are you looking forward to? Because that gives me a sense of what's happening cognitively. It also helps me to get some markers around behavior across the day and what helps with functioning, what gets in the way. With this young woman, I can't help but think is drinking a part of coping? Is burnout? I love that you mentioned it. Is she burnt out? And is she awakening each day and overwhelmed by the thought of making it through being an anesthesiologist every day? Maybe she's done with that.
Right.
And so we want to continue to not only assess for those symptoms of anhedonia, but get a sense of what they imagine, what they hope for, because she's hopeless. And then that becomes something we can work towards together, with our psychopharmacotherapy, but then also understanding from visit to visit, because guess what? When she tells me what she's looking forward to, when she walks in the door, I'm going to say, you had that visit with your friend from California, because I might put that in my note to also remind myself that our relationship is walking together down that path you've talked about, anticipating what she would like with her treatment and how she will feel better, helping her to build hope with what I can provide to her care and addressing that.
Would you keep her age in mind? Could perimenopausal symptoms be an added complexity to consider?
Excellent point.
The fact that she says something is different, I was thinking biologically is something. Is she starting early menopause?
Yeah.
Is there something else going on? I mean,
right.
Sometimes physical ailments can present like this.
Yes.
And so I would send her to a doctor for full labs and just, again, maybe something missing in her life, and I love what you say about that, and maybe she doesn't want to be an anesthesiologist, or she's going through somewhat of a life crisis, or maybe physically there's something we're missing. But without that information, or alcohol, something like, it will impact our choice of medications. Because clearly with this woman we're at the point where we need to start thinking about medication.
I like that. Look, when we use binoculars, we call that binocular vision, but in psychiatry we have a trinocular vision, don't we? Biological, psychological, social, and that's the lens I should be wearing. Mark, when I presented the case a few minutes ago, immediately I saw a flash of concern on your face, and you alluded to it. You said, this is someone I worry about. And if I'm understanding you correctly, what got you worried was the presence of nothingness in the presence of everythingness, which is anhedonia. And you said she's someone I would worry a lot about suicidality, and she's graduated into, if you will, holistic but still aggressive treatments. Let's make the assumption she's been on SSRI for 4 months. It's done nothing for her. What's your next step?
If it's done nothing for her, I would take her off it and think about a different antidepressant.
Okay.
Maybe something more activating, like bupropion.
Okay.
But I'm also in my mind thinking about augmentation as well, because
with what would you consider?
Well, to me, lithium augmentation is one of the most powerful, but you have to keep in mind the physical aspects of that. So I think we typically think of antipsychotics as probably before lithium. So one or the other, depending on the depth of her depression and what kind of response we see from a medication. And I think, you know, an SNRI would be an option, and bupropion could be an option. You know, in this case, we don't just want response, we want remission.
Yeah.
But if we can only get a response from the antidepressant after a good, adequate trial, the right dose, then I'm thinking about antipsychotic augmentation or lithium after that.
So a lot of options, but what is not an option is to do nothing.
Absolutely.
What's not an option is to not practice evidence-based, measurement-based care. Thank you very much. Julie, you alluded to medications are important, but there are non-medication things you might offer this patient. Could you name a couple?
Yeah, I'd like to talk with her a little bit about her supports, any connection she has that's helping her manage her life. I'd like to hear about her sleep and if that's been disrupted and if that's something we might address. I want to also hear about her overall health status. We have talked about that.
Right.
And stress management and what she might be doing to sort of address what happens with the hopeless thoughts that she's having. So a CBT approach.
Oh, I like that.
Or even, you know, I know we have new digital therapeutics that might, with a busy person, help her to be able to glob onto some of those CBT tools to help her in her very busy life coping. And as I think Kevin said, this person will be kept very close. I'd probably see her very closely so that she would begin to see some hope. And at the very least, our relationship, she would know she wasn't walking alone.
Yeah. Thank you. Thank you both. Yeah. Kevin, she's an anesthesiologist. Anesthesiologists have the highest rate of suicide amongst all medical professionals. How do you suggest I evaluate her for risk for suicidality? We only have about a minute left, so let me ask you to offer me some quick thoughts.
One, give her the safe space to be able to have that conversation. And the approach that I would generally take is actually to discuss potentially moving to a short-term leave, that your job and what you do is so important that it may be time for us to take a small break, and don't give a time frame of that, but will you consider taking that break? I'm giving you permission to take that break so that you don't feel as though you're letting your family down, your colleagues down, but taking that time away to then allow for you to take some time to get better.
Gotcha. And direct asking of questions is always the best thing to do. Folks, this case had me worried too. And thank you all, three of you, for your sage advice. And I'm sure our colleagues appreciate that such patients are common and they're commonly ignored. So Mark, Julie, Kevin, thank you.
Yes.
And thank you, dear colleagues, for being with us. And I have three quick practical takeaways for us. Evidence-based medicine and clinical wisdom, when they are brought together, it's a marriage made in heaven. 2, all cases are complex, but some cases are more complex than others, as we learn from these three situations. Thoughtfulness and careful analysis of the situation is, of course, appropriate. And finally, logical case formulation is always the right way to go when you're caught in a situation where the cases might seem very complicated. With that, thank you very much for being with us, and we will see you down the road. Thank you all three.
Thank you.
Cut.
Oh my God, you guys are awesome.
Yeah, good.
Thank you.
Great discussion.
Yeah.
Wow.
Great discussion.
Really great.
Nice
Deep.
cases.
The lead thing. What a
cases.
what a good idea. That's really what.
Yeah.
You know.
And we brought wisdom.
This was fun.
Wasn't that fun?
This is fun.
Wasn't that
my
fun?
first time having this?
I know.
This would be, you know, a good consultation for people.
Well, this
When you
is
think
what they
about-
crave for.
Yeah,
You know,
that's true.
No,
That's true.
regardless of where I'm at, people say, I'd like to get a senior consultation group together.
Yeah.
Not newbies, but folks who've been in practice just to have these discussions.
And I don't know if anyone is doing that. I know, you know, once they did that, but it was incredibly expensive.
I know.
And as a whole procedure. But it makes sense, you know, to have a smaller, because it's really, these cases are getting more complex.
I
there's no
agree with
question.
you. And the fact that even though it's over and we're still so deeply in conversation,
these
shows the value of
great
this connection.
Does.
Really,
It does.
really good case.
And it happens consistently, doesn't
Yeah,
it? Every
it
time we
happens.
do one of these.
Yeah.
This has to be one of the top hits of
It is.
regionals.
Yeah.
It was the
I
top.
So
really-
clinically relevant.
I
right?
know. I love when I go and learn all this stuff, and it's
Of course.
it's great.
Yeah.
Thank you.
Yes.
Yes, thank you.
Let's do it. Yeah.
You simulated, they simulated the take homes perfectly at the end.
Yeah. A master.
I was just listening to you and like a parrot, just reciting it forward.
I believe
It's quite a skill.
I'm
We're
here
we're
on
doing mics
two
for
of
both
us.
you guys.
Oh, good.
Because
Okay.
we're doing.
Yours and
Yeah.
I hope he's here early so we can.
Wouldn't that be so you
It's
can
only
get
three-
off?
We're already. It's only 3:00. This was supposed to be over at 4. So
Oh, so maybe he's here.
rocked it. Yeah.
I'm gonna just get something to drink.
I'm
Yeah.
on the train. If we can get way ahead, let's get way ahead.
Yeah,
We're
we're.
with Mashumi, it's Kevin's first psych regionals.
Yes.
Oh yeah.
Oh, we're doing pictures. Okay. Come on.
Oh, yeah,
I
of
won't do
course.
this because I want to stay. Well,
No, you're fine,
whatever.
You're fine.
That's great. Thank you.
Whose camera is that? Yours? Would you share it?
Yeah, share it.
Okay, sweet.
I want to do this.
Is our speaker here for the?
Yeah.
And
I would love that.
I'd love to
Oh, great.
you all.
Because we're eager.
time.
Oh, you're doing it from there.
Yeah,
How
it's
cool.
not, because it's in the ceiling, everything's Bluetooth, so I can
That's
control all the lights in here.
beautiful.
Nice.
Yeah, so I can turn that off, turn it on.
Yeah, with my tan, you better kick it up.
Boy, it was a lot. Your hair is so shiny, and I was like, okay, I gotta turn it down.
It's the brain power, dude.
Yes.
That's right.
You just
It's-
radiate.
Thank
know.
you. See, finally, somebody gets it. Finally, where have you been all my life? Nobody's ever said that about me. You're the first one.
All right, cool. We are set.
Oh, I like how he's pimping it.
Timer. 45 again.
Oh, this is the last session.
Is there any way that you can make
Very
the
nice.
title
Got it.
a little larger, you guys?
Yes, certainly.
On that screen, because I know you want
Yeah,
me
we
looking
can make all
there.
the text larger on this.
Thank you.
Trying to avoid scrolling, but that's okay. Is this,
Yeah, and I don't know, if you keep that there, I don't really need this paper, if that's okay. Thank you.
Thank you. Here, I'll make the body bigger, so after you leave the title, I'll scroll down to the body.
Thank you. That's perfect. And if you just leave it there, that's beautiful. But I just want to read the title.
All right, let's roll camera.
Audio, speeding, ATEM, speeding.
Speeding. Do you mind hitting this here?
You're gonna have to guide me on this
Yep.
one.
Forward. Good. I'm good on my camera. Good.
You still good, Harrison?
Yeah.
Mark. Getting a bit of noise on B.
Should I be trying to look at the camera or just?
Oh, yeah, let me tell you.
Just.
Yeah, we're going to talk together.
And it's just fine to look at you. Okay.
Yeah.
Got it.
Yeah, when she does introduction, you're looking straight ahead, everybody's looking here. But then as soon as questions get asked, you're just like,
Okay. Got it.
Okay, we're good.
All right, I'll count you in. Ready in 3, 2.
Welcome back, Psych Congress family, and do we have a discussion for you? We have a couple of experts here, Rakesh and Phil, and myself. We're going to be talking about solving the sleep puzzle, a multidisciplinary discussion on insomnia, mental health, and evidence-based care. Sleep and mental health. Married, aren't they? They're
are.
so married. And what a good time for us to talk, especially with you, Phil, and Rakesh as well, about what do we do about this marriage and teasing it apart with patients who are experiencing problems with sleep. So shall we start first talking about insomnia?
Absolutely.
And what is insomnia? Maybe, Phil, you can tell us a little bit about what is insomnia, and then we can speak to mental health.
Sure. So the definition of insomnia is actually quite simple. There's two main parts to it. The first is that people have difficulty falling or staying asleep. That's pretty obvious. The second part is that it has to cause some sort of significant distress or impairment in functioning.
Yeah.
I mean, there's a few other kind of nitty-gritty details, but it's that's really the essence of it.
So it's not just having trouble falling asleep or I wish I could sleep better. There's this actual criteria.
Right.
And it can be impairing either at the onset or duration of sleep.
Right.
What about tools that help us to detect, is this insomnia or what is this?
Yeah, and their thinking on that has changed over time because it used to be thought that if someone was complaining of sleep problems, but they also had depression and anxiety disorder, that really that was what you should focus on and not add a second diagnosis. But we've now learned that most of the time, even in the presence of these comorbidities, it warrants making a diagnosis of what we would call insomnia disorder as well. And so that from a diagnostic perspective, that makes it a little bit easier because you don't have to do as much trying to tease them apart as we used to try to do.
Yeah, yeah. Rakesh, do you want to speak to that a little bit about how we sift that apart? And we'll talk more about medications, which adds another layer of confusion around sleep issues.
Yeah.
But what do you think? Insomnia, psychiatric disorders?
insomnia is the one central condition I encounter probably 95% of the patients I see.
Yeah.
I think we should step back for a second and perhaps think about what is the purpose of sleep? Maybe looking at the physiology before we look at pathology. And I think the purpose of sleep, the best we know now, is so that we can function ideally in the daytime. So DSM was rather clever, and so was the International Society for Sleep Medicine, which is to not let us just look at sleep, but the consequences of lack thereof.
Right.
So it's shortened duration or difficulty falling asleep or staying asleep with consequences. Now that's where psychiatry comes into conversation, because the consequences often are fatigue, poor concentration, mood difficulties, anxiety difficulties. And now we know that people who don't sleep adequately actually have a shortened lifespan.
Yes.
Probably because of the inflammatory basis. So the thinking in psychiatry is if you have 3 nights of these challenges per week for a duration of 3 months, then we start calling it insomnia disorder. And I think I kind of like that, that you don't jump too quickly into making a diagnosis, because that would be bad. And also it's not required to be on a daily basis. In fact, insomnia may be the only disorder in all of DSM, as far as I'm thinking, where less than 50% of the presence of a disorder is still a disorder. So that's my thinking on insomnia. The other point we should probably make is insomnia is probably the single most common symptom of depression untreated, even after you treat it. So I think of insomnia as a worthy foe. I'm not the only one. Shakespeare thought that. So every play, which I was forced to read, a lot of them in school, but I'm so glad I did, because even Lady Macbeth, in the play Macbeth, her descent into madness was driven by insomnia.
Yes, yes. And we see that so often. And in the pediatric space, I see a longitudinal problem with sleep for many of our kids, even pre-treatment. And families will come in and talk about they were never a good sleeper. They still continue to have things like nightmares, tantrums. There's all sorts of characters or flavors of problems with sleep. I don't know if you want to speak to just that population for a moment, and developmentally, what happens with sleep and insomnia.
Yeah, absolutely. Sometimes it's a little difficult to tease apart in kids, like when is this now a problem?
Right.
Because some nighttime difficulties, of course, are just normal. And we know from a number of studies that oftentimes parents' perception of the severity of their kids' sleep problems is not the same as the kids themselves, because they will often stay in their room, especially older kids. And so parents often are unaware of the severity to a certain extent.
Right. Right. Yeah. And so they may report differently. And I just read a recent study too on kids with ADHD and quality of sleep versus time asleep.
Yeah.
And it was really pointing to the quality of sleep as being more of what we're looking for versus the amount of time. And I think sometimes we think about how many hours of sleep did you get, and rather than was it restorative, was it doing those functions that you pointed to?
And also yeah, you're right, Julie.
Yeah.
Even context dependent. So let's talk about ADHD. As a child psychiatrist, I often get kids referred to me because they have insomnia, and they actually don't. What they have is a mismatch between their circadian rhythm and cultural demands.
Yeah.
So if you fall asleep at 1 o'clock and you gotta get up at 6 because school starts at 7:30, well, technically, you got reduced sleep, you got daytime functioning, it's insomnia. But DSM doesn't permit that.
No.
DSM says, did they have adequate time to sleep?
Yeah.
If they didn't, then guess what? It's not insomnia, it is something else.
Correct, yeah.
In any particular, you mentioned a manic episode after a couple of nights of sleep. That's something we see quite a bit. Or depression. Sleep continues to be problematic. Another study that came out this past week too was around anxiety and impairment with sleep. And the idea that it may not just be around rumination, there might be something else going on too. Anything you want to comment on about what, in terms of psychiatric diagnoses and sleep, where you just go right to it as, oh, we really have to? Or is it every psychiatric diagnosis?
I often think about sleep as an emotional barometer that We know that changes to sleep are some of the most common prodromal signs of a depressive episode, a psychotic episode, a manic episode. So sometimes it's how are people sleeping typically, but especially paying attention to those sudden changes in sleep, because so often worsening of sleep precedes a worsening of mood, anxiety, whatever it may be. So it's kind of that harbinger of things to come.
Yeah, and in child psychiatry, we're often asked by parents to get a sleep study. I'd love to tell you they come with robust results that really help me to figure out how to help a family. I wish I could say that.
Yes.
But families come requesting that. What do you think we can do to maybe shift some of that? I'm not saying there's not value. Occasionally, we really pick something up. There's a strong intervention. And maybe it's the same in adult psychiatry, Rakesh. I don't know if you feel the same way, but what are your thoughts around an evaluation of insomnia and sleep studies?
So sleep studies or polysomnography are not considered to be part of the routine assessment for diagnosis of insomnia at any age, because if a patient comes to me of any age and says, I have insomnia, at most what I'm going to see in a sleep study is they don't sleep well. And that, they just told me
just
that.
Validates
yes,
it.
exactly.
Yes.
And so we're not at the point with the science where we can say, well, based on these specific features of your sleep study, that you have this type of insomnia or this, we're just not there yet. So right now, most of the time, the sleep study really does not yield helpful information.
Sort of like getting an MRI for a psychiatric disorder. It might, I don't know, is it going to tell you so much? It might rule something out. Well, such an important point, Phil. Do you want to say something more about that?
No, I'm just listening to you.
I know, it's a great point. Yes, yes.
Just because a test is available doesn't mean it should be ordered.
Right.
And with insomnia, the architecture of the sleep is compressed but not abnormal.
Yeah.
So it won't be helpful. But I will give you a couple of examples where it could be helpful. So if a person reports daytime fatigue and I don't think I'm sleeping well, and the wife reports or the husband reports snoring, and there's obesity, and you're trying to rule out something extra, then it might be. But what I do find is sometimes in my profession, the lack of confidence in accurately diagnosing insomnia leads to an incorrect recommendation for a PSG.
Excellent.
And we should avoid that because it's very expensive.
Right.
It delays treatment. Sleep or insomnia is a leading cause of motor vehicular accidents. It's a pretty prominent cause of academic failure. It can be a challenge in marriages. If you encounter insomnia disorder, treatment as soon as possible is appropriate.
Right. And that lends itself to this question about screeners. How, I mean, I know we all have technology now that might tell us about our sleep, but if you're a clinician and you're really trying to sift through meeting these criteria, what do you recommend, or what are some good recommendations?
So there are some really nice brief screening measures out there. Some of the more commonly used ones are the Insomnia Severity Index, nice 7-item brief screener.
Perfect.
You can get a total score that gives you an idea of how severe people's sleep problems are. Another one is called the PROMIS Sleep Disturbance Index, really created by the NIH. So those are my two go-tos usually.
And I read about a pediatric one, the bears.
Yes.
Which I really liked. It was like, what do they look like in bed? What is the bedtime routine? Sort of their experience or the extension of sleep. And so an acronym that just helps parents to organize beyond they flip around in their bed a lot, or it really helps you to be more concise.
Yeah, exactly. Yeah, that's especially important when it's young kids where they're not the ones who are really going to be filling out a survey. So that can be a helpful guide for parents.
Right. And I know something I use in my practice is just some sort of a recording or a measure around sleep, because that, I feel, helps us set the table for interventions we're going to be talking about in just a bit. So also having a way for them to track it so that we can conceptualize where is the sleep impairment and how is it impairing your functioning, and what's the quality of that sleep.
Absolutely.
A sleep diary can be magic. I mean, the simplest, the goofiest,
whatever they
on
bring.
your iPhone notes can be incredibly illuminating. Bedtime, 1 o'clock. What did you do? 2 hours Netflix. You know, that's sort of basic. When did you last have your coffee? I too like the ISI. let's remind our psychiatry colleagues that every PHQ-9 actually has a line item on sleep.
Yes.
Let's remind every one of our psychiatry colleagues that even the childhood depression
Yes.
rating scale, the CDRS, actually has, if you're using the HAMD, HAMD actually measures sleep 3 different ways.
Right.
MADRS measures it. So even if you're not comfortable with using a scale, create your own scale, which is sleep diary. Number 2, all of our pre-existing scales already have an item that focus on sleep.
Yeah.
And it's something that I ask each time I meet with my patients. Tell me about your sleep. And occasionally I'll have a patient say, you know, my sleep has never been a problem and you always ask me about it. Just occasionally, more often than not, we talk about the continued challenges with sleep. And it is something that I document each visit because it is a barometer. It is a way that we can measure overall mental health and wellness.
Yeah. And what I appreciate about that is we know studies have shown that most of these data are from primary care settings, that a lot of patients with insomnia will never mention it to their healthcare provider unless they're asked about it.
Oh, wow.
So that's great to hear that you ask everybody.
Yeah, interesting.
It's like a thermometer,
Yeah.
right? It's a metaphorical thermometer you get to put in the person's psyche to get a measure of sleep quality, daytime functioning. I almost wonder, why don't we have essential vital signs in psychiatry? And if we did do that, I bet you in the top 3 would be sleep.
Yeah.
Absolutely. Absolutely. So critical. Should we start digging into CBTI? I want to really tap into your wheelhouse. Can you tell us generally about CBTI? And I think I hear a lot of people talking about CBTI, like, oh yeah, I've done that. I know what that is, but just to help us to understand the concept first.
Yeah, sure. So for anyone not familiar with this abbreviation, it's just short for cognitive behavioral therapy for insomnia, which I often argue is not really a single treatment. It's a number of treatments that were pulled together into a coherent kind of treatment package. As far as psychotherapies go, it's fairly brief, usually 6 to 8 sessions. And it has a very high success rate, even in the presence of different psychiatric comorbidities. And the way I often describe it is when people have had trouble sleeping for a while, it's like a bad habit their body gets stuck into. It's the cycle that has developed. And what the CBTI components are designed to do is use different strategies to break that cycle and retrain the body into a healthy pattern of sleep again.
So very much like CBT,
yes,
where you're really looking at cognition and behavioral interventions, but really forming around sleep.
Exactly.
Yeah, yeah. Wonderful. So short-term course, mostly psychoeducational, and very individualized focus on whatever elements of sleep you're addressing.
Exactly, and this is where the sleep diaries become in, because that's really an essential part of CBTI, because what we're trying to do is use each individual's unique sleep patterns to customize the treatment so that it's really tailored to the individual.
And Phil, those outcome statistics are pretty robust, aren't they? Like you run through that course, and what is the percentage where they're going to see improvement?
So from the clinical trials literature, which of course is often does not include some of the more severe kind of comorbidities, but it's about an 80% response rate.
I was remembering 80%, but then I thought, could it be?
I mean,
80% response
yes.
to CBTI. And so that's what I've been telling my patients when we begin to walk down the road to CBTI. Yeah.
It's amazing. And I mean, and of that 80%, about 50% of those will be completely insomnia free at the end. They're a great sleeper again. The other 50% will be significantly better, but maybe still some residual sleep problems.
Okay. But then have a better understanding about what they might tap into.
Exactly.
Can you give us some examples of where you start and what it looks like?
Absolutely. So the start is always the sleep diary. So we do kind of an initial evaluation where we're trying to understand what are the specific patterns or cycles that this individual has gotten stuck into over the years, or even decades for some people. Send them home with a sleep diary. They come back a week or 2 later. And typically where we start is with 2 treatment components called stimulus control and sleep restriction.
Okay.
So stimulus control is based on classical conditioning principles. So I always say when people are good sleepers And each night they get into bed and they fall asleep, and they do that night after night. Just getting into bed triggers this conditioned response to sleepiness. That's what we want. Now, when people have insomnia night after night, they develop this association between being in bed and being awake and thinking about things. So for them, the bed is a cue for arousal and wakefulness rather than a cue for sleep.
So the brain immediately says you're not going to be able to sleep. You're in your bed, you're going to have another one of those restless nights.
Yes.
You can see where the train of thought begins.
Absolutely. So what we teach people to do is some pretty basic strategies of don't go to bed if you're not sleepy. If you're unable to sleep, get up. We want to really cut down on the time people spend tossing and turning in bed. Using the bed only for sleep or sex. And just trying to keep a regular schedule in general.
Yeah. And I recently learned that the morning awakening is more important than the bedtime, or does that really make a difference?
Some studies have suggested that it's the morning awakenings that affect people more during the day, but there's a lot of inconsistency across studies.
That's good to know. So
Yeah.
we're sticking to our old byline of consistent bedtime, consistent awake time.
Exactly.
Okay, okay. So that's where we start.
Yes.
With sleep CBTI.
Yes. The next step then usually has the awful sounding name of sleep restriction therapy.
Yeah, don't
Yes.
take away my sleep.
Yes. And I should say I don't usually use that term with my patients.
Yeah,
I
yeah.
say we're going to use sleep consolidation, where what we're actually doing is using the sleep diaries to figure out how many hours of sleep is this person getting per night on average, and then we temporarily restrict how much time they're spending in bed to their total sleep time.
Okay.
With usually a minimum of 5 to 5.5 hours per night.
Okay.
So we're essentially trying to use some mild sleep deprivation to our advantage. And when that people do that night after night, they come back and they say, I'm now falling asleep faster, I'm spending less time awake in the middle of the night. And then we gradually expand their sleep schedule again until they're getting better quantity of sleep.
Got it.
Yeah.
So that's the next step.
Exactly.
Consolidation.
Exactly.
Okay.
And it gets back to your point earlier, Rakesh, of quality versus quantity.
Yeah.
Or maybe you were mentioning that. That we've developed this kind of obsessive focus on the quantity.
Yes. How many hours did you get?
Right. Sleep restriction is really focused on the quality.
Yeah.
Saying, let's get you good quality of sleep before we deal with the quantity. Yeah.
And then what?
So then it depends on the particular person. We're almost always starting with those two. Then we may pick and choose a bit. Oftentimes we're integrating various relaxation strategies to help people physically and mentally wind down before bed. Sometimes we're doing some cognitive therapy strategies because people with chronic insomnia often develop very strong beliefs about their sleep that we're trying to target.
Yeah.
And then one of the things that often people will start with, but we actually typically save for last, is kind of the umbrella of sleep hygiene.
Yes.
So people's kind of daily practices and caffeine and exercise and how that affects their ability to sleep at night.
Right. Often the things that people say, oh, I've tried these things before.
Yes.
But it's nice to have more knowledge about what's under the umbrella.
Exactly.
So that we still have, well, did you also try this or
Yes.
that? So that encapsulates CBTI.
Yes.
It's accessible. It's easily accessible. Is that right?
Well, it depends on where people are. I mean, there's been decades of trying to increase the number of providers with training in CBTI. It's still, given that insomnia has about a 10 to 15% prevalence, chronic insomnia in the population, there's still not enough providers to meet the demand. But what's been really nice is there's a number of different digital options available.
Right. Tell me about that.
So one is, first there was a couple of iterations of internet-based treatments. And so some of those are now kind of commercially available.
One was through the VA or something, wasn't
Yes.
they? They launched one that...
They have one called, it was called Path to Better Sleep. They just recently rebranded it, and I'm blocking on the name.
That's
but yes,
okay.
there's a free VA program out there. And then the VA actually then took that internet program and turned it into 2 free apps for your phone. One is called the CBTI Coach, and the other is called Insomnia Coach. The second of those is the newer version, where it is a self-guided full program to take people through the steps of CBTI.
Very interesting. And some modifications, too, for younger persons, too?
Yes, there can be, because oftentimes, especially when we're talking about teens, young adults, oftentimes that circadian rhythm piece comes in where they're still on that kind of adolescent delay in their rhythms.
Yes.
So that kind of gets combined with their insomnia for kind of to magnify the issue.
Mm-hmm. Mm-hmm.
Yeah.
Rakesh, have you incorporated CBTI or had patients walk down this road in trying to address?
I got lucky. I went to a training program that I had a colleague of yours there. And even though I'm a psychopharmacologist by trade, I was trained very early on to respect non-pharmacological treatments, and CBTI became something we were trained in. I got to second what you said. CBTI can be very effective. And one way I explain it to patients is I tell them 3 things interfere with your sleep: your thinking brain, your feeling brain, and your lower part of your brain, brainstem. We really have to bring all 3 of them in line. So I'm using metaphorical language. So your thinking part, the cognitive, your lower part will use behavior, and then we'll get integration of sleep. Patient acceptability for CBTI has been high.
Very high.
Yes.
The only ones who oppose me and push back on me are the ones who either I or my profession got overused to using medicines to sleep. They've gotten so used to taking their Ambien or Xanax to quote unquote knock them out. They
For a
don't
glass
want
of wine.
or 2.
Or 3.
Yes.
Or 3. So it's not so much their fault as it is the system. But CBTI has been very effective. I use CBTI Coach a great deal.
Nice.
I did not know there was an updated version, but now that you shared that with me, I will be using it. I think no prescribing clinician should prescribe a medication without giving first great consideration to CBTI. It's not intimidating. It is approachable, and if you have a colleague who's trained in it, we really should take advantage of that.
And this is one of those areas of our practice where motivational interviewing really can make a difference, because sleep is probably the one thing I can get teenagers to buy into wanting to improve.
Yes.
Probably many of my patients to be able to want to improve.
People will forgive me for leaving them psychotic for 2 weeks. They'll forgive me for leaving them depressed for 6 weeks. They'll forgive me none if I make mistakes and, God forbid, make their sleep worse.
Yes.
Or don't help them with sleep. So of all my hierarchical ordered treatments, if I can help a person with sleep effectively without damage to them, I end up developing a lifelong bond of trust and comfort with my patients. The challenge is, Julie, CBTI takes time.
It does.
And I have to be very thoughtful in how do I maximize my output, knowing fully well that while CBTI will be effective in the long run, this patient will not give me even a week. So I have to be thoughtful about combination treatments if appropriate.
Yeah, absolutely. And the field for years has tried to find what's a good combination approach. Like, can we take advantage of the more rapid effects of medications while people are learning the CBTI strategies, and then as they're breaking that cycle with the skills, taper down off the medication? I don't think we've quite found the ideal way to do that, but I think there's a lot of potential.
Well, and a lot of risk. We know that insomnia can really increase risk of suicide in our patients especially. And so there's been some great data that shows improving sleep is going to help with reducing risk.
Absolutely.
So you feel that tension of wanting to do something quickly, but then also do something that sticks and that works and has our patients more functional across the day. Yeah. While we're talking about medications, maybe we can go there for a moment. Rakesh, what are the most commonly used medications across psychiatry that we have for sleep? And I hate to just lump them all together. Maybe first talk about if we're adequately treating our psychiatric illness, does sleep improve?
Sometimes, Julie, sometimes. So DSM-5 did us a solid, as the kids say. What they did is did not allow for insomnia to be mostly secondary to every disorder. Now we have the freedom to call it what it often is, a primary condition. Then you would not expect it to necessarily improve. So it's a complex issue. Sometimes I will encounter children with ADHD who have severe insomnia where a stimulant fixes the insomnia.
Yes, yes.
Which paradoxically should not make sense, but it does make sense. You're taking care of the underlying disorder, and sometimes that takes care of things. But often that's not the case. And Stardy taught us a very tough lesson that of patients who had partially responded, 94%, that's a strikingly high number, had residual sleep problems. And patients who had had no response, 90+% had residual symptoms. But we also know that if you take care of sleep through hopefully appropriate means, the output for depression increases. So what do? Well, I wish I could give you one answer, but very often I have patients who leave me first appointment with 2 medications and a third non-medication medication, which is recommendation on CBTI. I have found that unless I address sleep quickly, I tend not to get the outcomes that I'm looking for.
Right.
And as a result, I fall, even without evidence at the moment, in the camp of come in guns ablaze. Carefully, but come in with aggression. But perhaps develop a contract with the patient that this intervention is short-term, 2 weeks, 3 weeks, 4 weeks, and we'll pull that away and we will see how things are. Does that work every time? No. I think I sometimes trap my patients into long-term treatment, but I sometimes just have to take that chance because they're so ill on day one.
And it's almost like a priming the pump. Like, let's get that sleep taken care of so that the other treatments can work even better.
I love the way you phrased it, which is priming the pump, because my antidepressants are very slow to begin with. And the ones that are fast are not very good at sleep. So I'm now in a double bind. So I agree with you. I see it as priming the pump, and more often than not, that strategy does work.
Yeah. I often refer to it as resetting. Let's see if we could just reset this rhythm along with these other strategies. Do you have some go-tos, Rakesh, within
In
our
terms of
psychiatry
medication?
wheelhouse?
So I think you're going to hit me. Don't hit me hard. I have a sore left arm. So the American Society for American Medicine frowns upon a few treatments that I do use. So, and you have to correct me on this wrong, they don't look too favorably upon trazodone.
Yes.
But trazodone is one of the more common medications we use. Does it work? Well, the evidence from studies is not very favorable.
Right.
But in real life, I don't know if it's I'm priming the pump psychologically. Am I taking care of the antidepressant effect? But I still use it, and I still find it to be beneficial.
Me too.
You too, okay.
It is one of my
Okay.
go-tos after melatonin. And usually when patients will come and say, I've been trying melatonin, it's petered out, that might be one of the go-tos.
Gotcha. So here's a real conflict between evidence and expert guidelines.
know.
But as we are struggling with it, I'm happy to change, but it's not been that easy.
Yes.
I must say, very many of my patients have found their own ways of doing it that are not effective. Valerian root is very common. I try and dissuade that. I am surprised how much Benadryl.
Benadryl, I was going to say.
Yeah, which is not in their best interest, but there are patients who will not listen to me and say, this is about the only thing I'm willing to do. I want to be honest with you, I'm using it. I tell them about the long-term consequences, and in time, hopefully, we can wind it down. I do turn to my Z drugs.
Yes.
And there I do have to create a patient contract, which is let's start with 2 weeks or 3 weeks or whatever. This is how we, and I don't actually give a month's worth. I give funny numbers. I give 12.
Yeah.
I give 14 because I'm trying to emphasize to them how seriously I take the short-term nature of it. It's been very interesting. I thought patients would fight me. To the contrary, they have thanked me for doing 2 things at one time, which is taking care of the sleep now yet alerting them to the possible long-term challenges. And they've said, if I only knew that at the very beginning, I wouldn't have been caught in that trap. And most patients actually walk away from the Z drugs if I have done my job well. So what I'm finding is I'm the missing ingredient. If I do my job well, patients get the benefits from sleep medications and then don't get trapped.
Yeah. I like the way that you educate them up front, because I think we know that a lot of patients are afraid to take sleeping medications because there is this perception of, once I start taking this, I'm going to have to take this forever. So I like that you're setting clear expectations with them.
I learned that only the hard way. So I will profess complete guilt that without meaning to, I thought, I'll tell the patients 3 months later, because what's the point? Today they're so sick. And they have really been disappointed in me. They've said, I had a right to know. I wouldn't have said no, but I had a right to know. So I stand as a perfect shining example of what not to do. And I'm happy to admit my mistakes. But also, the thing to do is to bring the patient into the conversation. I've never met a patient who intentionally wants to do harm. They just want to be educated.
Right. And I like what you said, Rakesh, about there's a whole array of other things my patients will use. What came to mind immediately was cannabis. And I hear about cannabis use. Another medication that I see quite a bit is off-label quetiapine.
Yes.
And risk versus benefit. How do we navigate that? In terms of if it's working, does this bring risk? Maybe clonidine is another medication that's used quite a bit in our practice too.
Yeah, when they have PTSD along with insomnia, often it can be helpful in all ages, interestingly. Again, it's not a medication recommended in the literature. Quetiapine is a great example. I have often seen patients come on quetiapine for reasons that I cannot logically discern.
You and me both.
But they're trapped.
I'll add my name to that as well.
So I think someone who's very well-meaning 20 years ago started it without warning the patient. Now the patient is trapped. Now here's the great tragedy. I am seeing patients who've never taken anything but quetiapine who developed tardive dyskinesia. So it's now a catastrophic challenge.
Right.
I often think of quetiapine as the golden handcuffs. They get slipped on you and you know, oh, look at my shiny, but they're handcuffs. The half-life is 5 hours and the withdrawal is wicked. So if a patient's trapped into it, there are ways of bringing it down, and I try and do that, switching CBTI has been very helpful in that context. But I do believe there's a segment of the population, not a large one, but a segment of the population that simply don't respond to benzodiazepines, Z drugs, CBTI. They just don't. So they're reluctantly, with the patient's full consent about the potential harms, we continue the medication, but we try and chip away at it.
Thank you for addressing that. I think we saw a wave of common off-label use that hopefully is dissipating as we learn more CBTI and other approaches.
I think the availability of an app is important for the patients, but I think we clinicians need to know about the app. You can't recommend something you don't know. I became very familiar with CBTI Coach because I used it on myself, and I don't have insomnia. And I was astonished how much I learned about my own sleep. I did not know, for example, about my caffeine intake late in the day. I just saw it as no big deal, and I was not aware of how much I use my laptop as a bedtime companion. I have some really bad habits, and I don't even have insomnia, but to prevent it, I was able to address it with patients. The most common thing I hear after they get the CBTI Coach app recommendation from me is this: I didn't know how much of a role I was playing in my sleep difficulty.
And that's the essence of CBTI.
It is, absolutely, because so many of the things that can fuel insomnia are the logical things you would do if you were having a bad night of sleep. And so it just makes sense, if you're not sleeping well night after night, to spend extra time in bed at night. to take a nap during the day if you want, to have some extra caffeine. I mean, this just makes sense. And if it's short term and it breaks the cycle, great. But that can actually contribute to that long-term problem.
What about daytime awakeness? And just these dips in the day, or do you want to talk about that?
Sure. So we all experience that afternoon dip in alertness, which is actually a product. People often think it has to do with the food they ate at lunch. And while that can play some role, it's largely because of our circadian rhythm, that there's just a dip in our alertness rhythm in the mid-afternoon.
I see.
And the good thing is, for a lot of people, it's fairly predictable in terms of what time it's going to be. And so I always just encourage people to just plan ahead and to say, well, if your dip's at, say, 2 in the afternoon.
Mine's at 3.
Yours at 3, okay. I'm an early bird, so mine's like 1.
Okay.
But I just plan that, okay, maybe that's not the time I'm going to take an important meeting.
Yeah.
Or that might be a good time if I can take a short walk, get some sunlight. And so it's completely normal. Of course, the more sleep-deprived people are, the more they're going to feel that extra sleepiness during the day.
Yeah. And then, of course, we have to cover screen use.
Yes.
So, I mean, you mentioned it yourself. It's great to have an app, but it's another screen.
Yeah.
I will confess, I was trying to do meditation in bed one time on my screen. Fell asleep, and my iPad hit me. Thought somebody punched me in the face. It's this delicate balance of wanting to do the right thing.
Absolutely.
But then exposure to screens. So tell us a little bit about that.
Sure. So there's 2 components to it. One is the content of what people are doing on their phones. A meditation app I'm going to be less concerned about. But when people are doom scrolling, right before bed, that's a stimulating activity, and that's going to interfere with falling asleep. So there's the content, and then there's just the light exposure. So we normally are producing melatonin at night, but light exposure suppresses that normal melatonin production. And the color of light that has the most suppressant effects is blue light. And it turns out our screens give off more blue light than any other color. So I always say, if you ask me to design a device that would interfere with sleep as much as possible, I think a cell phone is exactly what I would have developed.
Does a great job of it.
Yes, and it's right in front of our eyes.
Right.
America is on a collision course with insomnia.
Right? Yeah.
There was a cover of Time magazine you two have probably seen. It's called Insomnia Nation. And it tracked sleep. I don't quite remember for how many decades. And we Americans are sleeping the worst that we ever have. And I think you're exactly right. So much of it is habit-driven. And that's what CBTI is doing. It's trying to break cognitive and behavioral habits that we humans have.
Yeah.
And what about those that have this robust nightlife? I know our teens are all up late, and that's a time for socialization. And so, how do we flip that?
It's challenging. It's a little easier with adults who may have a little more control over their schedule. In just the last few years, one of the things that more and more studies are finding is, while the amount of sleep people are getting is a predictor of mental health outcomes, the regularity is actually emerging as more important.
Yes, okay.
And so what's challenging is when people are on one schedule during the week, and then they shift later in the weekends, and then they shift back during the weekday, it's actually referred to as social jet lag, because it's like it does the same effect on our body that jet lag would have. And so what I'm always trying to balance with people is, I say, I'm not trying to take away your social life. I'm not saying you need to sit inside and do nothing all the time. But where do we find the right balance that gives you that social outlet, but protects your sleep as much as possible?
Yeah. My thoughts are going in a million directions. Shift work.
Yes.
Circadian rhythms.
Yeah.
There's so many questions. But I love this discussion that we've had today that actually started with, what is insomnia? How common is it across different psychiatric illnesses? Very common. How do we tease apart, is this a real case of insomnia? Does it meet DSM criteria? Can we address that as mental health clinicians? And then how do we screen for it? How do we measure it? How do we set goals around fixing it or improving it? Up to 80% response rate if we incorporate something like a CBTI
Amazing.
app. Isn't that incredible? And while we have medications that we use across psychiatry, sometimes have to use to reset, to calm mania, to create some hope while our medications are loading, that these are conversations we need to have about stop times when we start them, about expectations around dosing, and then also very much we all have sleep. We all have awakening times and times during the day where we're less awake and have to manage screens. All of this critical for sleep.
It is. It is. You talk about shift work. WHO classified nurses who were exposed to shift work as exposed to a level B carcinogen.
It's so damaging.
So I'd not heard that phrase. What's it called? Social sleep
Social
deficit?
jet lag.
Social jet lag.
Oof, I don't know what is happening. So it seems to me the way to sleep in the modern day world, sleep well in the modern day world, is to deny yourself the excesses of what the modern day world grants us. And it's hard to ask teenagers to not do it, but it's best they learn it now.
Yes.
And not suffer the consequences for the rest of their lives.
Setting them up for success.
Exactly.
And that starts when they're very young. And trying to shift some of those patterns when they are very young. Any parting words before we wrap up today, Phil? Our sleep expert, Rakesh.
Yes,
Great.
my goodness, we're so lucky.
I'll just say I really appreciate the conversation because, for so long in the mental health space, we've seen sleep as well. That's not something to pay attention to. And so I just appreciate how much things have come around, and now we're realizing, no, this is a major issue, and we need to do something about it.
Yes. How about you, Rakesh? Anything else you'd like to add?
I'm grateful to you for leading us in this conversation. I'm grateful to you for educating us. Sleep is not the acne problem of psychiatry. It's the primary reason why we are in the world of mental health.
Yes.
Good sleep is good mental health. Bad sleep is bad mental health. So even if you're not a sleep expert, which most of us aren't, guess what? This is your fight to engage in it.
Yes. Rakesh, Phil, thank you so very much for joining me in this discussion on sleep and best practices. And we look forward to more conversations with you both on this topic as we move across our time together. Thank you.
Thank you.
Thank you.
Good job.
Cut. Beautiful.
Wow. Wow, exactly like
I know I was
7 seconds left.
But-
Wow.
Should we stretch it out a little?